तो तुम्हा संकट अमुचे विलयाला जा
स्तवितो तुम्हा संकट अमुचे विलयाला जाओ
स्तवितो तुम्हा संकट अमुचे विलयाला जाओ हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय हे गजवदन वक्रतुंड महाकाय वक्रतुंड महाकाय वक्रतुंड महाकाय लंबोदर पीतांबर भैवर वंदना सरळ सोंड वक्रतुंड त्रिनयना रामाचा वाटपा हे सदना संकटी पावावे निर्वाणी रक्षावे सुरवर वंदना
देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव जय मंगलमूर्ती दर्शन मात्रे मन कामना पूर्ती जय देव 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 जय देव
Ladies and gentlemen, warm greetings from Utrecht, and I would like to thank to the organizers of this event for inviting me. It's a very important issue, of course, and we have been observing this for more than 40 years with several studies coming. I will not go 40 years back, of course, but I would like to remind a couple of studies from 20 years ago which showed that use of corticosteroids in septic shock showed significant effects on shock reversal, and this is a very consistent the result that we have seen in the last 20 years in many studies. But of course, if you look at the mortality, an earlier study of Anand has been showing us that low doses hydrocortisone and fludrocortisone were reducing the mortality in septic shock patients, but when the study was performed by Charlie Sprung and his colleagues a couple of years later, there was no difference in mortality by using corticosteroids or not. Again, both of these studies have shown a significant effect of corticosteroids in shock reversal. Then there were a number of systematic reviews being performed, coincidentally, mostly on the same year. And we see on the left-hand side the review performed by Jalali Anand, which shows that there was a beneficial drug effect when corticosteroids were used on short-term mortality, while in the same year, Sliegel and colleagues have shown no differences in mortality by using corticosteroids or not. We also again see here in both reviews that there was an improvement of shock reversal by using low-dose hydrocortisone. Another series of systematic reviews have followed this 6 years later, and again, one of them were showing reduced 28-day ICU and in-hospital mortality, while the other one did not show any effect at all on mortality when steroids were used versus placebo or no intervention. Again, very consistently, increased proportion of shock reversal was used by using of corticosteroids. An important study shows here actually that this was, of course, a retrospective study, but we see that although corticosteroids have shown no benefit, we see a benefit on let me see, we see the benefit especially on patients with an Apache score of 30 or higher. And this is actually an important finding because we see it maybe for the first time that there are some groups of patients who can benefit from the use of corticosteroids. There are two important studies performed and published recently. One of them is from Venkatesh, published in New England Journal of Medicine, and they were using hydrocortisone at a dose of 200 milligrams per day, and they actually have shown that this regime was not improving the survival of patients with septic shock. They have also shown that by using the hydrocorticosteroids, the median time to resolution of shock was lower, and to discharge from the ICU again was lower, and the mechanical ventilation, patients were less on mechanical ventilation, and they were receiving less blood transfusions. And when we look at the new onset of bacteremia and fungemia, there was no difference between the groups. As you know, we are very afraid of corticosteroids causing infection, but this was not shown in this study. And if you look at the adverse events, the corticosteroids group had significantly higher adverse events. But if we look at the numbers, we are talking about 3,700 patients. The numbers which are significant are something like 3 to 0 or 1 to 0. So even though statistically there is significance in adverse events, this was not shown in numbers. And if you actually go one step further, further, in the same journal, in the same issue, and if we had it in paperback, we would just be turning the page from 808 to 809. We would see the study of Annan, who also has used hydrocortisone plus fludrocortisone in septic shock patients, and you see the primary outcome that the survival was significantly higher in the group where hydrocortisone and fludrocortisone was used. Again, in this study, if we look at secondary outcomes, we see that the death from any cause at ICU, hospital, and at hospital discharge and at day 180 were significantly lower for the corticosteroids group. When we look at the vasopressor-free days and organ failure-free days, corticosteroids showed again a significant advantage. And when we look at the superinfection episodes by day 180, we did not see any groups, any differences between the two groups. As expected, the blood glucose levels were higher when corticosteroids were used. Now then, the question is, of course, how could it be that there are so much different results being achieved? And if we analyze the last two trials which I've been mentioning, the adrenal trial of Venkatesh and the approx trial of Annan, we cannot say too much about the severity of illness because they used different scores. But if you look at the sort of corticosteroids used, one used fludrocortisone and the other not, could this be the difference? However, we know it from Coit's study that the effects of fludrocortisone was not different from those of hydrocortisone alone. So this could also not be the pure reason. If you look at this slide, this is quite interesting, that there was an absolute value of 20% mortality between the two trial groups. So this could be a factor, even though the authors later of the adrenal trial were analyzing this. But we see that the group of patients are not identical with each other. We also see that the adrenal trial and the Aprocus trial had a different sort of patients. They were differing from renal replacement therapy, blood infections, pulmonary infections, etc. So it was not very comparable patient groups when we analyze these two trials. However, again, both trials showed improved resolution of shock and more rapid cessation of mechanical ventilation, which are quite important. And they all both showed low rates of serious adverse events, except hyperglycemia with corticosteroids. There were meta-analyses performed, two of them, including the results of these two trials. And actually, one of them concluded that no effect in short-term mortality was achieved by using it. And the other one has shown that there was a very small reduction in short-term mortality associated with use of corticosteroids, and again there was a rapid resolution of shock and shorter ICU stay. If we look at the Benzer study, he was using the vast randomized controlled trial data. They have shown actually that when they were identifying a certain threshold of cytokines in the blood, if in those patients where the blood cytokine levels were above the threshold, by using corticosteroids, you see it in the with the blue and red lines, using corticosteroids significantly increase the survival. Contrary to that, if the cytokines were below a certain threshold, the corticosteroids were increasing the mortality, again showing that we really need to define the group of patients with septic shock where we should use the corticosteroids or not. And this was actually, this is a paper in Press in Intensive Care Medicine where Venkatesh group, Jeremy Cohen, have analyzed the gene expressions and the relationship between the adrenocortical candidate and the clinical response to hydrocortisone. They could not identify a relation between the mortality, but they could show certain data for patients which would benefit in reversing shock with the use of corticosteroids. So this is an important beginning, at least, and we need more of these studies to identify the patient groups which would be benefiting from the use of corticosteroids in septic shock. And we also know that the Surviving Sepsis campaign has been giving a very pragmatic advice on this and recommending against the use of low-dose corticosteroids and starting with the fluid resuscitation and vasopressor therapy primarily. And if the hemodynamic instability persists, then it is suggested to use hydrocortisone. This is also shown in this diagram very well, where the position of corticosteroids are seen here, and it is very parallel to the advice of Surviving Sepsis campaign. If the shock persists, administer or consider giving hydrocortisone. In conclusion, ladies and gentlemen, we still receive controversial data concerning the effects of steroids on mortality in septic shock. Partly this controversy seems to be related to patient populations. And again, I would like to stress that we need to find the right patient population which would benefit from the use of corticosteroids. However, of course, the question will be use it or not. I think I would be sticking to my statement that if we do not reach our goals without corticosteroids, we should give them if fluid resuscitation and other measures fail, and we should not wait too long to give it. But we also know from a number of studies very consistent findings like improved shock reversal, quicker weaning from vasopressors, more ventilator-free days, and less transfusions and fluids. And these results achieve may be clinically a worthwhile goal to use corticosteroids. Thank you very much.
Thank you, Dr. Joseph, for a wonderful lecture. Now we move on to the next very important topic of antibiotic de-escalation by Professor Ian de Wel from Belgium. He has a special interest in antibiotics in critically ill patients. So let's hear from him.
Good morning, ladies and gentlemen. It is a true honor to contribute to this meeting. My name is Jan de Waele. I'm an intensivist working at the Ghent University Hospital. And my topic today is antibiotic de-escalation. So today I will briefly give an update on what de-escalation is, why we do it, as well as give you some practical advice that you can use in your ICUs and implement antimicrobial de-escalation. These are my disclosures, none of them in fact relevant for this particular topic. I think I'm not saying anything new if I'm saying that drug use and antimicrobial drug use in our ICUs is just way too high. Based on recent data, confirmed actually in a very recent point prevalence study published last year, a lot of our patients are receiving antimicrobials. Up to 70% of patients on one particular day in the ICUs are treated with antimicrobials. And the stunning thing is that lots of this is either inappropriate or suboptimal dose or even unnecessary. So definitely we need to do something about it. Now, the question, of course, is what are our options? What can we do? Antimicrobial use is quite a complex thing. And this is why antimicrobial stewardship programs were set up in many of our ICUs. This is a comprehensive strategy to improve antimicrobial therapy, both at the start of treatment, but also during therapy and at the end of therapy. And this is where de-escalation fits in perfectly. This is something that we should consider in the majority of the antimicrobial courses, if not all antimicrobial courses, and see how we can decrease antimicrobial exposure. So why do we do it? We do it because of the mantra, less is more. And indeed, one of the reasons you could be doing it is because you will see fewer side effects in patients in the ICU. There will be also lower costs. This is not going to be a huge saving, but definitely worth considering it. And finally, and this is the prime reason why we do this, is to reduce antimicrobial exposure and bring down antimicrobial resistance. This has been a concern in many, many countries. I think all countries are in some extent affected by antimicrobial resistance, and particularly in gram-negative organisms, of course, this is really a pressing issue. Let's first start with a description, kind of a definition of what de-escalation is. This is drawn from a consensus statement from 2019, because de-escalation is not just, for instance, decreasing the number of antimicrobials, but also narrowing the spectrum of one or more antimicrobials. So at a certain point in time, you will look at your empirical therapy, and you may want to stop antimicrobials that are not considered necessary because they are no longer needed. A certain pathogen that you may wanted to cover is actually not isolated from the samples you have obtained. But on the other hand, you may also want to decrease the spectrum of the antibiotic you are giving. So, for instance, going from a carbapenem to a narrower spectrum beta-lactam could be one example of de-escalation. What is not de-escalation is limiting the duration of therapy. So shortening therapy is, of course, important. You should not give antimicrobials too long if there is an infection, and you should not continue antimicrobials if no infection is there. But strictly speaking, stopping antimicrobial therapy in total is not considered antimicrobial de-escalation. It's very important to remind this. So there's been a lot of published a lot on this topic. Let's briefly take a look at a few of the studies that have investigated over the past years the topic of antimicrobial de-escalation. I do want to share some data from the Diana study. Some of you may have participated in this study. In total, more than almost 1,500 patients in over 150 centers have been investigated. In the study, we looked at empirical therapy. And although there was a huge opportunity for de-escalation, as you can see, 50% of the patients received combination therapy, a lot of broad spectrum antibiotics such as carbapenems, and many of these infections were microbiologically confirmed. So indeed, there was pathogens isolated by the microbiologist. Yet, much to our surprise, antimicrobial de-escalation was only performed in 1 out of 6 patients who were started on empirical broad spectrum therapy. So that is not enough. We need to do better, definitely. If you look at what exactly was done, in about half of the patients, combination therapy was discontinued, so from 2 to 1 drugs, and only 1 out of 3 patients, also the spectrum of the antimicrobial therapy was narrowed, and in a minority of patients, both strategies were used. So clearly a huge opportunity for improvement. This is an overview of a number of studies that have looked at de-escalation and looked at the outcome, looked at mortality. And as you can see, in many different types of infections, pulmonary infections, intra-abdominal, bloodstream infections, there doesn't seem to be an increased mortality. In meta-analysis, even a protective effect towards mortality was found, but probably this is caused by a bias, because it's probably the case that in observational studies, patients who were de-escalated were actually the one who were doing better. So bias studies, but clearly from this, it seems that de-escalation is safe. And this was also the conclusion from an ESICM estimate position paper that was published last year, where the committee felt that this strategy is likely safe. However, this committee also warned against the potential of increasing total duration of antimicrobial therapy. So this is definitely something to keep an eye on and make sure that duration of therapy is not increased in patients who are de-escalated. When de-escalation is used, it should be done as soon as possible, within 24 hours. And the committee also recommended the de-escalation for all bacterial pathogens, except for difficult to treat pathogens in patients with a high risk of death. But in the bulk of the infections that we are treating, yes, de-escalation is possible. Finally, the suggestion is also made to de-escalate in patients who are diagnosed with neutropenia, and de-escalation should be applied independent of the source of the infection. So clearly a broadly applicable concept. In the remainder of my talk, I would like to give you a practical approach on how to de-escalate, how to implement de-escalation in your units. And this is my 5-step strategy on how to make sure that not only you, but also your colleagues, of course, start de-escalating. Now, the first and foremost thing is, of course, to definition and agree on what antimicrobials that you want to target most. If you work in an ICU, where it's very common to start 3 or 4 antimicrobials in all patients who are admitted with sepsis or septic shock, then yes, of course, you have a huge potential. And this may be very specific for each hospital. But one of the big challenges is classifying these antimicrobials. And I'm giving you a number of solutions. This comes from a French consensus statement. A Delphi procedure was done to rank beta-lactam antimicrobials. And you can see going from rank 1 to 6, from low to higher classes, that indeed carbapenems are scored the highest. Amoxicillin was the lowest on this classification. Of course, this is only for beta-lactam antimicrobials, and there's also a disadvantage of not considering any newly introduced antimicrobials. So another attempt was done by these investigators, trying to develop a spectrum score for each individual antimicrobial regimen. So based on the antimicrobial spectrum, each antibiotic got a score, and when you go from a higher score to a lower score, you're effectively de-escalating. So this is more a microbiological approach to the problem. Lots of antimicrobials, of course. The question is how practically implementable this is, of course, and this is why I like this last option I want to share with you, where actually antibiotics were ranked in 4 different classes: narrow spectrum, broad spectrum, extended spectrum, and protected antimicrobials. And this is something that you can easily adopt to your own situation, whether you live in an area with a lot of multi-drug resistance, requiring a lot of what would be protected antimicrobials in this category, in this slide. This will allow you to adapt this to your own situation and agree beforehand. So that is my message here. Try to look at your own prescription practices, discuss with your microbiologist and your infectiologist what your primary targets would be, and then look at your formulary, what do you have, and agree on certain changes before actually implementing it at the bedside. So trying to identify what do we use a lot of and what would we like to see less use of. So the second step is, of course, making sure that you have all the information there, because that is a challenge. It doesn't just come to you. You need to make sure that you have the information required to de-escalate. The first step is, of course, confirming a diagnosis. You need to have a diagnosis of an infection and confirm that an infection is present. Pathogens and susceptibility are the next two things that you would need to effectively de-escalate. So that doesn't mean that de-escalation is not possible if you don't have a pathogen identified, but it will certainly help you to safely de-escalate. Do remember that, of course, time is an issue here. I think it's of little use that you de-escalate after 4 or 5 days. Try to do it as soon as possible and earlier if possible. And if you indeed have, for instance, availability of these rapid diagnostics that, as you can see here, that compared to conventional culturing would reduce with MALDI-TOF or with the PCR-based techniques, the diagnostic, the time to diagnosis and identification to a few hours, then it will even more rapidly allow you to de-escalate. Communication is a simple and not very expensive thing. Communication between the team, in your antimicrobial stewardship team, discuss this with your microbiologist, and do keep, of course, these regular meetings where you discuss antimicrobial choices and look at opportunities to de-escalate. My fourth recommendation is to maximize de-escalation. So going back to my example, if you have a patient who was started on 3 antimicrobials and a omni-susceptible E. coli, for instance, is the cause of the infection, make sure to maximize it. So this means drop all the antibiotics you don't need. So no antifungals, no anti-MRSA treatment for this particular patient, but also for the backbone antimicrobial that you want to continue, look if there's no opportunities to also narrow the spectrum there. So try to do both things, both narrowing the spectrum and decreasing the number of drugs. And finally, and this is a very important one, predefine the duration and keep counting the days that the treatment should take. So when a patient is de-escalated after 3 days of a broad spectrum therapy, and you intend to give a total duration of 7 days, then the de-escalated antimicrobial should be continued for 4 days and not for 7 days. And this is a mistake people commonly make. They forget about what the patient received before the narrower spectrum of therapy. Before I come to my conclusions, I want to share 3 common pitfalls of de-escalation. Make sure that you are not using de-escalation as an excuse to give multiple unnecessary antibiotics to every patient that comes to the ICU, claiming, I will de-escalate later. This is not a good strategy. Your empiric choices should be based on your local guidelines, your national or international guidelines. And if that means it is only one narrow spectrum antibiotic, well, there's no harm in that. Also de-escalate in case you have no conclusive macrobiology. If you are, for instance, covering MRSA, but the cultures come back inconclusive, well, probably there's no MRSA there, and you can drop this antimicrobial. And finally, as I mentioned, but it's very important to emphasize this, keep counting and make sure not to prolong antimicrobial therapy. So in all, this is my suggested 5-step approach. Agree on a definition, make sure you collect information, communicate with the lab. If you have everything, try to maximize the escalation, and also at that moment, predefine the duration of therapy and note it down. So in conclusion, ladies and gentlemen, I hope to have convinced you that antimicrobial de-escalation is something we should consider in each and every antimicrobial therapy. It is safe and it does reduce antimicrobial exposure. Look at the opportunities in your own unit, and again, every course should be evaluated for de-escalation. Make sure you have the information you will need. Sample your patients. You will need it 2 or 3 days later, and talk to your friends in the microbiology. When you de-escalate, do it early. Do it as early as possible. Once you have the information, just do it. But especially make sure not to prolong antimicrobial therapy when you are de-escalating. So with this, I would like to thank you for your attention. It was great participating in this meeting. Thank you and bye-bye.
Thank you, Dr. Yan, for a wonderful and simplified approach towards the sepsis, toward the antibiotic de-escalation. Now let's move on to the present scenario of pandemic, COVID-19, which we all are going through. Let's hear from Professor Ignacio Martin Loches from Ireland about COVID. Is it sepsis? Over to you, sir.
Hi, hello. My name is Ignacio Martin Loeches, and I am a professor in intensive care medicine working in Dublin, Ireland. So in the next 15 minutes, I'm going to discuss with you if COVID is it. And I think that when we are starting, I think that probably when we are talking about if it's sepsis or not, we are always thinking about the scoring. So I'm going just to put an example of a patient with community-acquired pneumonia. It doesn't need to be a person with COVID, and you look at the patient has a respiratory rate of 24, a blood pressure borderline, so slightly elevated issues with a renal failure, and the patient is conscious and oriented. And you look at the two scoring systems that they are majorly developed in patients with pneumonia, and you see that if the patient is with based on the quick SOFA, is going to be more than one, so the mortality is going to be quite low. But if we apply the course 65, we are going to have a different number. So this is something that when we are talking about if a disease is sepsis or not, I think that we should not be confused about the issue of scoring. And I'm going just to take again another example with community-acquired pneumonia, nothing to be related to COVID. This is a study published in the Blue Journal in 2017 in patients with CAP, and you look at a good number of patients that they were, some of them included in ICU with a mortality around roughly 20%. So when we look at the different scoring systems, you see that, for instance, there is a good sensitivity in SIRS and PSI, whether there is a good specificity with CORP both. So we can maybe say that if a patient is coming with a pneumonia, community-acquired pneumonia, we are going to maybe have an initial assessment with a SIRS and then further assessment with a PSI. So again, this is not COVID, but I think that this could illustrate how respiratory failure could play in this story. So when we look at COVID, if we are thinking that this is a sepsis or not, we see that this is a study, a retrospective study, including patients that they were assessed for different scoring system, and you see that one score that is not very well known, like the 8-drop score, was the one that was performing the best. And surprisingly, the quick SOFA again was the one that had the lower area under CORP. So when we go again to a disease such a community-acquired pneumonia, again not COVID, we see that patients that they are developing shock or they need invasive mechanical ventilation are going to have a much higher mortality. So then the story is it sepsis? If we have a patient having COVID, is it going to be sepsis? Could this be sepsis, as we have seen in different vignettes? And you see that many of the patients that we have been looking after, they do have many features that they are going to be compatible with this. So another interesting story is the cytokine storm. We know that sepsis is a complex combination of various dysregulated immune system mechanisms. The cytokine storm occurs in the early phases, maybe probably the hours in the disease of sepsis, where there are different cells and molecules like PAMs, PRRs, and innate immune systems that they are going to develop this hyper-inflammatory innate response. And I think that, you know, in patients with COVID, as it happened with influenza, was the first infectious disease where the cytokine storm was characterized. That happened back in the years 2000. So we can see that there are some pro-inflammatory cytokines like TNF, interferon regulator factor, other like NF-kappa B, that they are going to be elevated. So this is a first meta-analysis that was pretty much getting patients from China, and you can see that there is a higher expression of cytokines in patients with COVID. So more recently, there is a difference in patients with ARDS or sepsis. The problem of this study is that the number of patients is quite limited. You can see that patients with ARDS were only 12, sepsis 16, and only 9 were 15 patients were COVID-19. And as you can see, there were no differences whatsoever with common cytokines that we are taking into account. However, I would like to bring this manuscript, that is a manuscript that was published in Lancet Respiratory Medicine by the group of Clifford Dishman in the US. And when you look about different syndromes that we could say, for instance, severe COVID, critical care COVID, or all COVID, as it is in the literature, we see that the interleukin-6 levels, they were quite low compared to patients that they were flagged as sepsis or cytokine response syndrome. So this type of CRS syndrome. So, and I think that this brings something into account that I think that is quite interesting. So, which is the mechanism? So we are going to go now a little bit further in the physiopathology of COVID-19 and also sepsis. So this is a manuscript, a review paper that has been published with my group, and is trying to illustrate the netosis in the lung. We know that SARS-CoV virus is going to invade alveolar epithelial cells, are going to activate them with local macrophage populations. This could cause a surge in the production and systemic release of cytokines and chemokines, that well-known the cytokine storm that we were discussing some minutes before, with some subsequent neutrophil recruitment. So we can see that in as a common ground, we have an activated endothelial cells exocytose von Willebrand factor. So it's part of this immunothrombosis, this mechanism that is going to happen that will allow neutrophil and neutrophil extracellular trap in the vascular wall. So this is going to develop with IL-6 the famous term of netosis. Netosis is nothing more than this term that is going to create a negative feedback that is going to be innervated and is going to allow other cytokines to create and reduce some expression of other cytokines, such as interleukins 33, and as you can see in this cartoon. So the complement is also released from the nets. So we are talking about these traps, these kind of traps that they are going to be released by neutrophils, that is going to develop even more netosis. So allowing this opsonization of surrounding tissue, this ultimately will create necrosis. So as you can see, this is a good example how there is a local phenomena that is going to happen in the lung. So this is going to an increase of activation and proliferation and migration of immune cells. So as a major event, and ultimately the cell death caused by microbes as well as the host inflammation response is going to auto-amplify the cytokine response and to initiate a cascade of immune cell chemoactivation by the innate system. So as you can see in this cartoon, also we have to consider, taking into account, as I said in the previous slide, that it can happen, this cytokine release syndrome. So this intracellular inflammatory upregulation combined with downregulation of cytokine release checkpoints is well described in COVID-19. So I think that this is the common ground of the problem. So more recently, we have also published this paper in Intensive Care Medicine, where the first author is James O'Donnell. And we try to also illustrate a little bit the physiopathology of this entity, because we know that in COVID, there is this phenomena called pulmonary immunothrombosis that plays a major role in the pathophysiology of COVID-19. So we see that in COVID-19, we are going to have this entry into the airway epithelial cells, as I mentioned before, with ACE2 receptors. And that plays a role when we were talking in the beginning of the pandemic of this deleterious effect that might have associated in some patients that they were taking ACE inhibitors. That was, of course, discovered that was far from the reality. This is going to be accompanied by local cytokine and chemokines generation, leading to elevated systemic levels of cytokines, as I said before, and I showed before, TNF, IL-1, IL-6, and IL-8. As you can see in this cartoon, this is, the pathogenesis in COVID-19 with this pulmonary immunothrombosis and endotheliopathy. So, as you can see, when we are talking about this sepsis, pathophysiology, we can see that it's like a very local activation of vascular damage in the lung. We know that patients with infected with virus, with SARS-CoV-2 virus, is going to activate monocyte and platelets, and they are going to also create degranulation of neutrophils. Then the virus is going to activate and gain entry into the endothelial cells, pretty much in the lung, but in many other organs. And in severe COVID, I think that this activation is going to be further activated by pro-inflammatory cytokines. So as you can see, there is a good evidence that there is an increase in the pathways of thrombosis in patients. And as I mentioned in the previous slide, this is going to lead to netosis, that is going to lead to coagulation cascade activation, and then these phenomena of hypoxemia in patients with COVID-19. I think that the net effect of this regulated immunothrombosis is the generation of platelet and fibrin-rich thrombi and pulmonary vaso-occlusion. So the other thing that I consider that is quite interesting, if I'm trying to understand better the physiopathology of COVID-19, is that it's not just a problem in the lung. We have seen in this very nice review paper that COVID-19 is going to develop issues in different organs by different mechanisms. As you can see on the left-hand side in the pathophysiology, is not just the issue of inflammation and cytokine storm, as it's been described before, but also the vasculitis and the hypotension. And then we have seen in some patients some interesting phenomena, such as elevated level of D-dimers, troponin, IL-6 inflammation, and then we have this lymphopenia with the potential, however not very frequent, intravascular coagulopathy, as DIC, as it happens in sepsis, with the additional problem of heart failure that we have seen in patients that they have been developing myocarditis. So I think that probably when we are looking at COVID-19, we can see that the patient with severe COVID is going to develop that we call a generalized infection is going to develop a organic dysfunction that is going to be released by arrhythmias, acute coronary syndrome, phenomena of thrombosis, and finally injury, biomarkers of injury, as we have discussed with patients with immunothrombosis. So finally, I think that the severity, when we are looking at an entity such as community-acquired pneumonia, and we look at scores such as the core 65, is going to take into account the type of organ failure that the patient is developing. So in case of core 65, confusion, urea, blood pressure, and others. So pneumonia, and I would say that, for instance, is the same example with COVID-19, is not an infection localized in the lungs, is systemic disease. So the summary for me is that COVID-19 is sepsis. The body has a dysregulated immune response to the coronavirus, which is going to cause life-threatening dysfunction in organs, lungs, brain, kidneys, heart, liver, etc. So I think that this
Thank you, Dr. Ignacio, for a wonderful talk and letting us know the very practical approach of COVID-19. Uh, I have a request for all the delegates. As this is a keynote lecture sessions, there will be no question answer session in this. We request you to post your questions, if any, on the chat box by the format given. We will answer, we will forward these questions to the respective faculties, and will try to rectify all the all your queries. Let's move on to the with the same COVID scenario. I welcome Dr. Amit Mandal, who is from Chandigarh, working as an director of pulmonology in Med Center. Uh, he will he will have a word on cytokine storm and role of immune modulators in COVID. Over to you, sir.
Good morning, everybody. Thank you, Sepsiscon, and the entire organizing team for this wonderful invite. And amongst the stalwarts, I hope I'm able to do justice to this talk, cytokine storm and the role of immunomodulators. This is the imagery that I've taken from the review article in 2012, which talks about the effect of viral infection and the cause of the development of the cytokine storm and the organ effects. And this is how I would probably go through over the next 15 minutes in trying to deliver the talk. To this August audience, the host response to sepsis is probably not unknown. The pathogens get recognized by the pathogen recognition receptors, which gets on to initiate the inflammatory response, which is so important for us to not only protect ourselves, but also to, bring about the repair mechanisms in place. It's only when this so-called immune response becomes dysregulated does it cause the so-called cytokine storm and lead to organ damage. It's the homeostasis between this pro-inflammatory response, which is primarily to give us the protective immunity by initiating the localized immune response. Only when it becomes the exaggerated does it get cause more organ damage with the activation of the endothelial system, the coagulation profile, coagulation system, and so on and so forth. And it's the homeostasis that we want to achieve somewhere down. The anti-inflammatory mechanisms are primarily to bring about the local repair mechanisms. Again, when if dysregulated, can not only prolong the hospital stay, but bring about organ dysfunctions, secondary infections, and alter the morbidity and the mortality. And it is the homeostasis between these two responses is something that we are looking for that elusive model. The cytokine storm has been known to us first picked up as in the experimental models of hyperinflammation, and it was talked about with the graft versus host disease primarily. But in the last couple of years, we've noticed more often with the viral infections and the organ damage that we've had. Now, today, we know that both infections and non-infection causes could lead to the development of cytokine storm and the inflammatory damage that we get to see. We've seen immune-mediated cytokine storm damage leading to end organ effects, and particularly in dengue over the last few years of time. And this was a paper that I picked up, published by Bharat Bhushan et al. in 2018 in Neurology India, when it looks upon the dengue-related immune-mediated neurological complications and whether immunomodulation could alter the outcome in these patients. And here they used methylprednisolone or IVIG or plasmapheresis as immunomodulator therapies, and they did conclude that if initiated appropriately, they did have favorable outcomes. Cytokine storm is well known with influenza and the organ defects, particularly with the ARDS lung damage that we have seen over the last decade or so. Immune response to the fungal infections, Candida and Aspergillus, is also not unknown. They do stimulate the toll-like receptors and leading onto the production of pro-inflammatory cytokines like TNF alpha, IL-6, IL-12, which goes on to cause organ damage, to a point that of late, there's a lot of activity happening around the CD8 T cells because these are the cells which are responsible for not only the killing of yeast-infected host cells, also the generation or production of high levels of interferon gamma as well as TNF alpha. Also, the immune suppression promotion interleukins like interleukin 4 and interleukin 10, and to an extent that these have been the choice of the fungal vaccine candidates in the animal model as of now so far, and maybe we'll see more action in times to come. So bring across to the pharmacological or the different methodologies that we could probably be using for immunomodulation. Steroids have been in use for quite some time and has a lot of been focus of debate. We understand that the action of steroids could be because of glucocorticoid action as well as the mineralocorticoid portion. And it's the mineralocorticoid which actually has been proven to bring about the hemodynamic response in the most severe subset of septic patients. Looking at across the clinical practice guidelines published in 2018 on BMJ as to which populations, both adults and children, could probably be suffering from either intra-abdominal infections or pneumonia, could be the ideal patients for this sort of therapy, in particularly severely ill patients or patients with shock. Try and avoid use in pregnant patients, in neonates, and in patients with pre-existing adrenal insufficiency, or if there's a non-infectious cause of a shock. The recommendation, though weak, is towards the use of corticosteroids along with usual therapy. One has to be mindful because this is primarily because of the fact that there is some mortality benefit as well as a reduction in the length of stay and hospitals, though these have not been statistically been proven, but these favor these corticosteroids favor these outcomes. One also has to be mindful of the fact of the neuromuscular weaknesses that can happen in the patient with steroids. Also, the fact that hyperglycemia, electrolyte imbalances are something which are key practical issues that need to be looked into. A discussion should happen with the patient's family as well as the patient, because there are a lot of patients who probably avoid functional deterioration in an effort to maximize the quality of life and not just avoid death. And we should also be mindful of the fact that the greatest reduction happens or the greatest benefit happens in patients who have probably the greatest risk of death. When it comes to the choice of corticosteroids, when you look across the meta-analysis, this was in 2017, when they look across all the different steroids in the different formulation that it may have been used, none of them have had any clear evidence of being better or superior than the other in terms of reduction of mortality or the side effects of GI bleeding or super infections. And it is hydrocortisone, whether in the infusion or whether in the bolus form, has been universally picked up as the drug responsible for leading to shock reversible. Metabolic resuscitation protocol is something that there's a lot of hue and cry debate over its use and not to be used. Paul Marick and group did use this combination protocol of vitamin C, hydrocortisone, and thiamine in their group of patients, and they published it in 2017 as a retrospective before and after study. And they did suggest that they did have a significant reduction in the hospital mortality, the use of duration of vasopressors, the need for renal replacement, and the organ dysfunction scores. And they suggested that this could probably be a benefit in such severely ill patients. The consensus from the contrary group was that it is only a hypothesis generating study and probably needed more external validation, which did come in 2019 as a negative study as vitamins. This was done across 10 different ICUs in Australia, New Zealand, and Brazil. And they compared the use of vitamin C, hydrocortisone, and thiamine versus hydrocortisone alone. And the conclusion was that there was no difference between the two groups, and intravenous hydrocortisone alone was probably as good as the protocol, the metabolic protocol proposed by Dr. Marik. Ulanastatin is a series protease inhibitor, which is capable of reducing the levels of TNF-alpha and IL-6. It also suppresses the activity of neutrophil elastase and prevents the incidence of DIC as well as organ dysfunction and leading on to multi-organ dysfunction, and somewhere down probably causing a benefit in mortality. One of the, I picked up this RCT from conducted in India by Dr. Karnada and Dr. Daga across 7 different tertiary care ICUs across the country, where they used ulanastatin to the dose of 2 lakh units 12th for 5 days and compared it with placebo along with antibiotics and standard care. And they did see a significant reduction in 28-day mortality, in reduction in the new onset of organ dysfunction, as well as ventilator-free days and shorter hospital stay. The meta-analysis published in 2019 in ARDS patients suggested a statistical improvement in terms of the PF ratios or the oxygenation index in the reduction of the cytokine levels, but not favoring a better, but not statistically significant in reduction of ventilator days, length of stay in the ICU and the hospital, and some reduction in mortality. When compared with ARDS and severe sepsis, against the same key findings of decreased cytokines, improving oxygen PF ratios, but no significant mortality benefit that was picked up in across all the different trials that have been done. Sepsivac, also called as the Mycobacterium becky or Mycobacterium indicus prani, is a saprophytic non-pathogenic strain of Mycobacterium, and this has been in use recently in terms of because of the fact of its action of potent inducer of Th1 response, also by blocking the toll-like receptor 4 activity. It does cause a reduction in the cytokine levels of nitric oxide, interleukins, and tumor necrosis factor. And the RCT that was published in 2014 from our very own city at Chandigarh, PGI, where this was done in patients with severe sepsis, looking across primarily the 28-day all-cause mortality and the secondary outcomes. They did suggest a reduction in the hospital and the ICU length of stay, use of vasopressors, secondary infection rate, and improvement in the SOFA score in the treatment arm. They went on to publish this year early, and this was a RCT done over 5 tertiary care ICUs in the country, and they looked at again similar 28-day all-cause mortality and the secondary outcomes. And they, in these presumed gram-negative sepsis, they had encountered pneumonia and urosepsis as the predominant in final diagnosis, and the organisms that they picked up was E. coli and Klebsiella as the main organisms, and they did suggest that there was a significant reduction in mortality when used the severe presumed gram-negative septic set of patients. Bringing on to moving on to the extracorporeal therapy, there have been many extracorporeal therapies which have been used in an effort to, as probably an immunomodulator somewhere down, but there are non-selective uses and selective with toromyxin. It's predominantly the absorption, hemabsorption methodology which has been used, and there are many in vogue in the country today, toromyxin, cytazorb, and oxidase, which looks at clearing of the endotoxin or the cytokine levels. So looking at the various studies, looking at the effectiveness and the limitations of polymyxin B immobilized therapies, the Japanese registry, the findings that they got with Japanese registry with a significant mortality benefit was unfortunately not being able to duplicate it with any of the UFA studies or in the European pilot study that has been done so far. And it does, the bottom line is that in the patients with high endotoxin levels, it does cause significant hemodynamic stability. When it comes to cytazorb use the study in 2017 by Shadler was the only one which suggested some mortality benefit. The common key finding that I've been coming across is the reduction in the IL-6 levels across all the different studies, and that's the only common finding. Where it may be beneficial with less amount of side effects of its use, it has its own pitfalls in the development of thrombosis, bloodstream infections, hypothermia, major risks of bleeding, risk of underdosing of antibiotics and treatment failure, significant amount of electrolyte imbalances, fluid shifts, and nutritional loss. And in a country like ours, where most of us out-of-pocket therapy, a high cost of therapy precludes the use of such therapies, and no therapy till date has been found which can conquer all stages of inflammation and reduce the so-called dysregulated host response to infection. Thymosin alpha is an acidic polypeptide which is derived from the purified version of thymosin fraction 5, and it does stimulate the interferon gamma secretion and enhances the T cell function. And it has been approved in Asia and South America for use of chronic hepatitis B and C as a vaccine enhancer. So to kind of conclude, inflammation in relation to sepsis is something as a necessary evil which we have to live with. It does cause the release of the inflammatory cytokines which work as activators for both the innate as well as the adaptive immune systems, and both are crucial and essential for survival. It's only when this response becomes dysregulated, which is primarily the hallmark of sepsis, which is not only biological complex and which becomes a huge challenge to treat. No immunomodulator has been proven to deal with the inflammatory response syndrome in totality in sepsis, and primarily because that we've had single multiple target-oriented approaches and employed for the treatment of cytokine storm in sepsis, and that's why we've not had any similar common benefits that we've seen across all different studies. The extracorporeal therapy, though may appear safe and timely targeted compared with the longer-lasting pharmacological therapies, but yet the similar effects of mortality benefit or similar benefits has not been duplicated in most of the studies together. So as far as the magic bullet or the magic immunomodulator still remains elusive, and probably we'll have to pick and choose and decide which suits best to our patients. There could be an opportunity where one could use multiple modalities of therapies for better outcomes. So with that, I end this talk, and I hope I have finished on time. Thank you so much for the opportunity. Thank you.
Thank you, Dr. Amit, for a nice and elaborate view on the role of immunomodulators. Now we have done with keynote lectures. Let's move on to the next section of sepsis therapeutics. In that section, I welcome Dr. Ashit Hegde, who is a consultant in medicine and critical care at PD Hindujay Hospital, with a special interest in ICU infections, fluids, and electrolytes. Let's hear from him about sepsis-associated macrophage activation syndrome and how to treat it. Over to you, sir.
How to treat the sepsis-associated macrophage activation syndrome? Well, most of our knowledge about this syndrome derives from the pediatric literature about hemophagocytic lymphohistiocytosis, also called HLH in short, which, as we all know, could be primary, usually due to genetic defect, or secondary, usually following infections, connectivity disorders, or malignancies. And these were the 2004 HLH criteria laid down for the diagnosis of secondary HLH in children. IL-1 beta seems to be a key player in the pathogenesis of this macrophage activation syndrome, be it in adults or in children. And high levels of IL-1B act upon the natural killer cells, causing a cytokine storm. They act on the Kupffer cells in the liver, contributing to hyperinflammation, and overall cause increase in the levels of interferon gamma, leading to hemophagocytosis. Now, whereas the 2004 score was for pediatrics, it was felt that there is a need to have a separate diagnosis for the adults. So therefore, the HS score was derived recently, and this contains 9 variables. And a score could range from 0 to 317, and a value of greater than 169 provides the best cutoff in terms of sensitivity and specificity. Now, using these criteria, a certain percentage of patients admitted to the ICU would be diagnosed with the macrophage activation syndrome in adults, but most of these patients would probably be MA secondary to either malignancy or a viral infection or a connective tissue disorder. But there probably exists a small subgroup of patients admitted with classic bacterial sepsis who have features of hyperinflammation, who have features of activation of cytokines or cytokine storm, a lot of features akin to the classic macrophage activation syndrome. To test this hypothesis, therefore, that there is a group of patients with classic bacterial sepsis who have features of the macrophage activation syndrome, this Hellenic sepsis study studied 2 cohorts of patients. They defined the macrophage activation syndrome using the BS score, but since the bone marrow is not done usually in patients admitted with bacterial sepsis, they did not use this in the diagnostic criteria, and therefore they decreased the cutoff point from 169 to 151. So they used the other 8 criteria, but they did use the bone marrow and decreased the cutoff point. In addition, they also said the patient could have macrophage activation syndrome if he had features of hepatobiliary dysfunction and DIC as given by these diagnostic criteria. And because the bone marrow was not done, they didn't call this macrophage activation syndrome. They called it the macrophage activation-like syndrome, or MALS in short. So using these diagnoses for MALS, they found that in a cohort of roughly 3,500 patients, about 4% of patients had the criteria, they fit this criteria of macrophage activation-like syndrome in patients with bacterial sepsis. And this group definitely had a higher 10-day mortality as compared to the controls, or the patients did not have features of the macrophage activation syndrome, and this was statistically significant. In addition, what they found that a ferritin level of about 4,200 clearly demarcated pretty well the patients who had macrophage activation syndrome versus those who did not have it. Also, they found that if the ferritin levels did not decline over time, this was usually associated with poorer outcomes than in patients in whom the ferritin levels declined over time. So that was how basically, so therefore, there clearly is a group of patients who have features of the macrophage activated like syndrome in patients with bacterial sepsis. Now, how do we treat such patients, which is the talk for today? And the 2019 article in Blood talked us about the recommendations for the management of HLH in adults. These were the standard recommendations and usually indicate a combination of dexamethasone, etoposide, cyclosporin, and intrathecal therapy for patients who have CNS problems. And this is the therapy that they recommend for usual HLH, irrespective of the etiology. But in the same article, they also mentioned that you need to probably, for individualized treatment, depending upon the patient's, the cause of the HLH. And they mentioned a bit about HLH in the ICU. And there they mentioned that for the deteriorating or unstable patient, you should probably use cyclosporin plus minus IVIG. And of course, maybe steroids, maybe etoposide. Now, until recently, there's very little literature about the management of HLH associated with bacterial sepsis. Most people tend to use the standard treatment for HLH, and they use a combination of IVIG, steroids, etoposide, cyclosporin. There really is no consensus about the management, and most studies which have looked at the outcomes of these treatments have not been very positive. So still a little bit of clarity is required. Now, given that IL-1 beta is a key player in the pathogenesis of sepsis-associated macrophage activation syndrome, it would stand to reason that using an antagonist of the IL-1 receptor might be beneficial. But this study done in 1997, which looked at, of course, IL-1 receptor antagonists in all patients with sepsis, irrespective, they were not further classified. All patients with sepsis were looked at, and this study showed that basically in patients with severe sepsis, as by those definitions, IL-1 receptor antagonists did not show any benefit. But then Shakuri and his colleagues in 2016 had a relook at this paper. They reanalyzed this paper, which was probably 1997, and they looked at the 763 patients that were studied in this original cohort. And they noted, by going retrospectively, that, and they use a definition of hepatobiliary dysfunction with DIC, they use this as a criteria for diagnosing macrophage activation syndrome. And they found that by going by this criteria, 43 patients had features of the macrophage activation syndrome. And whereas the 28-day survival is similar in patients who are treated with anakinra or placebo. Anakinra is IL-1 antagonist, when patients did not have macrophage activation syndrome. But if the patient had the macrophage activation syndrome and was treated with anakinra, the mortality was much lower, only 35%, whereas those who treated with placebo where the mortality was 65%. Therefore, they concluded that IL-1 receptor blockade was associated with a significant improvement in survival in patients with sepsis who also had concurrent hepatobiliary dysfunction and DIC as a marker of the macrophage activation syndrome. And they recommend that a prospective randomized trial using these features, any diagnostic criteria for macrophage activation syndrome should be undertaken to confirm the role of IL-1 blockage. And this is exactly what this interesting study called the PROVIDE study is doing. They have classified patients with severe sepsis, usually bacterial sepsis, and by the current definition of sepsis 3. And, they have divided them into, these are patients with septic shock actually. And they're, depending upon the ferritin levels and the patient and the CD14 levels, they're divided into two groups. The ones who had a high ferritin, they were classified as having features of the macrophage activation syndrome. In the ones who do not have a high ferritin levels and have a higher CD14, and depending on the CD14 levels, they were classified as patients having sepsis-induced immunosuppression. And depending upon which group they belong to, they either got anakinra and IL-1 antagonist, or they got interferon gamma, which boosts their immunity. The results are not yet out, and they'll be very interesting to see whether this theory really of individualized therapy for sepsis really works. The results are expected anytime soon. Therefore, to conclude, up to 5% of patients with severe bacterial sepsis may have features of the macrophage activation-like syndrome. The diagnosis depends upon the HS score, about roughly 151 if you're not doing a bone marrow. You can also use the presence of hepatobiliary dysfunction and DIC to diagnose macrophage activation syndrome. Ferritin levels above 4,200 are pretty specific and sensitive for the diagnosis of this syndrome in septic patients. And at the moment, though, people have tried IVIGs, corticosteroids, cyclosporin, etoposide, etc. for this treatment. Anakinra is probably the most promising treatment, but it's not yet validated. Thank you.
Thank you, Ashit sir. Let's move on to the next topic. We all know approximately 7 to 10% patients who are critically ill will develop refractory shock, and with the short-term mortality exceeding 50%. I welcome Dr. Ashish Khanna from USA for a talk on vasopressor strategies in refractory shock. Over to you.
Hello, and thank you to the organizers of Sepsiscon. I'm happy to talk to you all today about vasopressor strategies in refractory septic shock. These are some of my disclosures. So the problem with refractory septic or refractory vasodilatory shock is that once we are on very high dose norepinephrine and norepinephrine equivalents of vasopressor drugs, our 30-day and 90-day mortality or overall patient outcomes are very poor. So this work by Samuel Brown and colleagues really set the stage for this. We always knew this, but this work clearly proved that once we're on high-dose norepinephrine, here being about 1 microgram per kilo per minute, 30-day and 90-day all-cause mortality is upwards of 50 or 80%. And really, even in patients who survive, the short and long-term sequelae of intense peripheral vasoconstriction and vascular injury, for example, to fingertips here, is significant and leads to a loss of quality of life. Vasodilatory shock that's refractory also leads to an intense catecholamine surge and or exogenous catecholamine administration that often leads to stress-induced cardiomyopathy, known as Takotsubo's cardiomyopathy, named after the Takotsubo or the Japanese octopus trap, very commonly seen in the ICUs, hydroponin for no other reason, patient with septic shock, and on high-dose catecholamines. So refractory vasodilatory shock really, if you look at the molecular profile of it, the center point is really membrane hyperpolarization, cellular relaxation, and intense vasorelaxation that leads to impaired responsiveness to catecholamines. Obviously, behind all of that is altered microcirculatory flow and intense endothelial dysfunction as well. And all of that combined leads to this bad combination where no amount of catecholamine is then going to work on this patient. So in terms of pressors, we do know that our general armamentarium is catecholamine, so norepinephrine, epinephrine, dopamine, and phenylephrine as sort of derived catecholamines and weaker pressors, and then vasopressin, much stronger pressor. But again, the overall actions and the pharmacology is more or less evident to this audience. I just bring up this slide to show you all what we have available mostly and we use in our ICUs to take care of septic shock. Our overall blood pressure targets are still determined to be about a MAP of 65 to which we're titrating our pressors, not necessarily to say a MAP of 65 doesn't prevent organ system injury in ICU patients. However, the surviving sepsis guidelines sort of give us these broad strokes of fluids followed by norepinephrine, followed by epinephrine or vasopressin, and then dobutamine in case of pump failure. In terms of evolution of these pressors, we know that dopamine and norepinephrine have been looked at in head-to-head work, and really Daniel DeBacker showed in this work published in the New England Journal 10 years ago that dopamine led to more arrhythmias, dopamine led to poorer survival in patients with cardiogenic shock, and no different survival in patients with septic shock. So the dopamine to norepinephrine balance tilted towards norepinephrine. Norepinephrine still remains our go-to first-line drug in septic shock. Vasopressin, norepinephrine sort of come together, and they've been looked at in various head-to-head trials, none of which has really shown a mortality or survival benefit. Here's the well-known VAS trial, where patients were given vasopressin or norepinephrine after an initial resuscitative dose of norepinephrine. And then the VANISH trial, Tony Gordon published this in JAMA about 5 years ago. No difference in renal outcomes of any sorts in a 2x2 factorial design where placebo and steroids were combined on each arm of vasopressin and norepinephrine, and no difference in survival as well, although some difference in terms of less use of renal replacement therapy in vasopressin. Vasopressin is a good drug. It does lead to catecholamine sparing. This is retrospective work that has shown that only about 50% patients respond to vasopressin, but those who do, it does lead to catecholamine sparing, improved MAP, and decrease in lactate concentration over time, although the mixed venous oxygen saturation doesn't really change. So we don't really know whether all of this improvement in lactate, improved blood pressure, and decreased catecholamines really improve tissue oxygenation in vasopressin or not. Interestingly, the same group that published this also published this, where they, in their ICU, they had a period where they had a lot of vasopressin usage, and then they had another period to follow after December 2016, where they restricted vasopressin usage to only patients who are on 50 mics per minute of norepinephrine or more. And they did not show any difference in terms of organ system injury, and showed that this was a financial benefit to the institution by not allowing as much vasopressin usage. Now, this seems a little controversial, although I'd leave it up to you guys to interpret this data. We do know that the counter-regulatory systems for use of pressors really rely on this three-legged stool that includes arginine, vasopressin, renin-angiotensin, and the sympathetic nervous system all together. And that's why I'm a proponent of a synergistic model where we not just use the adrenal medulla with norepinephrine and metabolites and epinephrine, also use posterior pituitary and vasopressin metabolites, and also use the liver, kidney, and the renin-angiotensin axis. So three together are the way to go in terms of refractory shock, especially. And when you see your patients headed towards a refractory trajectory, early initiation of multimodal vasopressors is the way to go. We do know that there is strong hormonal deficiencies, sympathetic nervous system impairment in septic shock, low plasma vasopressin in septic shock, and impairment of the renin-angiotensin cascade in septic shock as well. And we did the same in the ATHOS 3 trial where we used angiotensin 2 in vasodilatory shock. 80% of our patients had classical septic shock, and we showed a clear hemodynamic response with angiotensin 2. We also showed that there was no survival benefit, even though this was not a trial meant for survival, only about 330 odd patients, not powered for mortality outcomes. The molecular basis of usage of angiotensin 2 in catecholamine resistant shock or refractory septic shock is really that ACE enzyme is probably impaired in septic shock. That's because endothelial injury. ACE resides in the pulmonary capillary endothelium. When this happens, then renin and angiotensin metabolites at the back end start increasing. And high renin itself is a marker of poor prognosis. We have shown this in retrospective work published or post-hoc work published out of the ATHOS-3 cohort, where this dark red line here shows patients who had placebo given to them and had renin way above median. Half of these patients were dead at 7 days and about 80% were dead at 4 weeks. So clearly high renin shows poor survival, and patients in the blue here who had either renin below median or were given angiotensin 2 in addition to correct the renin, they had a survival benefit. So clearly a molecular basis, the use of angiotensin 2, this work has been sort of replicated in one way or the other. So this is the group in Belgium that showed that in a very heterogeneous ICU population, renin outperformed lactate as a predictor of ICU mortality and was not affected by diurnal variation, continuous renal replacement therapy, or drugs that affected the renin-angiotensin axis. So really, is renin the new lactate? Well, I believe we're almost there. We just need a point of care assay for renin. This work has also been recently replicated by the group in Maryland, larger cohort, and this time showing not just a peak renin, also a baseline renin that was better than lactate, overall renin kinetics that were better than lactate, and a renin of 40 picograms per cc that was better than lactate of 2 millimoles per liter in predicting mortality. And this is sort of a graphical display of what I just said. So renin of 40 picograms per cc or more had a significant association with mortality compared to lactate of 20 millimoles per liter or more. So clearly more and more evidence accumulating. This table here shows a sort of a breakup of the evidence. So on the right is the work by Belomo and our group with ATHOS-3, where we basically showed that renin is elevated in catecholamine-resistant vasodilatory shock, and the use of exogenous angiotensin 2 benefits these patients. Gleason's group then showed that peak renin and rate of change of renin predicts ICU mortality better than lactate. And then Jayaraju and the Maryland group showed that renin and lactate, both initial and peak, predict in-hospital mortality. And the rate of change of renin or renin greater than 40 picograms per cc is a better predictor of in-hospital mortality compared to lactate. So the evidence is accumulating over time, and more evidence seems to suggest that angiotensin 2 is a good pressor in refractory septic shock. Here is my own experience. This is a young patient with high renin vasodilatory shock. This is a patient on VV ECMO with COVID-19, and this was the day that we decannulated him. Had significant MSSA bacteremia leading to septic shock. Was on 4 pressors at this stage. Renin was 10 times normal. The lab came back to me 2 days later. But again, I did start angiotensin 2 here about empirically, and led to improved outcomes. We did publish this. This was also remarkable because this patient had a BMI of 74, and walked out of the hospital alive. So who responds to angiotensin 2? Again, the group from Mayo Clinic has done prospective work on angiotensin 2 and septic shock and shown a clear survival benefit in those receiving angiotensin 2, but these patients also were getting vasopressin and were well resuscitated with a lower lactate than those who did not survive. So clearly resuscitate patients well, give them other timely pressors, and they will fly with angiotensin 2. What are we doing at our institution? We are using angiotensin 2 for vasodilatory shock that is non-septic, that is post-cardiopulmonary bypass vasoplegia. But we're also combining it with serial renin levels, lactate checks, cardiac output, filling pressures, and also transcranial Doppler whenever available. And I'm happy to share this protocol with those who are interested. We've also published some of our initial results in patients with heart transplants. So very simplistically, this is my last slide or so. Really, the hemodynamics in septic shock, if you look at refractory septic shock, there's a lot of common sense. The important part is to identify and treat the underlying cause, early resuscitate, give fluids as necessary. Don't overdo it. Start pressors early, start multimodal pressors early. Keep treating other things that will impair response to pressors like acidosis, dyselectrolytemia, and hypovolemia, and add 2 or 3 different molecular mechanisms of pressors early on. Send biomarkers, send renin. Someday we'll have point of care renin. You'll be able to early transition to angiotensin 2. Also, look at sending lactate early. Look at starting vasopressin early, and then use your adjuncts as well, such as hydrocortisone, thiamine, ascorbic acid, and most importantly, always keep looking at your source. Don't have good source control, then you don't have good hemodynamics. So this is in short. Remember, whatever we're trying to do, we're trying to decrease the use of catecholamines in the ICU in septic shock. This is something that we've relied on heavily over the ages and really hasn't led to a lot of benefit when used indiscriminately. So thank you again for your time today and your patient listening, and I'm open for questions and comments afterwards.
Thank you, Dr. Ashish. We all know inflammatory response during sepsis causes an adaptive response of tubular epithelial cells, resulting in reduced kidney functions, and which has a quite high impact on mortality. Let's hear from Dr. Valentine Lobo, who's a consultant nephrologist at KM Hospital, Pune, on timing of renal replacement therapy in septic acute kidney injury patients. Over to you, sir.
Good morning. Today I'll be talking about the timing of renal replacement therapy in sepsis-associated acute kidney injury. Sepsis is associated with almost 50% of all ICU acute kidney injuries, and about half of these are prescribed renal replacement therapy, and these patients have a very high mortality. It's known that sepsis itself increases the mortality and risk of chronic kidney disease because of intrarenal systemic inflammation and organ crosstalk, which occurs in acute kidney injury associated lung injury and ARDS. The sepsis-associated acute kidney injuries in various studies were shown to have an increased need for renal replacement therapy, a higher mortality, and an increased ICU and hospital stay. Many trials which studied the timing of initiation of renal replacement therapy, both in sepsis and in general in acute kidney injury, have yielded inconsistent results. And so the data at this moment in 2020 in a systemic review have been concluded to be scarce, contradictory, and inconclusive. Unfortunately, a good many studies were small, single center, and retrospective in nature. It may be argued that an early start of renal replacement therapy would establish a good metabolic control, avoid hypervolemia, which itself is known to be associated with an increased mortality in ICU acute kidney injury, and may also reduce both renal and systemic inflammation. As opposed to this, delaying the start of renal replacement therapy allows a patient to be stabilized, reduces chances of complications which have been shown to be associated both with acute kidney injury as well as with renal replacement therapy itself, and a significant number of patients may actually improve without needing renal replacement therapy. In 2013, Mehta and Macedo put forward the idea that in acute kidney injury, there is a supply-demand mismatch. It is a condition in which the capacity of the kidneys is extremely low and the demand for metabolic control and volume control is very high. And this brought forth the concept that a renal support with renal replacement therapy might be beneficial in these patients. Over the last 5 years, 4 very large, high-quality studies have been conducted to assess the benefits of an early start to renal replacement therapy. These were the ELAINE study, a single-center study, and the AKI-KI study, Ideal ICU study, and the largest of them all, the START AKI study, which overall enrolled almost 3,000 patients, which was as many as all the other studies put together. What can be seen from this table is that the early group in any of these studies started dialysis very rapidly after the criteria were met, between 2 to 6 hours of the inclusion criteria met, as opposed to the late group, which in all the studies 25 to about 60 hours after the criteria were met. The percentage intervention, except for the Elaine study, which was almost the same in both the groups, showed that a significant number of patients who were randomized to the late group avoided dialysis altogether, whereas more than 95% of patients randomized to early renal replacement therapy in all the studies received renal replacement therapy as per the protocol. And the outcomes in all of these were hard outcomes of 90-day or 60-day mortality. Now, what did the two studies, the AKI-KI study and the ideal ICU study, show? When they compared patients as well as two of these studies looked at in the late group, patients who never received renal replacement therapy and those who received it as a rescue therapy late. It was seen clearly that the patients randomized to late therapy who did not receive renal replacement therapy did best, and by far the patients who received it as a rescue therapy did worst of the lot, being associated with a significantly higher mortality in the AKI-KI study as opposed to those patients who were dialyzed early. So there appeared to be from these studies an optimum time. The ideal ICU study was the only study which was conducted exclusively on septic patients, but two of the other studies had significant numbers of patients as well. Now, as can be seen from these studies, there was no significant difference in any of the three multi-center studies in either 60-day or 90-day mortality, but a significant proportion of patients who were randomized to the late start did not eventually receive renal replacement therapy, and a significantly higher proportion of patients in the START AKI study remained dialysis dependent at 90 days if they had received early renal replacement therapy. There was also a higher risk of catheter-related bloodstream infection in patients randomized to the early group, and also of complications except hyperkalemia in the early group as opposed to the late group. The ideal ICU study, as I mentioned earlier, was the only study of the four which exclusively randomized septic acute kidney injury patients. And this study, which was initially designed to include 834 patients, was terminated for futility at 488 patients. And this is what it showed. There was absolutely no difference at any time point in the mortality of going up to 180 days. There was no difference in the mortality between the two groups at all. The START AKI study, the largest of these studies, included non-septic patients, but importantly, there was a significant number of the 2,800 plus patients who were randomized. About 1,600 patients, more than 1,600 patients of these had sepsis, and about over 1,200 patients had septic shock. Now, when this subgroup with sepsis and septic shock was analyzed, once again, what was found was that there was no significant difference in the mortality. The relative risk was 0.95 with a 95% confidence interval that crossed 1. But there was a significantly higher renal replacement therapy dependence among the survivors at 90 days, even within the septic group, and that was associated with a higher relative risk overall. So what this study concluded was that even in septic patients, rehospitalization and dialysis dependence was higher in patients randomized to early therapy. And this is the Kaplan-Meier plot of the START AKI study. No difference all the way to max. In the AKI study, also there were septic patients, and I'll look at that in a minute, but this is what the study showed overall. Once again, all the way to 60 days, no difference in mortality whatsoever between the two groups. But only about 60% of the patients in the late group ever received renal replacement therapy, which was significant as compared to more than 90% of those in the early group who received renal replacement therapy within less than 24 hours of being randomized. Now, in 2018, the workers, the researchers of the AKI-KI study did a subgroup analysis of the septic patients. What they looked at was patients with septic shock. They looked at cumulative fluid balance. They looked at mortality, and they found that there was a significant group, 348 patients out of the 620 initially randomized had septic shock. And when they looked at the percentage survival up to 60 days, once again, there was no difference between the septic shock patients and those who were randomized to early therapy versus those randomized to late therapy. There was no difference in a higher septic associated organ failure score, but there was again a significantly higher proportion of patients randomized to late therapy who improved at day 28 and became RRT independent as compared to patients randomized early. So what they concluded was that whether there was sepsis or there wasn't sepsis, whether there was septic shock or not, a late therapy appeared to not confer any harm, but in fact, better renal replacement therapy independence at 28 days. Their conclusions were that early renal replacement therapy did not improve mortality at 60 days. The delayed strategy reported significantly low use of renal support in all patient groups and better recoveries. In addition to these randomized control studies, there have been about 8 retrospective studies, mostly a few of them have been prospective, most of them have been retrospective studies. Their entry points of all the studies were different. The modalities of renal replacement therapy haven't been well specified, and the time points chosen in all these studies have been different, and they have yielded contradictory studies. Beck's study done in 2017 showed a benefit of early renal replacement therapy, as did Payne's, but Chow's study did not, as other studies. In the last 10 years, these studies had different entry points, different outcomes, and different time points. And none of them was able to draw conclusive a conclusion, and none of them were comparable. So to conclude, the studies so far on early initiation of renal replacement therapy in acute kidney injury have not yet shown a survival benefit. A significant number of patients who received delayed treatment, even in among septic patients, recovered without requiring renal replacement therapy. A significantly higher number of complications actually occurred in patients who had been randomized to early renal replacement therapy. While sepsis-associated acute kidney injury may represent a special situation, more studies may be required on this group of patients to draw definite conclusions. Thank you.
Thank you very much, Lobo sir, for enlightening us with a talk on RRT in sepsis and its timing. Now we will move on to the next session, actually how we should do it. And for this session, first talk, I welcome Dr. Srinivas Samavedan, who is the head of Department of Critical Care, Virinchi Hospital, Hyderabad. And sir will be talking about fluid resuscitation in cardiac and renal patients. Over to you, sir.
Good morning, friends, and welcome to this interesting conference on sepsis, Sepsiscon 2021, the virtual conference. And I thank the organizing committee and the scientific committee of the meeting for giving me this opportunity. The next 10 minutes or so, I will be discussing about a confusing and confounding topic which we all face in intensive care units, and that's fluid resuscitation strategies in septic patients with cardiac and renal disease. I will first look at each of these two dysfunctions separately, and then we see what we can do when both the dysfunctions happen together for the same patient. This topic is relevant because we know that cardiac contractility is intrinsically linked to the volume status of the patient. And unless you improve the volume status, the cardiac contractility and therefore the cardiac output will not improve, which is the target for fluid resuscitation. Whatever inotropes or vasopressors we may use in the process of resuscitation are effective in a volume deplete state. So volume optimization is the first step during resuscitation. There is a belief and probably some evidence that standard rules of resuscitation may cause harm in certain subsets of patients through compromised organ function. We also know that hypovolemia is a frequent cause of oliguria, and we give fluids to counter this oliguria. But overdoing the fluid resuscitation may also confound oliguria by causing renal edema and intra-abdominal hypertension. When you look at the fluids in sepsis in a patient who's got cardiac dysfunction, the Surviving Sepsis campaign recommends 30 ml per kilogram of crystalloid for resuscitation. With the fear of compromising a cardiac function in somebody who has a pre-existing cardiac disease, under resuscitation is very common in these patients who have sepsis on a background of heart failure. Septic patients who have a reduced EF who receive more than 3 liters of fluids have been shown to have an increased mortality, and so that's probably one cutoff we can remember, that we should not cross this limit for patients with heart failure. This is the subgroup of patients who may benefit with the use of albumin, although all the studies with fluids evaluating crystalloids with albumin have not had a priori subset of heart failure patients. In such patients, dynamic indices might guide the fluid necessity, and you might have to do something like a global end-diastolic volume measurement, an extravascular lung water measurement to guide whether we are overdoing our fluid resuscitation. While those tests may be, or those techniques may be more invasive, we can use the ultrasound and look at the profiles of the ultrasound and the IVC variability with fluid boluses to guide us in optimal therapy for fluids in patients with sepsis and heart failure. So if you use the sonographic approach, the echocardiography can tell you whether you are dealing with a hyperdynamic heart or a hypodynamic LV. A hypodynamic LV should caution us for restricting the use of fluids. The IVC assessment would be able to tell us whether the IVC is full or flat. A flat IVC would mean you could give fluids despite the fact that the patient has got diagnosed heart failure. Lung ultrasound, if it shows bilateral diffuse B lines, then you are seeing a high extravascular lung water. So we should actually be limiting our fluid therapy for these patients. If the patient has a hyperdynamic LV, a flat IVC, and no B lines on ultrasound, then these patients, despite having heart failure, will be able to tolerate your fluid boluses. If you look at the routine markers of resuscitation like lactate, all these markers like lactate, capillary refill time, and SCVO2 have had some impact with heart failure on them. So the lactate, it may be inherently elevated in patients with chronic severe heart failure due to chronic tissue hypoperfusion. The capillary refill time may be less likely to be less accurate in patients who are severely edematous because of heart failure. The CVP is erroneously high despite hypovolemia in these patients with heart failure, and stroke volume variation may be unreliable in these patients because of the pulmonary hypertension and rhythm disturbances which these patients might have on a background of heart failure. So if you look at the stepwise resuscitation of patients with heart failure and sepsis and limit ourselves to the fluid aspect as the scope of this talk, we look at the history, the physical examination, the biomarkers, the echocardiography, and the lung ultrasound as we have discussed. So we see whether the patient is in shock or not in shock. If the patient is not in shock and there is no evidence of congestion, we go ahead with fluid resuscitation as standard therapy. But in the absence of shock, there is congestion, we have to consider a diuretic along with judicious albumin administration. If there is no congestion and there is shock and no congestion, we can continue with fluid therapy with support from vasopressors and inotropes. So this is probably a very practical algorithm for patients with heart failure and sepsis. When you extend this to patients with sepsis and renal failure, the initial response to any oliguric patient is a fluid challenge after excluding obstruction. But with the idea that the renal blood flow increases with an increase in GFR. While this is a physiological reality, this correlation of increased GFR with increased renal blood flow is lost once AKI of some degree has set in. Patients with chronic kidney disease have additional issues of sodium alterations and third space collections which can skew their fluid therapy. So the augmentation of renal blood flow with fluids may not therefore have the desired effect on the glomerular filtration rate in patients with sepsis whose cardiac output is normal or may be increased in the hyperdynamic phase of sepsis. When you give fluids to a patient who has got kidney disease or at risk of kidney disease, the type of fluid matters, whether it is crystalloid or it is colloid or albumin, it matters. Starches are found to be harmful. The volume of fluid matters. If somebody has got a positive fluid balance of more than a liter every day, at the end of 72 hours, the intra-abdominal pressures are bound to rise and compromise renal perfusion and drainage. So the cumulative fluid balance of individuals matters when patients have kidney injury. Does giving more fluids mean more output? The classic study has shown otherwise. Despite the fact that more resuscitation fluid has been given in the standard care group, the urine output in the fluid restriction group and the standard care group has been found to be nearly equally matched with the mean values nearly stayed. So it means that more amount of resuscitation fluid beyond a limit do not seem to convey the more translate into a higher urine output. And more fluid, a positive fluid balance or a fluid overload can cause kidney injury by various mechanisms like raised interstitial pressure, renal edema, renovascular resistance, increase the tubular pressure, increase the renal vascular resistance, and increase venous pressure. So you are actually perpetuating an oliguria by giving more fluid and then using that oliguria to give more fluids, which is a vicious cycle, which is self-perpetuating. If you look at the various fluids and how they stack up, if you look at maintenance fluids, the benefits are with a lower volume resuscitation fluid and buffered crystalloids. Albumin somewhere in the intermediate range, whereas starches and maintenance fluids have a negative effect or a harmful effect on kidney function in patients with sepsis and renal dysfunction. What happens when these two organ dysfunctions coexist together? In this situation, extravascular lung water may be an ideal measurement to tell us where we are going wrong with our fluid therapy. Similarly, lung ultrasound, transthoracic echo, and IVC assessment play an important role in these patients who have a combination of sepsis with renal failure and heart failure. And these patients may benefit with an earlier initiation of extracorporeal fluid removal. So in summary, heart failure and renal failure with coexisting sepsis present unusual challenges. Conventional markers of resuscitation will be altered in this setting. Ultrasound and echo have a key role to play, but multimodal monitoring may be the best way to optimize fluid therapy in these patients. Thank you very much and have a good day.
Thank you, Dr. Srinivas, for giving very practical approach to how to go about the resuscitation in cardiac and renal patients. Here we'll move on to the next very, very important topic. Fluids in ICU are very important and they are double-edged sword. It can cause harm also. So let's hear from our great teacher, Dr. Ram Rajgopalan sir, who is a professor and senior consultant in critical care from Chennai for about de-escalation phase of SOST. Over to you, sir.
Today will be in relation to de-resuscitation in the patient management of patients with septic shock. This idea is not necessarily very new, but something that has been developed over the last decade or so and has been increasingly commonly applied in the management of patients in the ICU. I think we need to understand the idea of de-resuscitation primarily because our initial focus in management of septic shock has always been to give a liberal amount of fluids. But now with the recognition that the fluids by themselves may create adverse problems, the focus has been also shifted to attempting to remove these fluids after the initial phases of resuscitation. So by definition, de-resuscitation is the process of attaining an even or a negative balance after the initial period of stabilization of the hemodynamics and the initial resuscitation has been completed. This is usually in two phases that occurs usually in the first 3 days to a week or so, what we call as late conservative fluid management. And there is an importance to this 3 days, as I will show a little later. And it also comes on to the later phases, usually after a week, when we do a late goal-directed fluid removal, usually with the use of aggressive amounts of diuretics, plus or minus renal replacement therapies. What is the rationale behind this? And I think most of us will understand that very clearly because much of us, our management of patients with septic shock has always been with the use of liberal amounts of fluid. But now with the recognition that that kind of fluid is potentially dangerous, we are trying to see if we need to be reasonably restrictive. Just to take as an example, the studies on EGDT that were initially propagated used volumes of fluid between 3.5 to 5 liters in the average adult in the first 6 hours of resuscitation, which most of us will find a little too aggressive at the present stage. Besides, when you look at databases on sepsis outcomes, it doesn't appear that the amount of fluid that you give in the first 12 hours or so makes a difference in terms of outcome. Here it shows that the administration of the 30 ml per kg, even if it is delayed up to 12 hours, is not associated with a change in the mortality of these patients. Also, in addition, we know a lot of physiological reasoning about why we need to be restricting fluid. Classically, in patients with ARDS, the reduction in the extravascular lung water can translate into significant improvements in oxygenation and ultimately weaning off the ventilator. So as a consequence, we try to focus on how we need to achieve this balance. And here again, there is reasonable amounts of data, again, from retrospective studies, which show that it is not only the adequate resuscitation in the early phases that translate into better outcomes in terms of hospital mortality, but it's also the ability to achieve a conservative amount of fluid restriction in the later phases that translates into a significant benefit. So it is not just fluid administration early that makes a difference, but it is also the restriction at a later stage that translates into a definitive outcome. But the question that we always ask is, when do we make this kind of a transition? Here, in that sense, the ROSE algorithm that is proposed by Malbrain is very useful for us to look at because it gives us a physiological reasoning for when we should start the de-resuscitating. In the initial phases, the resuscitation phase, there is an insult that is associated with hemodynamic instability, not a time to restrict the fluids, nor is the optimization phase that usually occurs from a few hours to maybe a day or so. And this is a period of ischemia and reperfusion, which again will be compromised by a process of fluid restriction. Where it does become very useful is in the later phases after the stabilization, where the increased permeability and its association with organ edema is probably going to be negative. That de-resuscitation makes a lot of sense. And also in the later phases, when the patient has had a huge accumulation of fluid, the reduction of that in a protocolized manner does make a difference in terms of outcomes. So when we make a decision, the goal to achieve a zero or negative fluid balance by day 3 and to try and keep a reasonable cumulative negative balance by the first week or so is reasonably logical. And this day 3 idea is not an arbitrary kind of a number because there are some retrospective studies that seem to imply that the negative balance at day 3 is an independent predictor of outcome in patients with septic shock. This again is with the recognition that this is retrospective in nature. We definitely need to have all of this evaluated in prospective studies. How do we achieve this kind of de-resuscitative process? Besides the fact that we need to restrict the fluids that are being administered to the patients, we try to use one of these 3 processes, the use of diuretics, the use of concentrated small volume albumin resuscitation, and the use of renal replacement therapy to try and achieve these endpoints. What is the data as far as this is concerned? As we clearly say, there are no hard data of the entire de-resuscitative process, though I will mention some of the outcomes a little later. But when we look at independent components, there is no data to say that each of them is associated with definite improvements in outcome. Let's just look at it. Diuretics classically are going to be loop diuretics. Very few people use the combination of loop diuretics with a thiazide, acetazolamide, or spironolactone, as was shown in this particular recent survey. But when we're using the loop diuretics, the efficiency of the loop diuretic is clearly improved, as seen in this meta-analysis below, by the use of an infusion in contrast to bolus therapy. Though it doesn't influence the creatinine clearance, it does associate itself with a greater amount of urine output. And a larger amount of urine output will be beneficial for the management of patients with a volume overload. It does not translate into a survival benefit, again in the same meta-analysis, where a comparison between continuous and infusion and a bolus dose doesn't show an improvement in the outcomes. The second therapy that we use is albumin. Though albumin has not been very favorably reviewed in the face of septic shock, the one trial that we need to look at, which used it a little differently, may provide us with some information, and that is the ALBIOS trial. In the ALBIOS trial, it was not used in the routine form as a fluid resuscitative process, but it was used as a replacement to aim to achieve a serum albumin concentration that was reasonably high. So this was done by the administration of a small volume of concentrated albumin in the beginning, and subsequently, with a close observation of the albumin levels, additional therapy was always given to try and maintain a albumin concentration of greater than 30 grams per liter. This was clearly achieved in this process. As you can see over here, the 30 grams per liter in the subgroup that was administered albumin. was significantly higher than the albumin levels in the other group. And what was this associated with? A clear increase in the negative fluid balance. As you notice over here, the administration of albumin resulted in a even fluid balance by about the 6th day. And by the end of the first week, there was an overall negative balance in these patients. So this clearly works. Albumin, when administered and titrated to an albumin level, is associated with good diuresis. It does not necessarily translate into a survival benefit. Though there is some concern that in patients with a low blood pressure and septic shock, that there may be a tendency towards an improvement. This is at best a hypothesis generating retrospective analysis of the data from this particular trial. So I think as it stands right now, we're not demonstrating a benefit in terms of survival, but we are showing an improvement in terms of the urine output. A third way in which you can do this is by the use of renal replacement therapy. And as we know from more and more recent trials, that the aggressiveness of renal replacement, usually associated with high ultrafiltration rates, are not necessarily associated with an improvement in outcome. But these studies have never looked at what you achieve in terms of your net balance, fluid balance. So a retrospective evaluation of the data from the renal trial, which is the Australia-New Zealand randomized controlled trial, shows that if they took a group of patients who achieved a negative balance and compared them with patients who achieved a positive balance, there was a significant difference in the short-term 90-day mortality, as you see in this graph over here. Besides the reduction in the risk of death, all the other factors are also favorably influenced. Renal replacement therapy free days, ICU free days, and hospital free days were all clearly benefited by the aggressive process of volume removal. Now, the question can always be if this is a marker of the mortality, or is it necessarily a cause of all this kind of change? And here they did a propensity analysis and seemed to imply that there may be a causality and that an aggressive process of removing fluids, not necessarily of very high ultrafiltration rates, can translate into benefits in these patients. There has been a method of combining these three processes, which is what is called the PAL method, the application of a strong positive airway pressure with the hope that the fluid in the lung is shifted out. The albumin traps it in the vascular compartment, and then the administration of Lasix, while the albumin itself will probably be of value in terms of producing the diuresis, the diuretic will benefit this. There is no hard data on this other than one retrospective case control kind of study, which clearly shows that with this process, there is an improvement in the surrogate endpoints. Your extravascular lung water comes down, your intra-abdominal pressure comes down, the cumulative fluid balance is favorable. But also in this study, there is an indication that there may be a survival benefit and a benefit in terms of weaning off the ventilator. This, unfortunately, needs to be confirmed in a large randomized controlled trial. Is there any randomized control information that is of value? I think here the best study that we know of is the FACT trial, which was the ARDS NET study, which used a conservative arm achieving roughly about a 130 ml negative balance during the course of the study, in comparison to the liberal arm, which almost had a 6 liter or 7 liter positive balance. And they clearly showed that there was no difference in mortality, but there was an improvement in the oxygenation and ultimately the weaning of these patients. This has been combined into a meta-analysis, and the meta-analysis comes to the same conclusion that with a few other small randomized controlled trials, the number of ventilator-free days is improved by the process of aggressive deresuscitation, and the stay in the ICU is also significantly reduced. But this, again, like in the FACT study, does not translate into a survival benefit. So as we see over here, in most of these deresuscitative processes, there is no improvement in survival, though the improvement in morbidity may allow the patient to come off the ventilator faster and maybe discharged from the ICU at a faster rate. So we need to look at this in a balance. Is there a potential for you to have adverse events? And a late analysis of the FACT study seems to imply that that may be a concern. Here is data from 2012, which clearly shows that the neurocognitive deficits in patients who were aggressively managed, or so-called conservative arm of the FACT study, was significantly greater than when we were liberally using the fluids. So on an average, when we look at this data, the best that we have is no demonstration of an improvement in survival with this kind of a process. But there seems to be an improvement in the direction of getting the patients off the ventilator and out of the ICU fast. But we need to worry about these long-term consequences. And unless we have much better randomized controlled trials in the future, I think I would be very conservative about recommending this kind of a process at this stage. So we do need a little bit more information before we incorporate the process of de-resuscitation on a more aggressive manner than we are at present. Most of us right now are conservative with the administration of fluids, but we do not go aggressively with the administration of diuretics, albumin, and other processes to remove the fluids. Thank you very much for listening. I think I'll be ready to answer any questions in the next session whenever it's available. Thank you very much.
Thank you very much, Dr. Ram sir. Now we want to move on to the next topic, very important topic in intensive care, that is glucose control in diabetic septic patients. As we all are aware that altered glucose levels are definitely related to the morbidity and mortality in intensive care unit. To throw a light on this very important topic, it's my pleasure to invite our next speaker, Dr. Subal Dixit sir, who is a consultant in ICU in Sanjeevan Hospital, past president ICCM. Over to you, sir.
Welcome to this session, and I thank the organizing committee of Sepsiscon and Sepsis Forum to inviting me for talking in this session. And I've been asked to talk on a very different topic than what we normally discuss into septic patients. And I've been asked to discuss about the glucose control, especially in patients of septic patients and those who have got diabetes mellitus. So again, thank the organizing committee for inviting me, and I will be very happy to share my presentation now. So glucose control in septic patients in diabetes is very, very important, because we know that sugar, definitely in sepsis patients, if the sugars are not controlled, it increases the mortality rate. And dysglycemia has emerged as one of the most common challenging problems in critically ill patients, and especially in all septic patients, and now also especially in this pandemic of COVID, which is there. The factors which mainly contribute to dysglycemia, it includes the prediabetes, especially those who are obese, those who are with poorly controlled diabetes, and various other drugs which are also used in the treatment of sepsis, like steroids, what we use, catecholamines, which are released as a part of stress, and even certain other medications, which also suppress the insulin levels, and as a result of which the sugar levels can also go up. Mind you, sepsis itself is a stress, and this sepsis itself can also precipitate increase of the anti-insulin hormones, and because of this, the sugar levels also go up. So sepsis per se, or directly also because of the COVID, which directly suppresses the insulin production of the pancreas, it is also known to precipitate diabetes or also produce uncontrolled diabetes. The various mechanisms of cellular hypoxia, which also occurs because of shock in critical illness, exacerbates the reperfusion or the oxidative injury, and as a result of which we have got increased blood sugar levels. And this injury also produces the injuries of the tunica intima, and as a result of which various coagulation disorders also get precipitated. And therefore, it mainly appears to be at a preventable risk, at least to some degree, and if dysglycemia is mainly controlled. So what is the pathophysiology of dysglycemia into these septic patients with diabetes? We know that diabetes is definitely a disease where there is a decreased production of insulin. There is also an immune alteration which also occurs into these septic patients, and because of the systemic inflammation, various stress hormones which are also antagonists to insulin, like cortisol, catecholamines, glucagons are released, and they also produce a higher rates of glycogenolysis as well as gluconeogenolysis, and as a result of which the sugar levels also go up, and insulin resistance because of obesity and also because of secondary to the various systemic vascular inflammation plays an important role. And mind you, even for refractory septic shock, we have been using steroids in the form of methylprednisolone, or even in this COVID pandemic, a large or overuse of steroids was also considered as one of the major factors for precipitation of diabetes, and also the emergence of a term which is commonly known as a steroid-induced hyperglycemia. So what are the common attributes to steroid-induced hyperglycemia in ICU patients? Glucocorticoids, we know they are beneficial. We are using glucocorticoids routinely into sepsis shock, or especially in those into refractory septic shock. And glucocorticoids are known to demonstrate reduced amount of mortality and the need for invasive mechanical ventilation in septic patients and also into hospitalized COVID patients. And various guidelines have also thought that systemic steroids for the treatment of COVID patients, especially severe COVID patients, can be beneficial. The risk factors which are responsible for development of steroid-induced hyperglycemia is also the dose and the type and the duration of treatment, how we are giving it. It also depends upon the physiology, whether you are giving it as a part of continuous infusion or a bolus treatment, especially those, the senior citizens, the male sex, especially those who are obese with a belly fat and a BMI which is on the higher side, EGFR which is less than 40, the creatinine clearance, or the HbA1c levels above 6, and those with a history of diabetes, and there's a family history of diabetes, and there is also a concomitant use of various mycophenolate, mofetinil, or other immunosuppressions. So the mechanism of steroid-induced hyperglycemia, we know that glucocorticoids have been used. There is increased production of glucagon, and this increased production of glucagon, there is also a progressive B cell failure, and there is a result of which is also anti-insulin, and as a result of which there is also an impaired amount of incretin secretions, and because of this there is proteolysis or reduced amount of glucose intake, and because of the reduced glucose uptake or proteolysis, there is also a decrease in the muscle mass, and as a result of which weight loss occurs, and over and above, the septic patients are also in a hypercatabolic state, and as a result of which they also, if not fed properly, they also continue to lose certain amount of muscle mass. So glucagon production, at the same time, reduced amount of insulin sensitivity, increased resistance, increased production of leptins, or decreased adiponectin, these are responsible for the mechanism of steroid-induced hyperglycemia into these septic patients. The molecular pathways for glucocorticoid side effects on glycemia and the protein anabolism, we know that there is definitely, because of the hypercatabolic state, and if not fed properly, there is decreased amount of protein synthesis. At the same time, because of the hypercatabolism, there is increased protein catabolism and decreased amount of glycogen synthesis. So why dysglycemia is harmful? We have also seen that various studies have also shown the nice sugar levels of the intensive insulin therapy, which was studied way back, have shown that yes, a very tight, rigid control definitely did help to reduce a mortality in patients of sepsis or even in patients of COVID. The in-hospital death rate was significantly lower in well-controlled group as compared to the poor control group, and there was a significant 87% risk reduction into the group where the sugars were well controlled as compared to vis-a-vis if you compare it in those groups where the sugars were not controlled. The glycemic variability and the outcomes which are there, high glucose variability is associated with increased amount of ICU mortality and in a large heterogeneous cohort of ICU. So therefore, this study was also published, and this study almost consists of about 2,200 patients where the glucose variability was measured by a standard deviation, and the glycemic index was significantly associated with increased amount of ICU mortality. And this relationship was maintained with a confidence interval of almost 95%, and even after excluding patients of hypoglycemia, which was defined as a sugar level of less than 60. So therefore, definitely glucose variability is associated with increased amount of mortality, and you must have a smooth and a very comfortable level of sugar control. Similarly, from this graph, which was published in Critical Care Medicine in 2008, glycemic variability as an independent risk factors, we have seen if the sugar levels are between 70 to 90. So basically the glucose variability or the mean glucose level, higher the glucose level, increase in the hospital mortality. And therefore, you must have an achievable or a decent, fair, reasonable control of sugar levels to between 140 to 150 milligrams per cent in all subset of patients, whether whether it's a septic patients with diabetes or diabetic patients with sepsis or stress-induced hyperglycemia, the sugar levels have to be controlled irrespective of whichever treatment you're giving with the help of insulin. Similarly, Badai, in a retrospective observational study of over almost 1.9 lakh patients, he studied the association of ICU-acquired dysglycemia and in-hospital mortality, and they found that the glycemic variability in terms of severity and duration was associated with high hospital mortality rates. So therefore, the sugar control is very important. Sugar control has to be given topmost priority as much as you give importance to all the fasting, and therefore sugar control also has been included as a part of a basic ICU care in the component of fast hug. Dysglycemia management in ICU patients, I'm sorry for the slides. The beneficial effects of tight glycemic control, what we saw from the NICE the intensive insulin therapy and the NICE sugar level study paper which came up, definitely in the studies which were published right from 1999 to right up to 2010-11, they've all showed that definitely in the intensive care unit, if a good amount of sugar control is being there is a significant amount of reduced mortality as well as reduced amount of infections, which are also seen, and they vary from almost about 15% to 20%. The various protocols for insulin therapy into ICU for control of sugars. Yes, intravenous infusion, definitely with a syringe pump, is very, very important. And most important primary target is to keep the sugar levels at a predefined target of 140 milligrams %. And also the blood sugar levels have to be controlled in all subset of patients. And mind you, the nurses play a very important role in maintaining and titrating the insulin doses in order to keep the sugar levels between 140. Even the ADA recommends the targets of glucose levels, that exactly there is no threshold which has to be predefined, but the average threshold should be kept between reasonably well under control between 140 to 160. And once insulin is started, definitely the glucose should be maintained between 140 to 180. And the targets of less than 110 or more than 180 are not recommended. And lower glucose targets may be appropriate in selected subset of patients into those subset to keep it between 110 to 140. Now, identifying most important thing is that the at-risk patients for dysglycemia or hyperglycemia. The most important thing is to improve the measuring accuracy. Every glucometer which is there, it has to be frequently calibrated as per the manufacturer's recommendations. And definitely, I was also one of the part along with Dr. Yatin Mehta and et al. To be a part of this esteemed panel to come up with the guidelines for dysglycemia control into intensive care unit. And definitely you have to see that the glucometer is well calibrated. HbA1c levels which are also equal to or more than 8.5, it should be taken as an indicator to postpone elective surgeries until the glycemic status is at least optimized for about 48 hours. And a HbA1c level should be done for all patients, especially in those patients who have got sugar levels of 140. HbA1c levels should be done for all diabetic patients if it has not been done for the last 2 to 3 months. And if the HbA1c is above 6.5, then the patient should be managed as a diabetic patients into intensive care units. An important thing into identifying of these patients of dysglycemia, if you find that 2-hour post-glucose, but after giving 75 grams of glucose, if the blood sugar levels is more than 140, it can also be used as a marker for diagnosis of dysglycemia, or a HbA1c level of cutoff of 6.5, along with the random blood glucose level should be used for dysglycemia diagnosis in all patients who are undergoing major surgeries or those who are at a risk of undergoing even minor surgeries. An important thing is a bedside capillary glucose levels should be used for diagnosis of dysglycemia. And however, in patients of shock or those patients who are on hypovolemia, definitely arterial or venous blood glucose levels are more reliable. That is very, very important. And this at a level of evidence of B1. And once a day random blood blood sugar level should be done for all patients who are admitted into the ICUs. Important thing, how frequently, almost a 4-hour recommendation, a 4-hourly blood sugar level should be used for detecting a glycemic variability in those patients who are on continuous feeds, or arterial sample or a venous sample is preferred over the capillary blood sugar sample for continuous monitoring of blood glucose. An important thing is the standard deviation should be used as a measure for glycemic variability in all critically ill patients with dysglycemia, and the mean amplitude of glycemic exertions, or the MACE, should be used as an additional measure. The acceptable targets now which are there, we have got a range of patients who come in with multiple organ failure, liver involvement, hepatic involvement, even those patients who have got CNS or neurocritical care patients. The preferred target should be kept for any medical patients or surgical patients should be 140 to 180 milligrams per cent. The frequency should be done at least 7 times a day in those patients who are orally fed and those patients who are on bolus feeds with dysglycemia. Mind you, don't forget to recalibrate your glucometers, and the blood glucose level should be measured 4-hourly, especially in those patients with who have got their continuous feeding with dysglycemia. And the monitoring and adherence of the glycemic targets are mandated. It is very important that adherence can be continued longer, and if there is a persistence amount of dysglycemia, or if the patient is on steroids. And hypoglycemia episodes should be very minimal, and effort should be seen that the blood glucose level should be kept to about 110, and with a standard deviation of just plus minus of 1. So the stress-induced hyperglycemia, as we said, those patients who are onto nutrition support, definitely every pharmacological treatment, any drugs or nutrition, all of them increase the sugar levels. Mind you, nutrition per se will not increase it. It's mainly the stress or the sepsis which is going to increase it because of the liberation of various anti-insulin hormones and also because of the use of steroids. So the acceptable targets should be kept between 140 to 180 milligrams per cent. The frequency should be measured about 7 times a day, especially in those patients who are orally fed or in those patients who have got dysglycemia, and blood glucose measurement should be done almost 4-hourly in continuous feeding patients where you have suspected dysglycemia, and more close rigid monitoring of glycemic targets and should be continued for a longer period of time, especially if there is a persistence of dysglycemia or if the patient is on steroids, and you should avoid hypoglycemia episodes, and effort should be kept to keeping the sugar levels to around about 110 to 140 and avoid hypoglycememia. As I said, we have come up with the Indian nutritional guidelines, and this paper was published in 2019 where Dr. Yatin Mehta was the leader. It is seen that yes, continuous feeding should be given over bolus feedings because it also maintains the sugar levels, and especially in those patients with dysglycemia, because continuous feeding, it helps you to achieve better glycemic controls, and it also minimizes the dysglycemic episodes. And what type of feeds should be used? Purely low carbohydrate feeds may not be reduce the postprandial glucose variability. But in those patients where there is hepatic or renal failure patients, definitely protein and electrolyte content should be taken into consideration, and along with the electrolyte imbalances and specific glycemic targeted specific nutrition support and containing optimal amount of proteins should be considered in those patients who are critically ill, where there is dysglycemia, whether the patient is diabetic or a non-diabetic. And most importantly, the feeds which contain complex or partially digested or slowly digestible carbohydrates and MUFA, they help for glycemic optimizations into these ICU patients who are critically ill. And the glycemic targets, especially into specialized nutrition, it should be identified by a glycemic variability or glycemic index rather than the carbohydrate index. And the glycemic index are precisely known for specifically formulated formula feeds. However, the estimation is not precise into kitchen feeds, and therefore commercially available formula feeds should be used for all feeding patients into intensive care units. The various recommendations which came up for ICU patients with COVID and the glucose control and glycemic variability adversely impacted the outcomes in COVID patients with diabetes. In asymptomatic or those patients, definitely the diabetic specific nutrition support should be given, physical distancing, counseling should be done, and it is recommended that frequent self-glucose monitoring has to be done in order to maintain the sugar levels. And management of diabetes, if the glucose control is good, then you can continue the same anti-diabetic regimes. But especially if the control is not good, then a rapid acting or a short acting insulin has to be supplemented. And as we said, more frequent rigid monitoring of sugar levels is very, very recommended. A strict diabetic diet along with commercially available formula feeds should be used. Drugs also should be titrated so as the sugar level should be maintained. Frequent glucose levels, almost about 7 times a day, or those patients who are on continuous feeds almost 4 hourly, should be reduced, because maintaining the sugar levels at reasonable well under control between 140 to 180 has shown that there is definitely a significant reduction in the mortality. Hence, to summarize, dysglycemia is an independent variable affecting the outcomes in diabetic as well as the non-diabetic critically ill patients. Stress-induced hyperglycemia worsens the glycemic parameters. Control of glycemic variables is imperative. Glycemic management includes both pharmacological as well as the non-pharmacological interventions, and dietary management remains as one of the most important non-pharmacological interventions into such patients. So please monitor, calibrate your glucometer, do rigid monitoring of the glucose levels to keep it between 140 to 180 milligrams per cent, so as to reduce the morbidity as well as mortality into these critically ill ICU patients. Thank you very much. And again, thank the organizing committee of Sepsiscon and Sepsis Forum for inviting me to talk on today's sessions. And I would be very happy to take any questions, if any. Thank you very much.
Thank you, Dr. Subal sir. Now we'll move on to the next session. Next session is very interesting. It is pro and con session. For this, we will have 2 speakers with us who will be fighting with each other. First is Dr. Deepak Govind sir, who is the Director Critical Care, Institute of Critical Care and Anesthesia, Medanta Medicine, Gurgaon, President of Indian Society of Critical Care Medicine. And our next speaker is Dr. Farhad Kapadia sir, who is again past president, senior consultant intensivist in the hospital Pune, Mumbai. Sorry. Apart from adequate source control and antibiotics, we have got very less armamentarium to fight against sepsis, and definitely because of increased mortality, we will be into more and more novel therapies for sepsis management. And one out of that is extracorporeal therapies for management of sepsis. So here to both of you, two pros and cons about these therapies.
Good morning, dear friends. First of all, I would like to thank organizers for giving me this opportunity. Today, I am going to talk about the extracorporeal therapies. Are they helpful in refractory shock? And Dr. Farhad Kapadia, who is one of the very senior intensivists in India and very respectable personality in ISCCM, is going to speak against it. So let us see. First of all, I would like to start with the case. It's a real case which was shifted to our ICU. He was a 40-year-old male, known case of severe acute pancreatitis, 4th week. He underwent exploratory laparotomy and necrosectomy was done. After that, he went into shock with AKI with multi-organ dysfunction syndrome. And when it was started progressing, worsening, he was shifted to our center on post-op day 2. He was already received meropenem, colistin, teicoplanin, and caspofungin. On arrival of our ICU, his hemodynamics was haywire. He was requiring 0.6 mics of noradrenaline and 3.6 international unit of vasopressin. He was tachycardic, his mean arterial pressure was low, and lactates were quite high. His echo was normal, and he was not any fluid responsive. He was requiring 80% of the FiO2 to maintain saturation, and PCO2 was 49, and lung ultrasound showed the shed signs and the basal consolidation. So now what to do? Continue with the standard of care, like giving fluids, like giving antibiotics, continue with ventilation, maybe prone ventilation, starting hydrocortisone, doing CRRT, blah, blah, blah. But let us see what happens. Once a healthy individual goes through shock, septic shock, and refractory septic shock, the mortality increases exponentially in these patients, and early intervention are warranted and may be beneficial. So whether would you like to wait or still continue with the standard of care, or would you like to think something out of the box just to save this patient or try to save this patient? Coming back to the role of the inflammation in the septic shock, inflammation is a necessary evil. We all know that. And the patients who are having inflammatory cytokine response are having highest risk of the death in these patients. So what we can do, if this is the immune response behavior, as you can see, when the infective insult is taking place, there is a surge in the pro-inflammatory arm, and gradually the anti-inflammatory arm also takes place. So in this area where there is a in the graph, as you can see here, in this time, if we do the any extracorporeal therapy, it may be harmful, but where the B, where the and pro-inflammatory response is quite high, at that time there is a cytokine storm, and the patients can benefit with the extracorporeal therapy. So in whom we can think of doing extracorporeal blood purification therapy as an adjunct therapy in those patients who are already on organ support, where the source control has done, the resuscitation is complete. After that also, if they are not stabilizing and ongoing instability is there, and those patients we can think of giving extracorporeal therapies as an adjuvant therapy. So as you can see in this slide, there is a cytokine, chemokine, concentration gradient is there, and infective tissues are there. After this blood purification in blood compartment, we can reduce the load of bacteria, reduce the load of cytokine, and reduce the load of leukocytes. These are the different extracorporeal therapies which are available in India. Is polymyxin B, called as a toremyxin, Altico LPS absorber, cytokine gene absorber device known as the cytosorb, and oxalis. So the studies are not new. It is the evidence little bit whatever is old. In this paper, they have concluded that polymyxin B hemoperfusion may reduce the mortality. Another paper, the UFAS randomized control trial. Here you can see in this study with the use of polymyxin B, the mean arterial pressure and inotropic scores, mean arterial pressure was better and inotropic score was better, and vasopressor dependency was less in these patients who were subjected to hemoperfusion. 28-day mortality was little less, and hospital stay was also less. Another paper, as you can see here, the SOFA score improved with the administration of polymyxin B hemoperfusion. Another paper which shows that toremyxin, this is the mortality risk, is the lesser with the toremyxin column in comparison to the conventional column. This was the editorial which was published a few years back, where they have said that balancing humors in severe sepsis is still a role of extracorporeal therapy. And as you can see, it favors the PMX. So recent paper where the potential survival benefit of polymyxin B hemoperfusion septic shock on the continuous renal replacement therapy, this was a propensity match analysis. And as you can see, it favors that the PMX reduces the mortality in high-risk population of the septic shock. So there are multiple papers. I don't want to go into much detail on these papers. I would highlight to the little literature, published literature on the cytosorb in Indian context. So in Indian context also, whatever little literature we are having, it increases the survival chances, it decreases the mortality, it decreases the hospital stay, it decreases the vasopressors requirement in these patients. And it seems quite safe in our subset of the patient. Latest paper, which was published 6 months back only, where these authors have done a propensity weighted retrospective analysis, where they have concluded that there is an improved survival beyond 28 days up to 1 year after cytosorb treatment for refractory septic shock. So with this, I would like to thank you all for your patient hearing. Let us see what Dr. Farad Kapadia says. Thank you very much.
Good morning, taking part in this debate on the role of cytokine absorption in severe or refractory sepsis. And I'm opposing the motion. I'm saying it doesn't have a role. Now, as intensivists, we do a lot of things for patients. We correct physiological parameters, we monitor them a lot, and obviously we try to save their lives. And we can broadly look at our outcomes in two big groups. One is physiological outcomes like vital parameters, hemodynamic parameters, ventilatory parameters, laboratory parameters. And the good thing about these parameters is we can see it literally on a day-to-day basis or almost in real time. We can see the blood pressure come up, we can see the labs get better, and therefore we think we're doing a good job. But it's much harder to actually know by doing a good job whether you're saving a patient or not, whether you're decreasing the severity of the illness or not. So we need not only to know whether our treatments are working in terms of physiological outcomes at the bedside, but we need to know that they're improving the clinical outcomes, and the three important clinical outcomes are mortality, severity, and recovery. And we can only do this by being aware of what the literature tells us. We can't really do this by just working at the bedside. So let's keep this in mind as we move forward. When we do science and evidence-based medicine, we always start with a hypothesis. And in the case of this particular treatment, extracorporeal cytokine absorption, we need to ask if we are decreasing the clinical outcomes, which are mortality and severity of the illness, or the time spent in the ICU or the hospital. Then we have to make sure that the methods we do are appropriate to reach the correct conclusion. And it should be randomized rather than observational. And having got the whole methods in place and well documented, then we should start the study, we should enroll the patients, then we look at the results, and based on the results, we should decide whether we should use it or not. Now, it's very important that we do it in this order. We first start with the hypothesis, then we come up with our methods, then we come up with our results, and then we go to the conclusion. We can't find results and then find that they don't show what we want and then try some other method to show they are successful. So this is called adjustment, and we really should avoid adjustment. So does cytokine absorption improve clinical outcomes in well-powered randomized controlled trials? It was wonderful to see my close friend Subhash Todi write an editorial in Critical Care Medicine earlier this month or last month, and he addressed this very topic, and he called it extracorporeal cytokine absorption, a storm in a teacup. And I think that's a perfect word, because in the past I thought this whole COVID cytokine storm was best described as a cytokine storm in a teacup, suggesting that it's given far too much importance and it's really not as important as it's made out to be. And it's not as different from any other form of sepsis as it's made out to be. COVID is not as different. So what did Subhash say? He said that sepsis is a dysregulated host response, and it's therefore conceptually appealing to absorb these molecules, and therefore it's worth studying this in rigorous clinical trials. Now, I think this is a slightly simplistic statement. Just because something is abnormal, it doesn't mean it's bad. So for example, if you have a septic patient whose heart rate goes up from 90 to 140, whose ejection fraction falls from 50 to 30%, and whose lactate goes up and has a severe SIRS with raised IL-6, it's not really the best form of critical care medicine to slow the heart rate down with evabrad, to increase the ejection fraction with dobutamine, to decrease the acidosis with bicarb, or to clear the lactate with dialysis. In a similar way, it's not the best form of medicine just to take out the inflammatory in markers just because they're high. An evolutionary based or a survival based approach is much more important. And in this approach, we first ask the question, are these changes we are seeing adaptive? Is the heart rate going from 90 to 40 benefiting the patient? Is the lactate going up benefiting the patient? Or is it a maladapted response which is harming the patient? And the key, once you ask this question, you'll understand that the only way, I need to stress this, the only way to answer this question is with clinical outcome data, preferably in large randomized trials. So what else has Subhash said here? 1 second. Yeah. So he noted that the earlier trials were limited to case series, registers, observational studies, small trials. They looked at historical controls and they looked at surrogate markers, and there was nothing particularly inspiring about it. Then he notes then that an early meta-analysis of less than 500 patients did show a mortality benefit, but when the trials which were done in Japan were excluded, then this benefit disappeared. And this has been a sort of striking feature of the polymyxin hemoperfusion literature, that it appears that one trial in Japan has outsizedly affected the interpretation of this. The two more recent analyses, which looked at more than 2,000 patients, came to pretty much a similar conclusion as the earlier one, that high-quality trials did not show a mortality benefit, and some trials actually showed harm. Trials conducted in the United States and Europe did not show a benefit, and whatever benefit was restricted to a couple of trials in Asia. Older studies showed some benefit, sicker patients had some benefit, but whenever the positive outcomes of the meta-analysis were ultimately negated by trials which adjusted for the small sample size of these RCTs. So there's insufficient data to recommend any blood purification technique today. So that's his comment in general. Now he's giving an additional comment on a paper which was published in the same issue of Critical Care Medicine, which is looking at a specific cytokine adsorption device called the cytosorb. And once again, he noted that none of the studies could show benefit in clinically important outcomes or mortality. And he said it is clear that this is far from satisfactory, but he also suggests it will be unwise to discard an important therapeutic tool in a lethal disease like sepsis. Now, discarding this and using it in sick, dying patients is is not exactly the same thing. When we say we shouldn't discard it, it doesn't mean we use it in desperate situations. It means we use it in well-powered clinical trials and clinical endpoints. So let's quickly look at the actual study. This study started with 300 papers and ended up with just 6, suggesting how inadequate the data is. And of those 6, 4 were cardiac surgery, so there were only 2 left with sepsis. Now, in these 2 sepsis trials, there were 120 patients, out of which 20 were about 120, out of which 20 were one trial and about 100 were in the other trial. And they found very low quality, inconclusive evidence for any mortality benefit, and similar for any side effects. So let's look at the numbers in a little more detail. One study had a higher 60-day mortality, that's 45 versus 26. And they claim it became insignificant after adjusting for comorbidities and baseline variables. And this is what I mean by post hoc adjustment needs to be viewed with a little bit of suspicion. They also noted a similar 28-day mortality, but please note the mortality was 36% versus 18%. So that though it's statistically similar, that's still quite a big difference. The others trial had a pretty much a similar outcome. The organ dysfunction was similar in both the trials. The length of stay was about 10 days in the smaller trial and not reported in the other study. The length of hospital stay was not reported, and there were more side effects, severe side effects and serious side effects and normal adverse events in the intervention group, whether the total number of severe adverse events were looked at or the patients with severe adverse events were looked at. In fact, there were 5 severe adverse events and 8 normal or less severe adverse events purely related to the device. And because the numbers were small, there were no statistics responding. So their conclusion was that the efficacy and safety of extracorporeal cytokine adsorption therapy in combination with standard care in the investigated indications was not established. And they strongly recommend that we need well-powered clinical trials with patient-relevant endpoints instead of further spending money on doing studies which look at which are non-randomized and which look at surrogate endpoints. So I'd like to end by pretty much echoing what Subhash said and what the author said, that in today's world, there is no role for these therapies in day-to-day practice, and it simply adds to the cost, risk, and complexity. If we are going to do it, we should only be doing it in the context of large RCTs with clinical endpoints, possibly because equipoise exists, and possibly as we choose patients better and get our therapies better, one day we will know how to use this device. But that doesn't mean it should be used in very, very severe refractory patients because you have nothing else left to do. Don't get fooled by physiological endpoints. Don't get fooled by poor quality studies. And remember that ultimately simplicity is the ultimate form of sophistication in a critical care practice. Thank you.
Thank you, Dr. Kapadia. So can I have 1 or 2 minutes for rebuttal?
You can have as much time
as
yes, so we have 5 minutes for rebuttal.
Yeah, Dr. Kapadia is one of the, as I earlier said, is one of the most respected person in our society. And we always look, if there is any issue or when we feel we are stuck up, we always look for his advice. But again, here I would like to comment few things, like he is a very purist, he is a very scientific person. He is trained in UK. Incidentally, I was trained in a small place called Meerut, so I am not privy to all this, so many scientific things. But again, I would like to highlight, where do we stand today? Endotoxin and cytokine removal is not the standard of care, no doubt about it. But all septic shock patients do not respond to a standard therapy. So what should we do? Let them allow to die? Sit behind in our big chairs and just think and discuss, wait for evidence. Patient with endotoxin SA more than 0.6, sepsis of abdominal origin with SOFA more than 8, they may be the ideal candidate for endotoxin removal within 8 hours of resuscitation. Despite Euphrates trial negative the effect of PMX, the role has been shown in various meta-analysis and observational studies till date. So endotoxin and cytokine removal is an exciting option in septic shock patients. Available options have still not shown mortality benefit in the trials, but we should look at them as an adjuvant therapy beyond standard of care, no doubt about it. Clinically speaking, the effect of patients have been encouraging with stabilization of deranged parameter. So the idea is, if you are able to stabilize your patient, you can gain some time, maybe a day or two, and by that time, your antibiotic, your source control may work, and you may save your patient. Selection of patient and timing of application is very important. So what should we do when our patient is dying? Just wait for evidence, let him die. Wait for evidence. Maybe evidence will take another 2 years, 5 years, 6 years. Or we can offer something where he can have Doobte ko tinke ka sahara. Thank you very much.
Okay. May I ask Deepak a few questions?
Yes, sir.
Deepak, imagine I use exactly your same argument. The patient is dying, etc., etc. And therefore, should I call Baba Ramdev and use his medicine? And Baba Ramdev charges 1 lakh a day. How would you respond to that?
Sir, many times it happens. It is not the Baba Ramdev and 1 lakh a day, but many times we have to honor the family's wish, and many times they are having wishes to follow certain religious things, certain Gangajal, and many times we also agree to that. So it, it depends on the situation to situation.
Let me ask you another question. A neurological patient is not getting better, and the family is convinced drilling holes into the air will get smoke out of the brain, and that will help the patient.
No, sir,
And
no,
they
sir.
will
But
charge 1 lakh for that.
still, sir, with these mixing, there is some evidence. Some case reports are there. You can say that these are as scanty as the using steroid, but we all are using steroid as well. Steroid is also not having that much of conclusive evidence, but still everybody is using steroid. So
Deepak, do you think this is a safe and cheap option as a desperate measure? Or do you
no,
think
sir, it is not a. It could be a safe, but it is not a cheap option as a desperate measure. I totally agree with that, sir.
Though you saw the number of serious adverse events and you saw the increased mortality, you still think it's safe, despite that the data which Subhash Todi commented on.
Shown, yeah.
Double the mortality. Double the mortality, and you think it's safe.
Yeah, but there are very.
What was defined as unsafe then? How many times should the mortality increase before something is
No,
seen?
but there are very few reports where the mortality is increasing. Majority of the studies, sir, they have not shown any harm by using this device.
Just read this paper now. He's showing it.
Yeah.
Subhash is commenting on it.
Yeah.
I didn't cherry pick this paper. This is the latest paper. I don't know if you read it. Yesterday in my inbox, an ICM letter came out. I've got it on my desktop, which exactly showed the same thing. Now the question here, Deepak, is isn't it possible that these cytokines actually have a role to play? And just because they are high, it is physiologically appealing, but survival wise, it might not be good or bad. And therefore, isn't it a much, much better option, much, much better to do this treatment only in trials? Because, I mean, you know what, a dying patient and a family is not really in a position to make, they're desperate.
Yeah.
So to some extent, just offering them an option so that you can say we tried everything, is that really a very high form of scientific integrity, or is it we are back to the wall and say we tried our best, especially if something is costly and dangerous? I have no issues with giving, high dose vitamins or vitamin C, vitamin B1, all that business. But when something is costly and dangerous, is it really, really fair to ask someone who's not in a position to make anything which looks like an informed decision, that why don't you try this on your loved one? I mean, what you're saying is one side, but you've got to understand there's a power imbalance in this debate. The same person without a relative dying might have a very different answer. So
no, I agree, but
unfair to put it that way.
Yeah, I agree what you are saying, but I would side by side, I would say that since it is a costly, only then we should not throw it away. Like we are using steroid, we are using vitamin C just because they are cheap.
Thank you.
Get away with the danger right now. You can't get away with the danger. Everything is worse in the meta-analysis.
ये डॉक्टर रणदीप सिंह को जरा वो भी कर दो.
So thank you.
Okay, sir. Thank you very much.
Thank you, Dr. Deepak sir. Thank you, Dr. Farad sir, for inviting. And definitely, the sum up is we need more and more evidence before using the therapies. Probably that is the take home from here. We'll move on to the next session. Next session is a panel discussion. Thank you, Dr. Farad sir. Thank you, Deepak sir.
Thank you for inviting me.
So next session is a panel discussion which will be moderated by Dr. Kapil Jirpe sir, and the topic is improving quality of sepsis management in our setting. And our panelists for the day are Dr. Pradeep Bhattacharya sir, Dr. J.V. Peter, sir, Dr. Soren Panja, and Dr. Adinder Kar. Over to you, sir.
Yeah. Good morning. Good morning to the all delegates, all faculties, and all my eminent panelists. Today we are here during the Sepsiscon regarding the discussion on sepsis management, how we can improve the sepsis management in our setting. Generally, we say that it is a resource limited setting, but I personally don't believe in India is now resource limited. We have all facilities, training, as well as the specialists available to manage the sepsis. And all of us know that sepsis is the topic which we discuss since ages, since last 20, 30 years. There are protocols are happening. There are goal-directed therapies are coming up. Still, we need to improve our sepsis management. And unfortunately, sepsis is the still cause of the mortality. It is the third cause of mortality after the cancer and heart disease. And if you see the progress of the sepsis generally, there's a 7.6% drop in chance of the survival each hour until antimicrobials are begun. And this is a reality. We need to understand that the sepsis is still our priority. We need to give him a very aggressive type of the thought process and manage the sepsis. And unfortunately, it is not only mortality. We lot always discuss on various platforms regarding the mortality part of the sepsis, but I always concern about the morbidity also, because there is a cost is involved, there is a pain and agony is involved, there is a lot of stress is involved at the every level, at the patients, relatives, as well as the healthcare this thing. And unfortunately, sepsis is very unpredictable. It's underdiagnosed in almost 44% of the cases. It is underdiagnosis. So with this background, every time we need to discuss about how we can improve the sepsis management or sepsis outcome in our setting. I will start with the very interesting or unfortunate example. Recently, I came across one of the young head injury. He was closed head injury without any polytrauma, improved slowly. On 10 day, there was a one fever spike. We thought probably he never had a central line or intubation. He was managed with the conservatively. Only Foley's catheter was there. And on the day 10th, he had a fever spike. Within 24 hours, he had a high-grade fever, drop in blood pressure, and acute renal failure. So it was septic shock with multi-organ failure. Naturally, we all jumped in, send the cultures, send the blood cultures. We have started the higher antibiotic empirically as per our culture data. We have managed it very well. And after the 30 days, we have discharged him. And then one evening, my team sent the photo with his family happy. Everybody was doing the thumbs up. So I just realized whether it was really things to celebrate, whether I should introspect, whether it is I really should be happy with the result, because this patient on the 10 day was so stable without any cost and the pain. And after 30 days of the huge cost involved, there was a lot of stress in the family, finance involved, and it discharged. So really, I should celebrate this survival, or I should worry about the morbidity and the finance involved? And shall I go back and tell my team that, please, this is not what we are expecting as a critical care specialist. This is not we are expecting in a sepsis. So my overall concern is, it is not only the outcome of the sepsis, it comes of the morbidity and the number of days in the hospital and everything we should consider while we are seeing that we are managing the sepsis. So with this small introduction, I would like to start today's panel discussion about the management of sepsis. So we have the eminent panel, Dr. J.V. Peter, Dr. Arindam Kar, Dr. Pradeep Bhattacharya, and Dr. Soren Panja. No need to introduce, because really everyone knows about their specialty and their work in the sepsis. So we'll go ahead with our discussion. Dr. Pradeep, you are around?
Yeah.
Yeah. So Pradeep, we always discuss, when we start discussing about any outcome, whether it is a sepsis or trauma or any other disease, we always talk about the multidisciplinary team approach and whether it really helps in the sepsis management. Now, let me get your views on what is your views on the multidisciplinary team approach in terms of the management of sepsis in first 1 hour, 3 hour, or 6 hours protocol-based management, whether it really helps in our day-to-day practice in improving the sepsis outcome.
See, Dr. Kapil, thank you for this question. Basically, if you ask me how we differ from sepsis differs from myocardial infarction. Acuity of symptom. The acuity of symptom in myocardial infarction alerts everyone. And that is the earliest sign and on which we actually work as a clinician. But in sepsis, if you say that, is there any early sign? We don't know exactly earliest signs which has been defined after a patient comes to the hospital. Then we try, see some clinical features, some blood tests and some other diagnostic tests, and they say patient is in early sepsis. But the vague symptoms which the patients have before that, and they are always confused. They usually do their home management 2 to 3 days, 4 days at their home, and after that they come to the hospital. By the time when they have come to the hospital, whether that is early or late, we don't know. Probably that is one of the determining factor which decides about the outcome of the patient. Secondly, what you said about the multidisciplinary approach. Multidisciplinary approach is here, it is very important, because as we see a patient, as soon as it comes to the hospital, the first responder is very important. And how much he is mature as far as diagnosing and managing, understanding the sepsis is very important. So the person who is attending the patient first, he should have a very, very clear-cut concept about sepsis. What is sepsis? What are the early signs of sepsis? And at what stage the patient has come to this hospital and what kind of intervention he actually requires. Then immediately, the first line of management he should be able to do with the help of all the nursing staffs as well as paramedical staff. The second important thing, which I said, is the data, recording of data, keeping the data and analysis of the data which were actually taken out from that patient. And once they are entered and they go to the right panel means they go to the right physician or the physician, the consultant who will actually attend this patient. Whether this is a surgical team, medical team, obstetric team, or whatever orthopedic team, doesn't matter. But whomsoever it is, whether a surgical or a medical team, he should be able to understand the signs of early sepsis, or is a patient who has come, he is having severe symptoms of severe sepsis or sepsis, whatever it is. Then another important thing is that the real-time approach of the other persons who will take care of not only giving the medications, but other supportive care, like oxygen therapy. There should be trained person who should actually understand and immediately start oxygen therapy. Communication is very important. Immediately, the junior doctor should communicate with the other specialties, and they should also communicate with their own real senior persons in their own department. They should communicate with the nursing staffs, paramedical staffs. Everyone should become aware about the condition, and everyone should follow the same pattern of management what that patient requires, and that should be kept in the emergency department in the algorithmic manner, and the algorithm should be followed the way we follow for myocardial infarction. So that is why it is said that a very good team approach, inclusive of not only junior doctors, senior doctors, it is also nursing staff, paramedical staff, and other disciplines who understands actually about the sepsis. They should follow the same algorithm. It is not that one person following another person, they say we don't know about this thing, because it can happen with any kind of discipline, whether irrespective of the discipline, the patient can come with sepsis.
Okay,
So
okay, Pradeep. Yeah, Pradeep, I really appreciate with your very nicely elaborating the team approach as well as the protocol-based management and multidisciplinary team and everybody's role. The bottom line is everyone should know their role, what they are made for and what they are supposed to follow. I would like to go to the Arindam Kar. Arindam, you are around?
Yes, sir.
Yeah, Arindam Kar, this is an extension of the previous question to the Pradeep. Is there any evidence that available that achieving the first hour, 3 hour or 6 hours criteria improves outcome? Like we speak a lot about this multidisciplinary team approaches and the various timelines in sepsis. So what's your opinion?
Sir, if you see the evolution of the bundles or the goals that were given, we have come down from 24 to 6 hours, then to 3 hours to 1 hour. Right. So that means that it is mostly time based. So any of these are, as Dr. Peter sir mentioned while we were discussing offline, that there are three components. One is the time, one is the target, and one is the intervention. So we are now reducing we are very strict on the interventions, and we have reduced the complex interventions so that it is much more equitable and acceptable to everyone. And we have now also reduced the time because it's a medical emergency, so that it has to be done within 1 hour. So all the research or the meta-analysis or your surveys and all that, which actually tried to prove not only the compliance to the bundles, but also the outcome when you stick to the compliance, when you increase the compliance, have mixed results. And so that's why it is ever changing. So what we have come after all those trials, particularly the last three trials in and around 2014-15, Promise, Arise, and the third one, the Process, right? We all know that these are helpful, but it has to be in a timely manner. And so if you see, and the standard of care is to serve the basic things very correctly and to the individually. But one thing I need to emphasize is that any bundles, right? The bundles is the composition of 4 or 5 very basic things. To be effective, that all the components of the bundle has to be done. That means all are non-law. We cannot have 3 bundles component done and 2 didn't done. And second, it will give you a uniform and equitable care. But this is a bare minimum thing that you need to do. And it should not do away with an individual clinical judgment, and where your clinical judgment actually predicts that you can deviate and do something on your own. So that's what I want to say. The evidences speaks like that, sir.
Yeah, so most importantly, adherence to your bundle and policies and the consistency is more important, along with the any bundles or any protocols. Right. Okay, Arindam, very nicely summarized in a very short time. Dr. Peter, I would like to come up with the next question. Dr. Peter?
Yes.
Yeah. So it is again, we are now entering into the management part. So we discussed the role of the multidisciplinary team. We discussed the role of the bundles, adherent to the bundles, and the timelines, 1 hour, 3 hour, 6 hours. So now the most discussed thing in the sepsis from 1996 till today is the early goal-directed therapy. And initially we were, it was very popular because it was easy and it was a 1, 2, 3, 4 type of the things you can, anyone can follow in an emergency system and get the results. But somehow on the background of the 3 recent trials, as you know, Arise, Process, and the Promise, there was a question mark over the effectiveness and it's really used in a practice about early goal directive. So will you please would like to explain what it's, whether still we can follow the early goal directive therapy, or in selective patients you can go ahead, or you don't believe on the early goal directive therapy?
First of all, thank you, Dr. Kapil, for inviting me to this very, very important topic. And Dr. Pradeep and Dr. Arindam have formed an excellent platform on which I could build. You're absolutely right. For over 20 years, this whole concept of early goal-directed therapy has been like a pendulum shifting from one side to another. Everybody was excited in the critical care field in 2001 when Rivers et al. Published that landmark trial in the New England Journal of Medicine that showed that early goal-directed therapy improves outcome in sepsis. So there are 3 components that they focused there. It was early, it was focused on achieving some goals, and there were several activities that were planned. But we must also remember at that time, the background mortality of sepsis was relatively high. And over the last 20 years, our better understanding of the disease has changed things. So the initial study by Rivers et al. Did show a benefit. So the question is, why did these 3 big trials show no difference? We'll quickly summarize those 3 trials. Arise was an Australian study, 1,660 patients, which compared early goal-directed therapy versus usual care. Process was 1,341 patients done in the United States, which had 3 arms: protocolized-based early goal-directed therapy, protocolized-based standard therapy, and usual care. And the UK study, which is the PROMISE study, was 1,260 patients comparing early goal-directed therapy versus usual care. Now, if you carefully scrutinize these 3 studies, usual care comprised of measurement of lactate, focus on administering IV fluids, and early administration of antibiotics, which form the core of the bundles. So usual care itself was very well done. So as a result, targeting specific goals through certain interventions like administration of dovitamine or giving more blood did not make a difference. And now with our understanding, we know that administering more blood is not going to help. Maybe use of dovitamine may not really help. So that is the reason why these 3 trials did not show a difference. I go back to this question. Is it activities? Is it focus on goals? Or is the time which is crucial? We'll get the answer at the end. But early goal-directed therapy towards certain goals with the use of transfusion targets and mixed venous saturation targets do not make a difference. Follow the simple goals. I think Dr. Arindam only pointed this out. Do the simple things well. Success lies in doing common things uncommonly well. And that is the key in sepsis.
Okay, Dr. Peter, I always believe on the simplicity and I always believe on the mass appeal. When we say that India is a diverse country, we know that the healthcare is not uniform across the India. We know that the training and the knowledge is not easily available or the uniform across the India. So don't you think the lack of the bundle or lack of the goal about the fluid management will make it more individualized and it may not achieve that success as compared to the Western country in India? See, when these all 3 trials happens in a Western countries where they have the proper system in place. Now I'm worried about the more of the our setting. The topic of the today is our setting. So if suppose my colleagues from the 2-tier or the 3-tier city or from any village, he calls me and asks me about the fluid management part, how I should guide them?
So it's a superb question, because what works in the Western setup where everything is so well streamlined may not work here. I want to go back to the 3 components that were looked at in the NEJM trial. It's a very large trial of, I think, 49,000 patients in 149 hospitals, which I think Dr. Arindam or Dr. Pradeep alluded to. Now, what they found was that early administration of antibiotics within an hour after a blood culture was one factor which improved outcomes. The second factor that improved outcomes was attention to the bundle. So what is happening is if a clinician stays with a patient for the first 3 hours, ensures that the 30 ml per kilogram of fluid resuscitation happens, and some very simple goals are met. I think that is the key, as you pointed out. We don't need to go for complex goals like mixed venous saturation. I think you're absolutely right. In a country like India, simple yet targeted outcomes are important.
Okay, thanks, Dr. Peter, for summarizing in a very simple way. But I think this question will go around and it needs the more broader discussion on this particular subject. So we'll move on with the, now next is Dr. Sauren Panja. Dr. Sauren, you are around?
Yeah, Dr.
Yeah, Sauren, up till now we discussed the multidisciplinary approach. We discussed the first 3 hours, 6 hours. We discussed the early goal directed therapy. And everywhere we understand that there has to be the team approach. There has to be the time is the goal. One need to follow the time as early as possible. Though I always believe that the 3 hours are broader guidelines as early as possible. Might be the, if the antibiotic available within 5 minutes in the emergency medicine system is more this thing rather than I have 1 hour, so I should wait, something should not be done. So like in trauma, there is a golden hour concept. In stroke, there is the stroke code timelines, who will see at what, and there are the various very clear guidelines and we need to follow them. What is your opinion about the such rapid response team, like a golden hour concept like trauma? Will any make a difference in sepsis management? Because I always see in my multidisciplinary hospital, when there are the 5-6 buildings are there, casualty in the one building and the critical care are on the building number 5. And probably in that crowd, it may get, we are lacking in ownership. I always believe on owning the patient. When any patient comes to the emergency department, we should owe them. So what's your quick opinion about a rapid response team and its role in management of the sepsis and improving the sepsis?
Dr. Kopil, already we have discussed about the certain activities in relation to the sepsis or diagnosis. From the diagnosis, then after diagnosis, some of the activities had already been mentioned and how the flow goes on. And also Arindam and Dr. Peter has mentioned about the time also. So if we take it that a principle of timing, so it is the utmost need that that should be a rapid response team. Because from the diagnosis or the suspicion of the sepsis to maintenance of the sum of the basic data to formulate as well as to analyze whether my patient is, I am dealing with sepsis, then after that we should intervene. And intervention in terms of both the sum of the activities that will go parallel with the diagnosis, that is the certain culture, blood report, as well as the basic diagnosis, whether if my patient is sepsis, that patient needs only medical intervention or a multidisciplinary team approach, along with some surgical intervention or the source control is necessary. That is a very important. So that's why this rapid response team is basically to aim at the reducing the time of this whole flow, as well as to involve or engage other stakeholders like surgeons, the infection control practitioners, or sometimes the other team members like a nephrologist, or if I reach that my goal has been reached, so then other team may get engaged into the taking care of that patient. But definitely, as already you are discussing one thing in our country, that all the facilities in different level of care, say primary, secondary, it may not be there. But I think in that aspect, there must be some nursing or para medical staff. They can be trained little bit, and even without the fancy testing or sometimes the lactate measurement, as already we have seen in the some evidence, the lactate has not improved the outcome. Rather, whatever Dr. Peter has mentioned about the early diagnosis, then giving some antibiotics at the timely fashion, as well as the fluid resuscitation, that is the important, and that can be done with a basic rapid response team. So here is the system that is very important, and that system, I think, with some manpower can be created at different type of hospitals. So that way it can be helped.
Yeah, thanks, Sauran. Pradeep, just quick answer regarding when we talk about a rapid response team, and we don't have a luxury of the emergency medical physicians or the trained intensivists to go to the casualty and manage the sepsis part. What's your opinion if we have a nurse-driven screening tool or management protocols, and we train our few very selected smart nurses to pick up the sepsis and start the early treatment? What's your opinion about the nurse-driven screening tool and management protocol to improve the sepsis outcome in our setting? Pradeep?
Yes, am I audible?
Yeah.
Yes, hello?
Yeah, please.
Am I audible?
Please. Yes, yes, please go ahead.
So that is the best thing, what you are saying, that can be done as far as our country is concerned, because we have huge number of patients for every hospital, wherever we go. And a nurse-driven screening protocol, they should be provided with simple palm tops, and they will just enter some of the data as soon as the patient comes to the emergency. And that should also contain some warning signals. Okay, if you are entering this data, if it goes beyond this or if it is less than this, then obviously there has to be some problem and you need to inform. So a computer-assisted screening algorithm, if it is provided to the first liners or the nursing staff who are first responders to the patient, even if a doctor is not there, and if they get some kind of automated suggestions out of that, definitely it will improve the outcome of these patients as far as early intervention is concerned. As you said, it is give apart 1 hour, give apart 3 hours, give apart 6 hours. Why not 5 minutes? Why not 10 minutes? So that is why If a nursing or the first responder who attends the patient and he immediately notes everything on the palm top and the palm top guides her as far as an algorithm is concerned, it is as she manages the patient, then immediately, obviously, the care will be much better, what I understand. But that needs a vigorous training, and we need really smart nurses whose IQs are really as far should be better as far as our nursing standard is concerned. They should have a good IQ. They should be able to handle, as you said, the ownership. They should have that attitude of ownership. Then only these things can be implemented.
Thank you, Pradeep. Arindam, you
Yes,
are
sir.
expert. You are expert in the next question. I am sure you are waiting for this question. See, when we talk about the nurse-driven protocols, when we talk about the computer-assisted screening, whether your automated suggested sepsis-specific orders outside, if you are trained with the computer and you are just feed them that key, once you pick up the sepsis, the automatically regarding the management of the resuscitation or the initial resuscitation, choice of the antibiotic as well as the goal-directed therapy. If we do it through the automated suggested sepsis specific order sets, whether it is going to improve. I know this is very ambitious. I know this is not easily possible when we are talking about the 2-tier and 3-tier cities, but at least at the tertiary care centers, it is possible.
I think can be possible, sir. We taking this cue from the O'Keefe and the Get Food study. In fact, in Reliance, we have started the sepsis pathway, which picks up with a screening tool and the protocol. Then it gives a sepsis alert, and then we have specific orders, as you have said, both for the workup, for the resuscitation, for the choice of antibiotics, as well as the goal-directed or the target-directed therapies. And we are getting quite a good aim. Not only the compliance has increased, and we have had in the interim analysis, we have had almost around 2% of drop in the mortality itself. So it's doable in the tertiary setup through artificial intelligence. But I would also add that in a resource limited setup, we need to improve the human intelligence. And this can only be done with performance improvement initiatives, particularly the thing exactly you are doing, sir, that is awareness and education. So I think a combination of both AI and human intelligence can bring in more awareness and more abrupt, active interventions at the bedside at the timely manner.
Yeah, thanks. Very nicely elaborated. Dr. Peter, human intelligence, what Arindam is saying. You always strongly believe on early and focused intervention. Though we have the set guidelines, though we have the set protocols, though we are adherents to the guidelines and we are following the guidelines, what you say, the one thing is the whole protocol and intervention, whatever the protocols and guidelines and policies, multidisciplinary. On the other side, the early and focused intervention. So how you will weigh them? We have a few minutes left, so I expect the very precise answer.
Sure, sir. I would focus on 3 terms.
Yeah.
Early. How early is early? And the panelists actually elaborated it quite well. The NEJM study said less than 12 hours is better than more than 12 hours. The same study showed less than 3 hours is better than more than 3 hours, and still less than 1 hour is better than. So time is tissue. Early is as early as possible. Push the boundaries. Identify early. Second is focus. What do we focus on? So what is the source of sepsis? How do we identify it? How do we take appropriate cultures as quickly as possible? Get the first dose of antibiotics in. You beautifully said, if it's 5 minutes, let it be done in 5 minutes. The second focus is on organ perfusion. Do a quick assessment. Is the person clinically well perfused? If not, you find out what is the organ dysfunction. Send off a quick lactate. So these are the focus points at the bedside. Identification of sepsis and its approach, perfusion. Third is goals. This is where we have problems. We don't have clear-cut goals. I think we need to look at it as a society, look at what could be the macro circulatory goals. Do we target a heart rate of this much or a blood pressure of this much? Do we have some microcirculatory goals? We know that lactate is not very good, but it's a reasonable parameter. SCO2, VO2 has been a flop. Can we look at other markers? So my point is early, focused, goal-directed.
Okay. very nicely summarized in a very short time. Sauren, you would like to add anything to early and focus intervention? So then we can summarize the things.
As already Dr. Peter mentioned, I will reiterate the same thing, that whatever we have discussed till now, that can be done without much of the kind of technology or anything resource. It is very resource that is the important is human resource. That is what we can develop in ourselves, and that is the awareness, education, and not only that, we are carrying with the smartphone. That smartphone tool can be generated. Anyone can get that, apply that tool. That okay, these are the factors and these are the blood pressure parameter or vital clinical parameters. From that, there will be a final result that this patient might have sepsis, and then there should be in a smartphone that is a flow that what is the type of sepsis, and just check the lines or check the urinary catheter is there or not. If that is the type of the thing we can develop even in our country also, a very small approach, but that smartphone driven approach can be done, and it is also a miniature form of artificial intelligence that can be applied finally to apply in our primary, secondary healthcare with some motivated people who are really passionate about this. That can be done successfully.
Yeah, thanks, Sauren. And we are now coming to the end of this very informative panel discussion. And I'm sure this 30 minutes will give us a good idea about the sepsis management in our setting and how to improve that. To summarize, I first say that the sepsis is still challenge in our country, and not in resource limited. It is challenge in the Western countries also. Multidisciplinary approach definitely will going to help, but provided that you should have the system in place, and you should have the role allotted to the everyone, what your nurses are going to do, what your juniors, what your seniors, and how you can play part, and how you can maintain the harmony amongst them in a focus way. Rapid response team might be the solution, but still it needs to be the evolve in the right way, in the right with the right timelines, and follow it meticulously. Nurses driven screening tool as well as the computer assisted early sepsis pickup science and their guidelines is the future. But Arindam was very particular regarding the AI. He don't want to bypass the human intelligence. At least in the resource limited countries like India, we should not bypass our human intelligence. We have a huge backup is regarding that. And like Dr. Peter says, the early focus and then clear-cut goals. This is very important. We should have the clear-cut goals rather than giving a just goal-directed therapy. It doesn't mean anything. And with the smartness of the Sauren Panja, he said the utilization of the smartphone in a right way, at the right place, in a right person's hand makes the difference. With this discussion about how to improve the sepsis management, I really appreciate all of you appear on this day, and you provided your valuable time and participate with your expert opinion. On behalf of the Sepsis Forum, I take this opportunity to appreciate you as well as to say thank you. Thank you.
Thank you, sir.
And have a good day.
Thank you, Zilpe sir, for moderating the session and taking us through the quality of sepsis and improving its management, making us more smart with the approach. Now I request Dr. Deepak Govil sir to take us through a case to learn more on sepsis and its management. Over to you, sir.
Afternoon, we are going to discuss a case about the refractory septic shock. My colleague, Dr. Anant Vikram Pachisia, will be discussing this case, and we'll be discussing question answers in between and at the end also. Dr. Anant, please start.
Thank you, sir. So today we'll be discussing a case of refractory septic shock. So we'll start away with the case. We had a patient who was 45-year-old male who was admitted outside initially with the alleged history of gunshot injury, where he was evaluated and found to have pneumoperitoneum, for which exploratory laparotomy was done with the jejunal resection and with the primary anastomosis, primary repair of the ascending colon with double barrel ileostomy. He was subsequently extubated but had to be re-intubated in view of worsening respiratory failure. He also developed during the stay, he developed shock with AKI multi-organ dysfunction. He received 2 sessions of dialysis. Because of his progressive worsening, the family decided to shift him to Medanta. So he was airlifted to us on post-op day 3. He had already received meropenem, colistin, teicoplanin, moxifloxacin, and capsofungin at the previous hospital. So when he arrived at ICU, he was sedated with midazolam. He was already on 0.6 mics of noradrenaline with 3.6 units of vasopressin. He had tachycardia, MAP was 96. Lactates were in respectable range. On 2D echo, his left ventricular function was normal. His LVOT VTI was 17.2 with minimal variability. And also IVC distensibility index was less than 18%. However, his ventilatory parameters were poor. He had an FiO2 of 80% with PO2 of just 54, PCO2 of 59, and pH of 7.32. We did his bilateral lung ultrasound and we found straight sign bilaterally in zone 4, right more than left. In his investigations on day 1 in our ICU, hemoglobin was okay. TLC was in acceptable range. He had thrombocytopenia. Creatinine was slightly elevated to 1.9. Bilirubin was 3.9. OTPT were again in acceptable range. He had elevated procalcitonin CRPs. His coagulation profile was okay. His urine RM and NCCT brain were again within normal limits. So we had started him initially on piperacillin tazobactam and metronidazole combination.
So at this point, Dr. Anant, I would like to ask one question. The initial resuscitation in septic shock, should it be based on surviving sepsis 1 hour bundle or advanced hemodynamic monitoring? What is your thought on this?
Yeah. So if we look at the surviving sepsis 1 hour bundle, which has been proposed recently, the level of recommendation which is provided in these guidelines are very poor. And especially if you look at the resuscitation part, the quality of evidence is low. So a prescriptive fluid bolus amount does not, cannot consider the patient's individual needs, and in patients with comorbidities, it may be potentially deleterious. And studies have found that at least only 40% of the patients in our ICU may be fluid responsive. And now we have ample data which suggests that increased fluid overload or cumulative fluid balance leads to more morbidity and mortality. So it is better that we separate the patients who are responding to fluid boluses, that they have increase in stroke volume with fluid bolus, than those who are not responsive, and thus avoid unnecessary fluids and their adverse effects. So this was a systemic review and meta-analysis which was published in Critical Care Medicine in 2017, which assessed the fluid dynamics, dynamic fluid assessment. And what they found that the patients who had received fluid by dynamic therapy had a better survival rate compared to those who had received the usual care. So dynamic therapy is better. This is another more recent trial which is published in 2020. It is an RCT, where they have compared the fluid assessment between the two groups by using the PLR. And again, they have found that the fluid balance was better in patients who received fluid with PLR. Length of ICU stay was less. Number of days with ventilator use was again less. Also, they required less renal therapy and ventilator use. So if you are giving fluid to a sepsis patient, a dynamic fluid therapy, fluid monitoring and therapy should be better if you have it. You should do it rather than giving a prescriptive bolus of 30 mLs.
So now another pertinent question is there. It's a very important question. The choice of empiric antibiotics in the patient with high infective biomarker or shock. So should we use carbapenem as a first line drug or should we reserve it for later stage? What is your take on?
So the Surviving Sepsis campaign in 2016 has defined empirical antibiotic as the initial treatment that should include a broad spectrum antibiotic alone or in combination that has activity against all likely pathogen. It should be based on the epidemiological and host risk factor, severity of illness, likely site of infection, probability of an MDR organism, whether the disease is community onset because of the long-term exposure or hospital onset. If we are looking at the host factor, we should look for recent infectious exposure, evidence for pertinent colonization, comorbidities, indwelling catheters, what is the immunological status, and if he has had any antibiotic exposure in the last 3 months. And also up to 14% of the patients globally and more than 40% patients in Asia are said to be colonized with the beta-lactamase enterobacteriaceae group. So, and the studies have also again found that if the colonization with these bacteria are more, the chances of infection with this subgroup may be more. So now the question for empirical antibiotic comes, should we give a combination or a monotherapy? So again, the surviving sepsis guideline 2016 suggests that we should give empiric combination therapy using at least 2 antibiotics of different antimicrobial classes aimed at the most likely bacterial pathogen for initial management of septic shock. But the problem is, again, the quality of evidence is very low. So this is a meta-analysis or regression analysis which is published in Critical Care Medicine in 2010. And what they found that patients who received combination therapy in the subgroup of shock or they were critically ill, they had better survival compared to the patient who had only monotherapy. Also, this RCT, which was published in 2012 in JAMA, where they compared meropenem monotherapy versus meropenem with moxifloxacin, they have again found that there was no mortality difference in the combination therapy. So it, and also the length of ICU stay was not different. So still it may be difficult to suggest at this point whether to continue with the combination therapy or monotherapy. But the combination therapy has been advised by SEC because they suggest that it may decrease the development of resistant, and at least one of the components of the combination therapy may be it may be susceptible to the bacteria which is present. So as of now, we can continue with the combination therapy for empirical, but as soon as we have our culture report, we should narrow down to the sensitive drugs. As far as the carbapenems are compared for the first choice for empirical therapy, this is the famous Merino trial, which was published in 2018 in JAMA, where they compare the effect of piperacillin tazobactam versus meropenem on 30-day mortality in patients with E. coli or Klebsiella in bloodstream infections and ceftriaxone resistance. So this was a non-inferiority trial, but the piperacillin tazobactam was not able to achieve the p-value for non-inferiority. So we can use piperacillin over meropenem over piperacillin tazobactam as an empirical therapy. A more recent study, which is published in March 2021 in the CHEST, which is a meta-analysis and systematic review of carbapenem antibiotic for empirical treatment of nosocomial pneumonia. What they found was that carbapenem-based empirical regimens are associated with lower mortality compared to non-carbapenems. However, the mortality effect was not observed in patients who had high disease severity, and those were not associated with Pseudomonas. Also, this mortality difference was mainly observed in patients who had ceftazidime in the control, that is a third generation cephalosporin. So if we compare cephalosporin with piperacillin tazobactam with carbapenems, the carbapenem may be a better choice to start as a first-line therapy compared to the other two classes which are more commonly used. So coming back to our case, his day one stay in ICU, he was resuscitated with IV fluids, his vasopressors were tapered off. He maintained a urine output of more than 1 ml per kg per minute and continued to remain hypoxic after 2 hours of lung protective ventilation with a PEEP of 14. So his PEEP was titrated to best FRC and positive end expiratory transpulmonary pressure by esophageal catheter. His oxygenation improved, his PF ratio was more than 200 after 4 hours, but he continued to have high-grade fever. His ET gram stain came as gram-negative Coccobacilli, and his antibiotics upgraded to meropenem 2 grams stat followed by 1 gram IV 8th-hourly. On day 2, he was still febrile after starting on meropenem, and his CT chest and abdomen were done. There was no leak or collection in the abdomen, but his lungs showed pneumonia primarily on the right lower lobe. Subsequent stay from day 2 to day 6, he continued to be febrile despite the antibiotic therapy. He was agitated and was requiring sedation, but his stoma output was high. And he had already been started on enteral feeding. Renal function, however, had improved. However, because of the, again, persisting febrile episodes, he was started on colistin and ceftriaxone sulbactam sodium EDTA combination on day 4. We had his culture reports from the ET secretion, which showed XDR Klebsiella, which was sensitive only to fosfomycin and colistin.
So at this juncture, I would like to ask another question. The antibiotic, what should be the antibiotic therapy in XDR gram-negative organism? And should we add empiric antifungal at this point of time? What is your take on, or what evidence says?
So XDR organism is defined as organism which is non-susceptible to at least one agent in all but two or fewer antimicrobial categories. Basically, the bacteria isolates remain susceptible to only one or two categories. So the most common drug which we are using for these are the polymyxin, which is a standard practice from over the past decade, where we have been using colistin or polymyxin in combination with at least one other agent of different class. However, recent trial where they compared colistin versus colistin plus meropenem for treatment of severe infections by carbapenem resistant GNBs, what they found that the clinical failure and 28-day mortality were not different whether we are using combination or monotherapy. So a monotherapy may be adequate with the polymyxin subgroup. Next drugs that we can use are the TG-cycline and minocycline. So TG-cycline generally not recommended for bacteremia because of the bacteriostatic activity and low steady state concentration in serum at the current dosing recommendation. So there is a lot of talk about double dose or high dose TG-cycline. So this is again a meta-analysis which was published in Medicine journal in 2019, where they studied the efficacy and safety of high-dose TG-cycline for treatment of infectious diseases. And what they have found is that overall mortality was better in the patients who had received high-dose TG-cycline. And also, if they look at the individual disease subgroups, that is the VAP and nosocomial pneumonia and intra-abdominal infection, again, the patients performed better with high-dose TG-cycline. But if you look at the bloodstream infection, the results were not as good as the other subtypes. Next drug is the minocycline, which is an old derivative of tetracycline, has been rediscovered as an agent for its in vitro activity against the carbapenem-resistant Acinetobacter strains. However, it is not against the CRE as TG and has no activity against Pseudomonas. And also the data which is coming for minocycline is mainly from the case series, and RCTs and larger studies are lacking. Relatively new kid on the block is the ceftazidime avibactam, which is highly active against the KPC producing CREs, but does not inhibit the metallo-beta-lactamases such as the New Delhi metalloproteases, and also is not active against Acinetobacter and Stenotrophomonas. The fosfomycin, the good old drug which has been used orally for years, is active against the majority of CRE and carbapenem-resistant Pseudomonas, but again is not active against the Acinetobacter and Stenotrophomonas. Also, there is uncertainty about the IV fosfomycin, whether the monotherapy is efficacious in treatment of systemic infections other than complicated UTI and pyelonephritis. So it is preferable to use fosfomycin again in combination. Other drugs which are mainly still not available in India, like ceftazolone, tazobactam, which have up to 89% activity against the carbapenem non-susceptible Pseudomonas, veverbactam, meropenem combination, and plazomycin, which is an aminoglycoside, again, which are active against the KPC group, but not active against the NDMs, and also the combination of imipenem celastin with relebactam, which is again not active on the class B and D of beta-lactamases. Cefiderocol, however, is slightly different as it covers all the classes of the ambler beta-lactamases. So, and also the coverage for gram-negative range from Enterobacteriaceae to Pseudomonas, Acinetobacter, and Stenotrophomonas. Now coming to the second question of empirical antifungals, the risk factor for invasive candidiasis are major abdominal surgery, necrotizing pancreatitis, immunosuppression, use of broad spectrum antibiotics, central vascular catheters, candida colonization. We can also use the candida score or the colonization index to stratify the risk for the patient for invasive candidiasis. So what IDSA says is that empirical antifungal should be started as soon as possible in patients who have the risk factors that you have discussed and who have signs of septic shock. But again, the quality of evidence is moderate. empirical trial which was published in JAMA in 2016. And what they found was that whether giving micafungin for empirical treatment, the patients did not improve. So whether if even the colonization index was more than 0.5 and score was more than 0.3, more than equal to 3, the patients did not have a better outcome compared to the placebo versus micafungin. So is this the final nail into the empirical antifungals? Maybe still not, even further trials may just be needed. But till then we can, if we have a patient with new onset sepsis with unknown origin or is having persistent signs of infection after a hospital stay of 7 days and despite broad spectrum antibiotics, we can look for the host risk factors. And if they are present, we can consider invasive candidiasis, send for blood cultures and initiate antifungals, preferably with echinocandins. And just if the culture reports are negative after 70 to 96 hours, we can just stop the antifungals. So after this, we are coming back to our case. We are still at day 2 to day 6. At day 5, he had fever spikes, which was still persisting. Antifungals had been added by now. That was micafungin was added. There was pus from his midline wound, and which was having GPC, so teicoplanin was added. His CT abdomen was repeated and showed no collection or contrast leak. However, the pus wound culture came back as enterobacter, which was sensitive to colistin and fosfomycin. By this time, his renal function rapidly worsening and creatinine increased to 2.9. We had done fluid assessment again, and he was found to be equibalanced and had already received intermittent fluid boluses. By day 6, changing antibiotic and adding antifungal, his fever spikes reduced and he was extubated and put on HFNC. By day 7-8, he was doing well on HFNC. However, his renal function continued to worsen. So colistin was discontinued and he was started on fosfomycin. However, there was no still improvement in renal function, and he had new onset high-grade fever on day 8. So cultures were again repeated and the sensorium had again worsened.
So at this juncture, I would like to ask you, in a patient of this type who is having increase in the creatinine or decrease in the renal function, it could be because of two things. It could be because of worsening AKI, or it is a worsening sepsis because of the XDR, Klebsiella, and Enterobacter, or colistin-induced nephrotoxicity. So there could be three possibilities. What do you feel is the right choice, the right possibility here? And another question, should we continue colistin or stop colistin? Colistin doses in patients with MDR, XDR, gram-negative sepsis and worsening, whether we should do renal dose modification or not. And should we switch to polymyxin B? What is the evidence? Can you highlight?
Right, sir. So this was an article which was published in Clinical Journal of American Society of Nephrology, where they looked at attributable risk course of colistin-associated acute kidney injury. They had 150 patients which were exposed to multi-drug resistant pathogens, and the intervention included colistin versus antibiotics and median follow-up of 7 days. And colistin had more AKI at 72 hours and significantly more AKI again at the end of the follow-up. So colistin is associated with substantial excess AKI. So as far as the colistin dosing is concerned, this was the international consensus guideline which was published in 2019. And they said that for colistin, the loading dose should be 9 million units, which should be infused over 0.5 to 1 hour. And the first maintenance dose should be given after 12 to 24 hours. And again, for the maintenance dose, it should be divided into 2 doses, that is 4.5 million units 12th hourly over 0.5 to 1 hour. Renal dose modification has been advised by the guidelines. This is the chart which we can follow. And they recommend that to target a plasma concentration of colistin of 2 milligrams per liter, if the patient is on SLED, that 10% of cholesterol sodium should be added to the baseline daily dose per 1 hour of SLED. And for CRRT, they are recommending higher dose, that is 6.65 million units every 12th hourly. As far as replacing polymyxin for colistin is concerned, this was again a systematic review and meta-analysis published in 2017, where they compared colistin versus polymyxin for the treatment of multi-drug resistant gram-negative infections. And they found no significant difference in unadjusted mortality between the patients who were treated with colistin or polymyxin. Also, both the unadjusted and the adjusted nephrotoxicity was more with colistin. So we can definitely change over to polymyxin from colistin. Coming back to case, now we have reached day 9. There is still no improvement in shock. We have given him hydrocortisone, initiated advanced hemodynamics. His SVRI was very low, that is 583. Echo was again repeated. His LV was still normal, but he was hyperdynamic. His cardiac output was also 8.8.
This point, I would like to ask you, what defines refractory septic shock? Should it be dose of vasopressors or should it be based on duration of the shock? And how to evaluate refractory septic shock patients? What is the evidence?
So there is no consensus definition for refractory septic shock. It has been variably defined as the presence of hypotension with end organ dysfunction requiring high dose vasopressor support, which is often greater than 0.5 mics per kg per minute of epinephrine or their equivalent. However, if we look at the definition, it should be that time is more important compared to dosing. Because if the shock is going on for a longer time, there will be more tissue oxygen debt, less of CO2 clearance, and this vicious cycle will go on and which will further worsen the patient. So if you are able to control it early, this vicious cycle might just stop. So time may be a better factor to define refractory septic shock than the absolute dose of a vasopressor support. As far as evaluation of refractory shock is considered, apart from the usual cultures and the markers which we send for sepsis, if we have availability of advanced hemodynamic monitoring, we can go for those, especially the thermodilution technique, as we can look for the extravascular lung water, and we can look for what is the vasodilatory state, cardiac output, if the patient is fluid responsive from the stroke volume variation, etc.
Now the next question arises. What should be the catecholamine sparing strategies in refractory septic shock? What is the role of steroid, thiamine, vitamin C?
So numerous therapies have been suggested as potential for sparing the catecholamines, which range from hydrocortisone to methylene blue, which is more extensively studied in the cardioplegic patients, ascorbic acid, thiamine, terlipressin, and angiotensin 2, which has a very promising outcome from the Ethos 3 trial, which is published by Dr. Khanna and his team. So if you look at the steroids now, it's been now nearly 20 years where clinicians have debated over whether to treat septic shock with steroids or not. And the latest RCTs which had come for steroids were in 2018, that was the adrenal and the approaches. So if you look at the adrenal trial, what they found where they compared hydrocortisone 200 milligrams with placebo for 7 days, and they found that the 90-day mortality was not different, but the median time to resolution of shock was definitely less in patients who received hydrocortisone. If you look at the approaches trial where they compared hydrocortisone plus fluorocortisone to the placebo, they found that the primary outcome, that is death from any cause at day 90, was less in patients who received steroids. Also, a meta-analysis has come after these two trials, which includes these two, which is published in JAMA. And they again have found that a steroid reduced mortality at 28 days. So jury is still out whether steroids lower mortality in septic shock in patients, but multiple trials shown that steroids shorten the duration of septic shock. So they can definitely be used in patients who are having refractory shock. So as far as the vitamin C hydrocortisone thiamine combination, which is the famous Merrick protocol, as we all know, is considered. This was a trial published in JAMA 2020, the vitamins trial. Maybe has the final blow to this combination, where they found no survival benefit when they are using this combination with the hydrocortisone alone. So maybe further trials may be needed for this combination, but as of now, the current evidence that we have, hydrocortisone alone is as good as this combination. So coming back to our case, we are still at day 9. Patient was not improving, so we had sent endotoxin assay, which came as 0.8. His cytokine panels were also sent, as IL-6 level was 17,000. So we started him on here, toremixin hemoperfusion, which was connected to CRRT, and he received 1 session of that.
Now the question arises, in a patient with high endotoxin assay and increased IL-6, which is the preferred extracorporeal blood purification technique? Toremixin versus cytosorb versus a new device is there, Alteco. What would you like to choose and why? And what is the role of IVIG? Is there any role of IVIG at this point or not? I know these are the gray zones. We don't have got any clear-cut answer, but still I would like to hear from you.
Right. So till date, there is no conclusive evidence has emerged for routine use of any of these modalities as an adjunct to standard sepsis care. Apart from the UFAS trial, both Euphrates and the Abdomix trial for toremixin have not shown any mortality benefit. So as for cytosorb, especially the studies in sepsis are still not to give too much evidence. So with the limited evidence, the therapy should be individualized to patient-specific needs and the resource available. So whatever filter you have, if the patient's both level are high, you can definitely try, as the patient is already worsening. There's no harm in trying it. And if you're using toremixin, we can look for the EA levels, which we generally do our at center. You can send for EA levels, and it is between 0.6 and 0.9, which is, this is from the data is from Euphrates trial. We can go for toremixin filter. As far as role of IVIG is concerned, there are multiple meta-analyses, including that for pentaglobulin, have shown that use of intravenous IVIG in adult septic patients may have a rationale and seem to be associated with reduced mortality. But the treatment effect generally tend to be smaller and is less consistent. So the available evidence is still not very clear, and more studies and more data is needed for a widespread use of IVIG in treatment of sepsis. So coming to the our case again, so we have given him toremixin filter. He is on CRRT. After 48 hours, his vasopressors have stopped. His SPRI is improved, but he is still anuric, continues to be on CRRT. He continues to be febrile, is on controlled ventilation, still drowsy, but arousable following simple verbal commands. The repeat cultures which will send again show XDR Klebsiella, which is sensitive to colistin and phosphomycin.
So the another question, we discussed a lot about the choice of antibiotics and different subtype with the Ambler classification. The role of subtyping of organisms is important or not? And treatment strategy for persistent XDR Klebsiella despite 10 days of appropriate antimicrobial therapy, what should we do in such cases? This is a common problem which we face day-to-day basis.
So subtyping of organism in the present era is very important, as we can look at the beta-lactamase class, which the bacterial subtype is producing, and we can modify an antibiotic to according to the profile which we have, especially the NDMs, which are the most common beta-lactamases being produced in our part of the world. So the combination generally which we are using for NDM producing XDR bacteria are ceftriaxone, sulbactam, EDTA, and Aztreonam, avibactam. The data from for the ceftriaxone, sulbactam, EDTA is mainly originated from India, but they have shown good activity against the MBLs. As far as this Aztreonam, avibactam combination is considered, see the Aztreonam has good activity against the MBLs, but it lacks the activity against the other beta-lactam classes, while avibactam not active against NDMs, but is active against the other classes. So if we are combining the two, we can have the entire coverage. So and also the bugs generally which we have NDM have other genes also positive. So this might be just a good combination. This specific combination is still in phase 3 trial, and Pfizer is doing it, and we might just get this drug soon. So till the time we don't have this specific combination, we are using ceftazidime, avibactam with Aztreonam. So ceftazidime is generally just additional drug which we are giving because we don't have this specific combination. And the combination has also been recently approved in 2020 by IDSA for the CRE infections outside of urinary tract. Also, there are multiple studies and there is very good data about the in vitro activity of this combination. So coming back to the case, we have given him toremixin, he's still not improved. On day 3, vasopressors have again increased. He has multi-organ failure. Here TLC is increased to more than 30,000. He's having coagulopathy now. He's unconscious, continues to be febrile on ventilator support and CRRT. With progressive worsening, he has cardiac arrest on day 15 and could not be revived. So this brings to end of our case.
Despite of doing so much, we could save the patient. So it's again it gives a very sense of low feeling that despite of doing everything, nothing can be done. But again, this is a case, can't help it. Nobody can fight with the destiny. With this, there is an end of this presentation. Thank you very much, Dr. Anand, for covering every aspect of the this type of patients and this type of septic shock. Now the session is open for question and answer. Thank you.
Thank you, Deepak sir, for a nice and elaborative taking into stride all the aspects of the sepsis and managing a refractory septic shock. Now I invite Dr. Yatin Mehta sir for an inauguration program. Over to you, sir.
Good morning, everybody. Namaskar. Happy Ganesh Chaturthi. I think it's a pleasure to start this Sepsiscon annual event. I think it has become a very important academic event of the year. It's going to be recurring every year. And I must thank Dr. Zirpe and Dr. Subal Dikshit, along with all the EC members for having put this program so quickly. In I think a month's time, we have put this together, confirmed all the national and international speakers. So I think the content is very good. Last year also the meeting was very well appreciated, and I'm sure this year also it will be the same. Also, I must emphasize that this is a non-political academic association which we have. We are going to run it by consensus, and the only goal is to improve academics and research in sepsis, whichever sepsis form it may be. So I think this year's goal, which we have finalized in several EC meetings, is that not only shall we have the annual conference every year, similar time, corresponding with the World Sepsis Day, but also we'll start having regional meetings very soon now. From next month onwards, you will see that, and where we'll involve the local faculty along with the national faculty. Also, we are going to have a regular newsletter, so you can see what you're doing. The registration fee, we have kept minimal, just as a formality, because we need to do that. And also the membership fee is also very little, so that we are not interested in the monetary input from the members, but just for participation. And we require to do that for continuing the registration of the society. So I think everybody working together, the society has come up very fast in 1 year's time, and I will hope that we'll continue to do the same. Thank you very much, everybody. Thank you.
Hello, Kapil.
Yeah, Kapil.
I think Kapil is somewhere. So I will take over from the Dr. Yatin Mehta. Myself, Dr. Jirpe. I am a secretary of the Sepsis Forum. And as Dr. Mehta sir is already brief about the Sepsis Forum, its activity and the future activities. I echo with the same, and I am sure Subal and our whole governing council, we are thinking on the same line, and our whole purpose is to spread awareness and doing a lot of training and education about sepsis across the country and globe. I must say that what Dr. Mehta mentioned is very right. In a very short time, over a period of the 1 month, we have decided to go ahead with this second annual event. And I take this opportunity to appreciate and thank each and every member of the governing council, as well as those who helped to make it reality. And the front line or the major boosters are our scientific program chairman, Dr. Todi and Dr. Samir Zog. let me tell you that it was just their brainchild, and we are implementing through the event person. So the whole idea, the whole program is prepared by the Dr. Todi, and time to time till today, till 5 minutes back, he is advising us how to move ahead with the implementing this sepsis program through the Sepsiscon 2021. So I again take this opportunity to appreciate and thank Dr. Todi as well as Zog for guiding us and for giving us such a fantastic academically rich program to run. And I'm sure every delegate must be enjoying. And the last and the least, this is not the only program or event we are doing. In future also will come up, and we need your inputs, we need your feedback so that we can make it more friendly affair for everyone. With this, I hand over it to the organizers. Thank you very much, and welcome you all to the Sepsiscon 2020.
Thank you, Dr. Kapil Jirpe. On behalf of the entire organizing team for Sepsiscon 2021, I, Dr. Subal Dixit, as treasurer of the Sepsis Forum, would like to formally place on records. Thank you to all our support partners and partners, Bharat Serum, Cadila, Cipla, Acumentis, for helping us arrange this event. I would also like to thank all the international faculty and the national faculty for sparing their valuable time and sending us the recording, and also certain faculty who offered to come live to have a face-to-face talk. I would also like to thank all my supports and colleagues, Dr. Kapil Borauke, Dr. Khalid Khatib, Dr. Abhijit Deshmukh, Dr. Prasad Suryavanshi, and also Ruby Hall Clinic for extending the Central Control Support Room. I would also like to thank officially all the delegates who have registered from different parts of the country and also different parts of the certain SAARC countries for this today's Sepsiscon 2021. And last but not the least, I would like to thank Alina, Bran, and the entire support team of Medwins, and along with them supporting Zia and Girish for helping us to arrange this Sepsiscon digitally and successfully hosting it. And without last but not the least, I would again like to thank Dr. Yatin Mehta for supporting us in all the decisions along with Kapil to arrange this Sepsiscon 2021 along with each and every member of the governing council. So thank you very much and welcome you all to Sepsiscon 2021.
Janagana mana adhinayaka jaya he Bharat bhagya vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, Dr. Kapil Jirpe, Dr. Yatin Mehta, and I would like to officially close this inauguration ceremony, and I request Dr. Khalid Khatib and Dr. Prasad Suryavanshi and the moderators to please take over. Thank you very much.
Thank you, Subal.
Good afternoon, everybody. The next lecture is a keynote lecture, Preparing for a Pandemic, What Did We Learn from COVID by Dr. Samir Zog.
Welcome to Sepsis Conference 2021, and thank you organizers for inviting me to give this prestigious talk on preparing for a pandemic. What did we learn from COVID? I am Dr. Samir Zog from the Dinanath Mangeshkar Hospital in Pune. I would like to start with Benjamin Franklin's quote, by failing to prepare, we are definitely preparing to fail. And just to give you glimpses of what we faced in the last 18 months, in January 2020, we started learning about COVID, mainly from Chinese media. And this is the devastating picture in many Indian cities in May 2021. But remember, this has happened everywhere in the world, not only in India, but in New York, in Milan, and in Brazil as well. So, whole world was affected by COVID pandemic. And here I am to discuss with you what we learned over the last 18 months. I'll be talking mainly from our own experience at Dinanath Mangeshkar Hospital in Pune. In March and April 2020, we were mainly in a preparing phase because knowledge about the COVID was minimal and was mainly based on experience in China as well as in northern Italy. But the first wave hit to Pune and Maharashtra in mainly July, August, and September in 2020. Then there was a period or gap of almost 4 months when we thought we recovered to normalcy, and our non-COVID ICU and non-COVID hospital activities started as usual. But unfortunately, we got struck with second wave of COVID, which started in Pune and Mumbai, probably first in the country in March first week, and lasted till April last week or maybe May first week. And now probably we are in coming back to our normalcy, but this is new normalcy, not old normalcy. And let's see what we learned from these 18 months. Fortunately, our center was a high volume center in H1N1 influenza pandemic. So we had experience of treating upper respiratory tract infections pandemic, not pandemic, but epidemic in 2009 and 2010. And this is our editorial published in Indian Journal of Critical Care Medicine. So in April 2020, this is the article we published in Indian Journal of Critical Care Medicine about preparedness of acute care facility and a hospital for COVID-19 pandemic, what we did. So this was our preparatory phase in 2020. And now, after 14 months of our article got published, I'm looking back and adding to what we learned in additional 14 months. This is an interesting quote. It doesn't matter how many resources you have. If you don't know how to use them, it will never be enough. So it is about to utilize your own resources, your own manpower, your administrative skills, and what you have, and apply them for the benefit of larger population. At our hospital, we had a different thought process which started almost February 2020 as we got news from Italy and some parts of Europe. And there were significant number of meetings occurred and were still ongoing about administration, organization of hospital space, staff management, supplies, cost effectiveness of our hospital. For example, we immediately implemented facility of HRCT at only 2,000 rupees, which was revolutionary in this part of the country. Then hospital adopted a policy or philosophy of no profit making during COVID, even if we bear some losses, but there will not be any profit making activity during COVID because it's the pandemic and we have to help people. And in today's talk, I'll be mainly talking on maintenance of standard of care in non-COVID area, which is also, I feel, equally important. There's specific COVID ICU management, what we learned over the last 18 months, and a trade-off between usual care and a pandemic, which is very less top topic even today, because people don't want to expose ourselves for the lacunae, I believe. So what we did differently, before talking about that, I would like to quote our numbers of our hospital. So far in last 18 months, we have treated 17,000 outpatient in our hospital, 13,000 hospital admissions, out of which 2,500 were COVID ICU admissions, plus on an average 400 non-COVID admissions per month we have been catering for last 18 months. And so far our hospital has completed more than 1 lakh vaccinations for our community in Pune. So going back to what we learned or what we did differently, as an administration was very important. I believe there should be single point of decision making or contact in such a pandemic period or such a crisis period, because everybody has got their opinion, and if we start implementing opinion on everybody, it will be disaster or chaos. So single point of decision making policy was adopted in our hospital. Then division of responsibilities and ensuring accountability was maintained. Initial period, we stopped routine non-urgent work like joint replacement surgery, spine surgery. We used social media, especially WhatsApp, Facebook and YouTube, for inside connectivity amongst ourselves, and utilization of all the staff and doctors in COVID care. For example, during these 2 surges or 2 waves, our surgeons were looking after our fever OPD, audit of oxygen utilization in the hospital, relative counseling, and counseling of relatives after death. So everybody, irrespective of their specialty, was working for COVID work in our hospital. Infrastructure, fortunately, we have got 3 separate buildings in our campus. So we could dedicate one whole building which catered for around 450 patients for COVID. But during the second surge, we had to occupy 2 floors of a non-COVID building as well. Because on April 20, just so let's see our numbers, we had 630 COVID admissions and 210 non-COVID admissions on a single day. On that day, we had 39 non-invasive ventilators going on in our patient in non-ICU areas, and in the designated ICU area, we had 80 ventilators in our ICU. So this was the most difficult day in my life, probably, I believe, April 20, 2021. During the COVID pandemic, we had the challenge of keeping the non-COVID ICU running as well, because we never stopped non-COVID ICU work, like myocardial infarction, stroke, trauma, GI bleed, emergency post-operative care after cesarean section or after difficult IC bleed was always continued over the last 2 years. We had a policy of rotation of medical, nursing and paramedical teams. The rotation was between COVID building and non-COVID building, and all of us did rotations of COVID and non-COVID ICU. So both the ICUs were parallelly running during this period. So we recruited a lot of non-ICU staff and trained them with simulation to work in our ICU. For example, our ophthalmology resident, because the cataracts were not getting operated during the pandemic, our ophthalmology resident and doctors were trained to fill up the discharge summaries and death summaries. So this is how appropriate utilization of manpower was performed in the ICU. This is one spectacular thing what we did in the country. Probably we were the first one to adopt this policy, that our hospital as a policy never used the ready-made PPE or personal protective equipments in COVID pandemic starting from March 2020. If we go back to utilization of PPE, it is only for Ebola virus or Zika virus which are sprayed through body fluids, the PP might be effective. But COVID is a respiratory virus. So there is no point in covering your whole body with raincoat-like PP and getting stuffed inside. So we use the simple modified PP which is shown in the picture. Just the gown which we use during our procedure, the gloves, N95 mask and the cap, that's all. We never use those kind of PP and we save almost few crore rupees of the hospital. About the quarantine, initial period of the pandemic, the healthcare workers were staying in a hostel or a hotel all over the country. But from the day one, we adopted a policy. Since COVID is inevitable and COVID is going to affect everybody who comes into contact, there is no point in staying in separate facilities. So all of us stayed at home or hostel or a place where he or she was staying before COVID. So we never adopted a policy of renting a hotel or a hostel for COVID workers. All of us were working as if it was a non-COVID period. But we had dedicated rooms inside the hospital with all basic facilities for those who had suspected or suspect symptoms or those who were positive. So all the hospital staff had a facility to remain in the hospital if they do not have the home quarantine facility. Those who had home quarantine facility, they were allowed to stay at home just like common population. And the hospital admission for even staff was restricted only if they were hypoxic or if they require concomitant medical care. Otherwise, we did not admit hospital staff in our hospital and occupied the bed. They were allowed to stay at home. Then what we use, I think, is WhatsApp utilization was significantly high during this pandemic. Not only for spreading false news, but constructive use of WhatsApp, I would like to mention here. We use WhatsApp video calling from ICU to relatives, and that's how the communication was well established and the faith was well established because relatives were unable to visit the patients. And only on phone communication and audio communication, which I often feel is not a complete communication. WhatsApp video communication is an effective tool to talk to the relatives and show them the situation of their patient. We had multiple WhatsApp groups inside the ICU or inside the hospital for the fast implementation of new policies because policies were changing every day during the first wave, even during the second wave. And we use YouTube videos for our colleagues who were placed in the resource limited areas like Taluka places in Maharashtra. Especially in our Marathi language, we produce a lot of YouTube videos to spread the correct science and knowledge about the COVID. Our simulation training center was well functional even before COVID. So during February and March last year, our simulation center took special efforts to teach everybody in the hospital about donning and doffing, and not only donning and doffing, but small procedures like suction, application of non-invasive ventilator, application of HFNO, application of CMAC for those who are going to intubate patient. And I'm proud to say during whole COVID pandemic, in the last 1.5 years, we did all intubations in our ICU with CMAC video laryngoscope. This probably helped us in avoiding the exposure of aerosols in a coughing patient or during intubation. So video laryngoscope is one thing which implemented rigorously during the pandemic. So these are our photographs of our simulation center, where all the hospital staff was trained in various activities like CPR, bag masking, oxygen therapy, and many other treatments. We did a good community outreach during the pandemic. These are some examples of our community outreach examples. We discourage the use of unproved therapies during the pandemic. And this is, I think, very important topic, which many of us forget. We started initially with HCQS prophylaxis, but soon after 4 to 5 weeks, we stopped it because the reports or publications quoted that HCQS is of no use. So we stopped using HCQS, doxycycline, and azithromycin. Even till today, we don't use these drugs for COVID, and we never used them during first wave as well. We kept using dexamethasone and remdesivir only for hypoxic patients. Those who require oxygen, we provided dexamethasone and remdesivir. Those who did not require oxygen, these drugs were not prescribed. And this is how science is practiced. Experimental therapies like convalescent plasma transfusion, ivermectin were not adopted, lacking the definitive scientific evidence for COVID. And very, very selective use of the newer drugs like tocilizumab, itolizumab, tofacitinib during the second wave, we use, but very sparingly we use, not on the rampant scale. Then thoughtful use of HFNO is something which was discussed in April 2020 all over the world, because many of our colleagues believed that HFNO will produce a lot of aerosol formation and all the staff in the ICU will be dead if we use HFNO in COVID. But this proved wrong. We started using HFNO from our first patient in March 2020, and we used HFNO extensively during the first week and in the interim period. During the second week, because of the scarcity of oxygen supply in the region, we reduced our HFNO use and we shifted to non-invasive ventilation. But I believe HFNO has definitely revolutionized the management of COVID, especially in a resource-limited setting where invasive mechanical ventilation is difficult to execute in many ICUs. About severe ARDS, what we learned, I think HFNO and NIV are always our first choice in COVID. Clinical assessment is important and numbers. Intubation decision was made only on clinical and oxygenation merits, not on oxygenation merits or not only on clinical merits. Early prone for 3 days was a game changer, I believe. And if somebody is not improving after first 3 to 4 sessions, if PF ratio persistently remains around 100 to 150, or if plateau pressure remains persistently above 30, then the outcomes were poor. And this is what we learned definitely about severe ARDS. We sparingly used ECMO during the last 18 months because if you see the world literature, ECMO is not a very promising therapy in COVID. So we are ECMO center for almost last 10 years, but despite this fact, we did only 7 ECMOs in last 18 months. Palliation and non-aggressive care is probably the most difficult aspect of ICU care in pandemic. Because during the surge cases, especially during April, May, when we were treating 600 plus patients in the hospital, it was very difficult to make a decision for whom we will continue care and for whom we will palliate or we won't give aggressive care. This was the most difficult aspect in the ICU, I believe. Because of the huge demand of the ICU bed, and we were having limited number of beds, and this is situation all over the world, including India. So we had to take a decision, a tough call based on age, comorbidity, Apache score, severity of the disease based on X-ray and CT scan, and response to therapy in last 3 to 4 days. Based on this, we took a difficult call of going non-aggressive care or palliating few patients in our ICU. In such cases, I would like to highlight the fact that if you ask every single person in your ICU, what do you feel about an individual case, everybody will have different opinions. So for such difficult cases, democracy cannot work. One person, especially the senior most person, has to take a decision and take a lead decision that we are going to give aggressive care for this patient and we are not going to give aggressive care for this patient. We continued our research work and academic work during the COVID, which was actually an opportunity to publish our own work. So far our hospital has published more than 20 papers in various areas, whether it is neurology, cardiology, critical care, ENT, emergency medicine. And I would like to mention our Pune city's experience. We have collected 1,200 patients' data during the first wave, and the study is called as Picasso study, which we are writing a manuscript at present. And soon we will be publishing this, our experience of Pune City ICU in COVID. So finally, what I learned from COVID in last 18 months, first of all, it's a respiratory disease, respiratory viral disease, and we have to live with it for probably next 2 to 3 years. We cannot escape from it, and we have to apply what we have learned over the last 18 months and avoid unproven unscientific therapies just because some report, some case series claim that it cures COVID. There is and there won't be a magic remedy for COVID-like illnesses. just provide standard ICU care. And I think we'll be doing justice for not many patients. What we have learned is also important. We can't save all lives. I would like to repeat, we can't save all lives, but definitely we can give care to all if we accept this principle of justice to all. And it has shaken now, lastly, it has shaken my many concepts in critical care, especially severe ARDS, hypoxia, use of HFNO or NIV, ECMO or palliative care. Because we have treated hundreds of patients whose PF ratio is below 100 with HFNO or with NIV. So what is true severe hypoxia? What is severe ARDS? We really don't know. The COVID has taught us this. And now I am more humble and cautious than confident intensivist after COVID. Thank you very much.
Thank you, Dr. Samir Zog. The next lecture now will be by Dr. Shirish Prayag, sir. Sir needs no introduction. He is father figure of critical care in the Indian subcontinent. I would like to call upon him to talk about sepsis management in low economic countries. Over to you, Prayag, sir.
Good afternoon, everyone. My name is Dr. Shirish Prayag. I am from Pune, and this afternoon we are going to discuss a topic which is called "Should sepsis be managed differently in LMIC?" This was the topic given to me. It's quite interesting topic that we will be discussing. And before we begin the discussions, I bring to you my greetings from the ISCCM in Pune, which has been the original branch which started the critical care training and teaching way back in 1992. We know that over the last 30, 40 years, the medical lingo has evolved. And there have been lots of changes in the way doctors speak with the patients. And perhaps I thought that the title this afternoon came from that when they talked about LMIC. The abbreviation was a bit intriguing to me to begin with. And therefore, when I looked it up as to what it means, I got a host of options to tell me what it meant. They were quite bizarre, honestly, from Lawyers Mutual Insurance Company and Light Microscopy Imaging Center to Lutheran Ministry Christ. And hopefully, the organizers of this afternoon's meeting meant that I'm supposed to be talking on should sepsis be managed differently in low and middle income countries or lower middle income category. This is on this premise I'm going to base this afternoon's discussion. So WHO, along with the health economics data, have defined what is high income, upper middle income, lower middle income, and low income. And this is just the world map to indicate that in the maroon color or the violet color, we are seeing the lower middle income. And in the flaming red color, we are seeing the low income category of countries. And therefore, you will agree that it's a very large segment of the world's population that we are categorizing as lower middle income or low income categories. Now, the issue is that should we be managing sepsis differently in these category of patients? Why should we do that? The answer is that their per capita total expenditure on health for any disease is different for these LMICs as compared to the higher income category. So if you see just the numbers, the lower middle income categories are in the yellow to orange to red, which is a very small amount that per capita total expenditure is spent. So essentially these category of countries or these groups spend quite a low amount in total on the health per se. On top of that, the out-of-pocket expenditure on health as a percentage of the total expenditure or as a percentage of the private expenditure is also quite high in these countries, which means that the third-party payments, the insurance, the government, the employers, these agencies do not look after a significant proportion of these expenses, which means that these LMICs, the patient in these LMICs, the patient needs to pay from their own pockets to actually bear these expenditure. And then when we look at sepsis as a disorder or intensive care treatment in general, the expenditure is large. So we are facing a situation where we are looking at the possibility of countries which have lower incomes, very low component of that income is being spent on health. A large proportion of what is being spent on health, it comes from the patient's own pocket. And the expenditure in toto is quite significant because it's a serious disease being treated in intensive care. Now, obviously, if the patient is going to pay from his own pocket, then the common response of the intensive care community or the medical community in general is to adjust or adapt our strategies according to the patient's ability to pay. And therefore, it's a common thing to see factually that we do adjust our treatment strategies or management strategies to the ability of the patient to spend for it, or tend to conserve the patient's resources into areas which are absolutely necessary. Now, although India in the current stage is tending to show that its economy is changing and we are not really in the LMIC categories, and it's showing a lot, bringing in a lot of statistics and trying to show chests which are bulging. Actually speaking, we are in our own country, we are resource limited. And when we say resource limited, it's not just the economic resources, but it's also the human resources and intellectual resources. And basically because of all this, we will need to adjust our strategies to what is being prevalent in our country based on not only the economics, but also the resources from the human angle and their ability to look after these patients. From these, we'll need to adjust. And I would allude to this paper which came in Journal of Critical Care in 2018, of which from the World Federation of Intensive Care, of which I was a co-author. So coming back to the original questions, should we manage sepsis differently? The answer is yes, in some ways, but not in every respect. And let's go into the details. The definition of sepsis, when we look at that, it is important to note that the definition of sepsis was established largely based on adult patients suffering from bacterial or fungal infections. So effectively, the category of patients that we are facing in the third world or the LMICs are the tropical infections or the protozoal or some of the peculiar viral infections. In these group of patients, the definition of sepsis itself has not been validated. So for dengue, malaria, tropical infections, other tropical infections, the definition has not been validated. And therefore, our primary question itself comes into a bit of a question mark as to should we be adapting to what the recommendations of the world or the Surviving Sepsis Campaign guideline or to whatever else the Western world is adapting to? Should we be adapting those recommendations and guidelines to our patients which have not been included in the definition of sepsis in the first place? Number two is the heterogeneity when they talk about the LMICs. It is too simplistic or naive to say that the LMICs are all uniform. And within LMIC, one LMIC itself, for example, within India as an LMIC, there is an important heterogeneity in the availability of intensive care, even in a particular geographic area. For example, if you look at Pune, my city, there will be a huge heterogeneity in the types of intensive cares, the resources available in intensive care, the patient population which comes into these intensive care, the resources of the ICUs in terms of manpower and economics, and therefore the quality of services which are being dished out, and the case mix which comes there. And this continues to evolve because the urban population in many LMICs continues to evolve. And the more urban the population is, the more resources are different than the rural area. And therefore, there is a significant heterogeneity when we talk of LMICs as a general word. Moreover, the contemporary scientific evidence and guidelines, as I mentioned, of the sepsis management, not just the definition itself, but even the evidence and guidelines of treatment have come almost exclusively from high-income countries. International guidelines focus on critical care aspects of bacterial and fungal sepsis, whereas the disease which we face are significantly different from these diseases. And therefore, these guidelines cannot be necessarily extrapolated to non-bacterial sepsis such as malaria or tropical viral illnesses. Furthermore, if you try and implement these guidelines verbatim, we see a lot of problems. The problems comes because we need our own database to actually adapt these guidelines to our own databases. Now, our own database definitions or implementations have had huge limitations, primarily because the data recording is faulty. We have deficits in personnel, lack of diagnostic codings and health records, and changing definitions in science. Failure to adhere to guidelines even for the classical bacterial or fungal sepsis as defined by the Western population is itself faulty because of the variability of resources. And moreover, the manpower itself is not adequately trained and appropriately trained in various aspects of management. Additional problems include inappropriate use of antimicrobials, non-standardization, lack of antibiotic stewardship, lack of access to rapid, low-cost and accurate diagnostic testing. These are some of the problems which we face in LMIC, as a result of which it becomes difficult to implement, and sepsis guidelines cannot necessarily be managed or applied verbatim in the LMICs. So the solutions must be found because we need to save these patients. And these solutions must be simple, easily applicable, reliant on frugal technology, reliant on ubiquitous technology and should be cost effective. Therefore, the implementation must come from protocols developed in our own countries. These protocols, if developed, will be useful because it has been shown even in low and middle income countries that these kind of protocol implementation associated with education and proper feedback has been shown to change clinician behavior and has been associated with improved outcome and cost effectiveness. So the differences between what has been traditionally recommended internationally and what is adaptable to LMICs can be approached in three parts. The best way is to prevent sepsis. When I say prevent sepsis, we can't prevent we make attempts to prevent infections in the first place. But if we see a patient coming in with an infection, we try and prevent him from going into sepsis by diagnosing or identifying these patients early and treat with supportive care much earlier than what we should be doing. If we do this, we are likely to be preventing sepsis. And by preventing sepsis, we are likely to conserve the resources, improve the outcomes, and actually adapt the international guidelines to the LMICs. So the early and appropriate management of patients is the key, and therefore preventing patients from going from infection into sepsis, into septic shock and multi-organ dysfunction is the key in these patients. Such an approach may conserve the already scarce resources, and this preventive approach would paradoxically not focus on critically ill patients, but interrupt the pathway from acute infection to sepsis and try and avert organ dysfunction. So the goal is to recognize early. QSOFA, which has been used internationally for early identification of sepsis, has been shown to have reasonable power to predict increased mortality from resource-limited from studies from resource-limited settings as well. So we should be using QSOFA classically to identify these patients early. But more importantly, as I have been teaching since 1980s, we should be recognizing sepsis by our ability to smell sepsis. By that, I mean that in a patient who has an appropriate clinical settings, for example, a background story of a likely infection, we should be able to identify unexplained signs like tachypnea, tachycardia, hypotension, drop in urine output, encephalopathy, acidosis, etc., and then smell sepsis and recognize it early. And having recognized that this is likely to be sepsis, we should be doing certain tests which identify the type of infection, the focus of infection, the likely causative microbiological pathogen, and recognition of the stage of sepsis in the form of septic shock or organ dysfunction to initiate our therapy. When we do that, the core elements of general supportive care will come into play. And fortunately for us, they are not different from the standard recommendations as per the SSC guidelines. By that, I mean the hemodynamic in resuscitation after early recognition in the form of fluid resuscitation, vasopressor selection, the targets of vasopressors, the choice of vasopressors, the choice of fluids, etc., are no different in LMICs. So also the renal replacement therapies or mechanical ventilation or hematological support, etc., etc. So general supportive care remains the same. The early identification is the key. And if we therefore summarize what should be, should the sepsis be managed differently in LMIC? Yes, it should be managed differently by doing some smart modification. This smart modification should be based on data from LMIC, which should be the way to go. Early clinical recognition forms the backbone. And for early clinical recognition, we should be training the staff, whatever is available, by the trained intensivist, do all the relevant investigations, and then start aggressive early treatment, which is appropriate in the given clinical settings. Thank you.
I thank Dr. Shirish Prayag sir for that excellent lecture. As there are no questions, we'll move on to the next lecture. The next session is sepsis research, and I now invite Dr. Diwatiya sir to talk about INDICAP 2. Over to you, Dr. Diwatiya. Thank you.
Good afternoon. I will be giving you a brief overview of sepsis in Indian ICUs based on the results of the INDICAPS 2 study, which was a 4-day point prevalence study that was performed in 2018 and 19, and similar design as that of the INDICAP study, which was done in 2010 and 11. So as you can see, there were these two studies in INDICAPS 1 and 2. The number of patients was slightly higher in INDICAPS 2 than in INDICAPS 1. Apache scores was more or less similar, severity of illness. The number of patients who died in ICU overall was about 13.5% in INDICAPS 1 and almost 16% in INDICAPS 2. But the number of patients who were terminally discharged, the proportion of patients terminally discharged was significantly higher in INDICAPS 2 as compared to INDICAPS 1. And the total ICU mortality, which is the sum of the patients dying in the ICU and the terminal discharges, was therefore 18% in INDICAPS 1, but 23.4% in INDICAPS 2. Okay. Now, when we looked at sepsis in INDICAPS 2, sepsis was defined as infection on the study day and a SOFA score of 2 or more, or a diagnostic category entered of sepsis at admission. And you see here that we had 1,368 patients with sepsis of 29%, and the overall ICU mortality was almost 37% in patients with sepsis. Of these, 590 patients had septic shock, and they were significantly sicker, and their mortality was 53.4%. Patients with tropical infections, that malaria, dengue, tropical leptospirosis, and scrub typhus, these were laboratory confirmed infections, were seen in just about 3% of patients. These patients were much younger. They had a lower Apache 2 score and a significantly lower mortality in the ICU. Now, of all the patients who had sepsis, you can see that about 51% were mechanically ventilated, 38% received vasopressors, and 17% received renal replacement therapy. The commonest tropical infection was dengue, followed by scrub typhus, leptospirosis, and then malaria. So this was seen in 135 patients, and these represented laboratory confirmed infections. When you compare INDICAPS 1 and 2, the number of patients is roughly the same. The diagnostic criteria were different. In INDICAPS 1, it was based on the investigator saying that the patient had sepsis. Tropical infections were significantly more in INDICAPS 1, but these were suspected or confirmed infections, whereas in INDICAPS 2, they were restricted to laboratory confirmed infections. Mortality slightly higher in INDICAPS 2, also driven by the higher number of terminal discharges, and the tropical infections, again, as compared to other sepsis, significantly less sick and significantly lower mortality. Sources of infections were largely respiratory, bacteremia, abdominal, and genitourinary in INDICAPS 2. When we looked at the organisms between INDICAPS 1 and INDICAPS 2, again, we can see that the gram-negatives form a significant proportion, almost 70%, over 70% in INDICAPS 2 of the total number of infections. And what we can see in INDICAPS 2, the Klebsiella has overtaken Pseudomonas and Acinetobacter as the #1 organisms. So almost 34% of the organisms, gram-negatives, were Klebsiella, which were only 21% earlier. Pseudomonas and Pseudoaeruginosa species, which were the dominant ones, have almost halved to almost 13% in handicaps 2. So Klebsiella and E. coli are the #1 and #2 organisms, followed by Acinetobacter and Pseudomonas. Fungal infections, more or less the same. Candida albicans remains the dominant fungal infection, but much less so in handicaps 2 than in handicaps 1. Not much difference between the gram-positives, a very small proportion, about less than 20% being gram-positive infections. And again, MRSA and MSSA being the major gram-positive infections that we've seen. Antibiotics, now this is from the entire cohort of 4,669 patients. The imipenem or meropenem, piperacillin, tazobactam, cefoperazone, sulbactam, metronidazole, and teicoplanin form about 70% of the antibiotics which have been given. Colistin comes at #7. And if you compare the antibiotic usage between handicaps 1 and handicaps 2, you see that meropenem and piptazo remain as #1 and #2. Cefoperazone, sulbactam usage has increased in handicaps 2. A new antibiotic which makes its way into the list is ceftriaxone, sulbactam, and EDTA. Colistin slightly higher in position, teicoplanin increasing in incidence. So this is overall sort of comparison of the usage of antibiotics, probably guided by study patterns as well as new pharmaceuticals coming up in this period. When you look at interventions for sepsis, we find that this is the blue bars are showing handicaps 1. The usage of steroids slightly reduced. Invasive arterial pressure monitoring increased in handicaps 2. Central venous pressure monitoring and SCVO2 usage has declined in handicaps 2, but use of SVV or PPV for hemodynamic monitoring and the use of lactate has shot up. And this probably reflects the results of the change in practice following the results of the studies of goal-directed therapy, which showed that goal-directed therapy did not probably have as much usage as earlier. Okay. Other interventions like echocardiography is high at 30%. 10% of patients receive vitamin C. And the other extracorporeal techniques in nylostatin was used in a small number of patients. And these interventions are not actually captured in handicaps 1. So in this very brief presentation, I've tried to highlight what we've seen in handicaps 2, a brief comparison with handicaps 1. So thank you for your attention.
Thank you, Dr. Diwatia. I now call upon Dr. Atul Kulkarni sir for his next lecture, which is on sepsis papers in 2020 and 2021 in IJCCM. Thank you.
Good morning. In next 10 minutes or so, I will be talking about publications on sepsis and septic shock in 2020 and 2021 in the Indian Journal of Critical Care Medicine. First, we'll talk about the papers that are published about epidemiology and outcomes. So this paper from Chennai looked at impact of healthcare associated infections on patients who are primarily admitted with sepsis and non-sepsis diagnosis. So a single center prospective study in a single unit, and 271 patients were included, out of which 106 patients had sepsis. The incidence of hospital-acquired infection was similar in both the groups. However, complications such as AKI and shock were more in patients who had sepsis, and more patients in sepsis group needed mechanical ventilation. Therefore, they obviously had higher ICU length of stay. There was no difference in 30-day mortality. From the same group comes this study from Chennai, where they looked at outcomes of AKI in patients with and without sepsis. They used the Akin criteria for diagnosing AKI and the American College of Critical Care Medicine 2001 criteria for sepsis. They had fairly sick patients. Total number was 242, out of which 111 patients had AKI. Out of these 111 patients, 55% had sepsis and 49% had non-septic AKI. The patients who had AKI due to sepsis, the need for renal replacement therapy was significantly higher. However, there was no difference in patients with septic AKI or those with non-septic AKI. But when patients with sepsis had AKI, as compared to those with sepsis alone, that is without AKI, was significantly higher mortality in that group. Then there are several studies published on biomarkers in sepsis. This is an interesting study, though it's a small study of 80 patients, which looked at the levels of adrenomedulin and whether it confers any protective effect gender-wise. So what they found was that patients who had sepsis, the mortality was higher in males. Also, the Apache 2 and SOFA scores were higher in male patients. And they also had lower adrenomedulin levels, and the difference was significant. They concluded that adrenomedulin is a protective neurohormone. Though it is elevated in all patients with sepsis, the rise is higher in females and it confers a protective effect, and this is something that can be explored further in other studies. Presepsin is one of the new molecules, and this study looked at the role of presepsin for diagnosis of sepsis and mortality. In 40 patients, they measured presepsin within 6 hours of emergency department admission. And for diagnosing sepsis, they found that it was quite useful, and the area under the curve was nearly 85%. However, it was not so good for, it was also quite good for predicting ICU mortality in patients with sepsis. Again, a small study and probably needs to be duplicated in further studies. So they concluded that early presepsin is more accurate in the diagnosis of sepsis and prediction of mortality as compared to SIRS and Q-SOFA scores. Now, SIRS and Q-SOFA scores are not very good comparators. So you probably need to compare it with some other markers which can predict the mortality and diagnose sepsis. This group presented this, published this paper about the urinary albumin creatinine ratio to predict outcomes of patients with sepsis. They had 138 children, out of which 56 had sepsis, 31 had severe sepsis, 22 had septic shock, and 29 patients had multi-organ dysfunction syndrome. They collected the urinary samples for calculating the albumin creatinine ratio at admission at 12 hours and 24 hours. Out of these 138 patients, 21% died. The albumin creatinine ratio was significantly higher in non-survivors at all 3 time points. And as the sepsis severity increased, the ACR increased progressively. So they said that urinary albumin creatinine ratio is a cost-effective tool which correlates well with the severity of sepsis and associated morbidity and mortality in children. And it can be used in low resource setting countries. This study from Delhi, again a single center study, looked at the diagnostic and prognostic utility of soluble urokinase type plasminogen activator receptor and procalcitonin syndrome and compared it in patients with sepsis and SARS. There are 88 patients, out of which 59 patients had sepsis. They measured both the biomarkers on days 1, 3, and 7. The levels of SUPAR and the PCT were significantly higher in the sepsis group, but they found that the area under the curve for soluble urokinase type plasminogen activator receptor was much better on day 1 as compared to procalcitonin on day 1. However, the trend at predicted mortality was much better with procalcitonin. Another interesting study comes from a pediatric intensive care group where they looked at the CPKMB levels on days 1, 3, 7, and 10. And they looked at patients who survived after having septic shock and patients who had non-shock sepsis. They also looked at the P-load score, the vasopressor inotrope score, and the 2D echocardiographic findings in these patients at the same intervals. So the patients who survived septic shock had a higher CPKMB, the VI score, and a P-load score on day 1. More than 50% of patients with septic shock, who were septic shock survivors, had myocardial dysfunction. They found that the reduction in CPKMB correlated well with improvement in the severity score, the vasopressor inotrope score, and the 2D echo measures of myocardial dysfunction among patients who were septic shock survivors. And the area under the curve for predicting myocardial dysfunction for CPKMB was also quite good. It was about 0.72, though it is not very high. So they concluded that the patients who survived septic shock had markedly elevated CPKMB, and its fall paralleled the improvement in clinical status and myocardial dysfunction. So it could be a potentially good monitoring tool for septic myocardiopathy, resource limited setting where echocardiography is not available at the bedside. Coming to the last group of papers, which described therapy, and there were only 2 papers which talked about the metabolic resuscitation. The first study from Hyderabad looked at individual components of the metabolic resuscitation, that is hydrocortisone, compared with hydrocortisone and ascorbic acid. And the third group was hydrocortisone, ascorbic acid, and thiamine. They found that in patients with septic shock, there was no difference in time to shock reversal when they were given these individual drugs, which are components of the metabolic resuscitation. Another trial called the Victor trial looked at the metabolic resuscitation versus routine care. They had 88 patients which were divided in 2 groups. One group got metabolic resuscitation, the control group got the routine care, but there was no restriction on using hydrocortisone or thiamine in that group. And they found that metabolic resuscitation did not significantly improve the inpatient all-cause mortality in patients with septic shock. Now, we must keep in mind that both these studies did not do a formal sample size calculation, and they may not have been powered for mortality. Thank you very much.
Thank you, Dr. Kulkarni, for taking us through the papers of IJCCM on sepsis. The next session is a panel discussion. Moderator is Dr. Subhash Todi, and panelists are Dr. Yatin Mehta, Dr. B.K. Rao, Dr. Sheila Mehatra, and Dr. Rajesh Mishra. Over to you, Dr. Todi.
Hello and welcome to this panel discussion for the Sepsicon 2021, which is organized by Sepsis Forum of India. We have four eminent key opinion leaders of the country. We are going to discuss the research agenda, sepsis research agenda in particular, what to do, where we go from here. I'm sure we will all agree that we have done a very good work on training, education, with so many courses going on, the national board, the societies giving certificate courses, so many webinars and board review courses around the year. I think we have done very well in that front. But again, I'm sure everybody would agree that on the research front, we have not done well. We have not put up ourselves in the international map of research in critical care. There are definitely endeavors in small single center observational research, a few multi-center, but nothing in a big way. So that is what we are going to spend 30 minutes and just to kind of brainstorm, where do we go from here? Can we take some clues from our discussion and then operationalize these concepts? So we have four senior key opinion leaders. One, Dr. Sheila Mitra from Mumbai, Dr. B.K. Rao from Delhi, Dr. Yatin Mehta from Delhi, and Dr. Rajesh Mishra is from Ahmedabad, myself, Dr. Todi from Calcutta. So my first, it's an open question to all the panelists. We'll just take opinions of all of them. Is the era of network of critical care, as we take the ANZIX network, phenomenal research, the Canadian network, the Discovery network of USA, now the Brazilian network. They have published two very phenomenal 30,000 critical ill patient study in JAMA a couple of weeks back. So how do we take it? How do we go forward having a national network of critical care? How to go about it? Let me start with Dr. B.K. Rao. Dr. Rao, if you can just, what's your suggestion on this?
See, like in other fields, in critical care, especially in the research, the three factors, the key factors, the limiting factors are the recruitment, and recruitment. All of us who do research, we know that we have to struggle very hard to get recruitments and then keeping them on board. And then the size of patients with individual hospitals is not that large. And then we also know that the biases that come in a single center. So trial networks is the necessity, whether you call it a network or large coordinating centers. I do that, you do that with the ICMR, we do in the antimicrobial resistant network that we have. I also work with the antimicrobial stewardship program that we are doing. And now they are going for the GARD-P, which will be an international program on the antimicrobial resistance. So we have realized that at the end, the data when we pool becomes very significant. And then it has flavor from, one is a theoretical academic kind of thing. The other one is as we do. So it really catches the essence of what we do. So in my opinion, if you're looking at any global presence, then we have to have a mechanism, though it is going to be very challenging and probably controversial also, for putting networks in place in India. Government agencies can do it. I don't know how the private bodies can do it.
Yeah, we'll get to that. Yatin, like in Brazilian network, there was a debate on how they started all this, and they said it started with a bunch of friends getting together, and it was no formal meeting and things like that. 8 or 10 people who were just friends, they got together and their ICU started collaborating with each other. So what is your suggestion? Because to do a big formal coordinating network might be a very difficult task to start with. How to coordinate at least 10 or 15 ICUs who can do collaborate and share data and do some research. Yatin, what is your views on that?
See, there are some fundamental issues with sharing all the data. I mean, the private hospitals, even government hospitals, would be resistant to sharing their morbidity or mortality data or showing what is the incidence of sepsis in their ICUs. It is not that easy. Secondly, see, with networking and data collection, it's a very limited research which one can do. What can you do? You can do epidemiology, you can do incidence, you can do demographics, you can't do interventional studies. And the weightage of any good study is interventional study. Sheila has done multiple studies like this. So has this INDICAP study come out with a good district, but it is a very limited value and very limited life and very limited exposure. Because only Indian data, the Western people will not be that much interested in publishing Indian incidents or of, say, sepsis for that matter. So I think we need to now agree that the ANZICS and Canadian network are doing very good job, but many of them are not necessarily incident studies. They are interventional studies. Many of them are randomized controlled trials, and they are obviously supported. Now, if you do randomized controlled trial, which is supported by an industry for a particular drug or for a particular device, again, that becomes a little not that great a study because there are biases and there is a limitation to that activity. But if you are doing, say, like what Sheila was doing about hemodynamic disease, what intervention you can do if you can randomize that. And you can do a multi-center large trial, which we have the network. We all are here comfortably sitting and communicating with each other. It can be expanded to say 10 or 20 good busy centers. But who will support it? I would say ISCCM has enough budget now. So ISCCM should be supporting some randomized controlled trials, say two studies a year or something. There is enough in the budget, and we should utilize that budget instead of just data collection and analyzing the data. Because data collection, you have done nothing. You have collected data and analyzed it and discussed it. But interventionally, you have not come out with any earth-shaking new information. So we have the wherewithal. Yeah. We have the expertise thanks to this thing. We all are now very comfortable on the net. We might as well now, I think this year, next year, with you being chairing that research committee of ISCCM, I think we should do a few. And both Sheila and Rajesh being there in this meeting, I think we should go ahead with some interventional randomized studies.
That is the issue of funding. Interventional study requires a lot of fund. And if it has to be an investigator-initiated research without much of an industry influence, the kind of funding, the JAMA article, which was recently published by the Brazilian network of critical care units, it was funded by their Ministry of Health. That was what I got from the funding source of JAMA. And here in the private sector, I have found ICMR not coming forth very much for investigator initiated in private sector critical care research. And I'm sure, as Yatin has mentioned, that ISCCM, Sepsis Forum India, if they have budgets, but to do a big interventional study, observational studies are okay. You can get away with probably less funding as we have done in Hermes. But in order to get a CRO, big CRO on board, to do big interventional research is huge funding. We are talking about 50, 60 lakhs and above of funding for a study. So Rajesh, how does a society can help in coordinating the ICUs? What would be your vision that how would an ISCCM can coordinate, or any other critical care society or sepsis forum can go ahead with this kind of venture?
So thank you, sir, for putting me in this soup. And thank you, Dr. Mehta, for bringing out very important issue. So, you rightly pointed out that it is the research, particularly the game-changing or practice-changing research where India lacks. So I will not disclose all the plan, but in 2 or 3 months, you will see something very major We have already started planning, and as far as budget is concerned, I have already told, at least in my personal capacity, me and Deepak had already told our research committee, but I do not mind spending any money. Maybe it is 50 lakh, 60 lakh, even crore also, because we have around 1.5 crore rupees reserve budget, research budget. So if we can bring out with any ground shaking or any, one of my goal when I will be becoming president would be at least to give India at least 3 or 4 practice defying negative or positive study. We do a lot of things, but not. So we have already started planning the first stage. Like we need to find out the gap, what we really India need, because we need to look toward the India problem. So there are a lot of areas where we lack, we do not have enough information. So we have already started planning their preliminary data collection, surveillance, and we are going for questionnaire, like how we should do. So probably we'll start working, but you are right. And society has already started working on that. Our research committee is very strongly working on that. I am very sure that next year, at least by the time I get out of as a president, you will have definitely 2 or 3 study which will change the Indian critical care practice.
Just to get away from just a focus on a particular society-based critical care research and all, Sheila, what would be our priorities in sepsis-related research in India? What would you think, if you 1, 2, 3, what are the 3 important priority research?
Before I say that, if I could just add to what the previous speakers have said, I agree that with everything that has been stated, but I have a slightly different perspective on this. I think if we as a society have to gain international recognition and respect, I think we have to really take our agenda forward for research. And I think the greatest strength that India has is also the numbers. And in terms of sepsis, we have unique situations and settings which are not available internationally. And the West is quite interested in our kind of data. For example, they don't know much about dengue, malaria, etc. From my experience from the INDICAP study and the Hermes study, 70% of the patients were from the private sector. So we can have these kind of network. It's feasible. The INDICAP study was able to, in part 1 and part 2, get 9,000 patient data. And first time we had 120 centers, then 130. In Hermes, we were able to get 1,200 cases from 250 centers. So this is possible. It is about developing a network. I agree with Dr. Mehta when he said that, these are all epidemiological kind of studies. You get, more descriptive data. So if we have to do interventional studies, we can start with a few small centers. We can start with 10, 15, like you said. It need not be 100 center, but definitely there is interest. And doing this kind of, involving multiple centers has made people, sensitize them to how to collect data, how to take consent, how to go about, filling a CRF. So people have started getting trained into this. So I look at this as a real strength. And as Rajesh has rightly said, the IRCCM does have money. It's not that we don't have funding. There has to be a will, and there has to be a complete change in mindset among us, that we should not just be doing research for international studies. We should have our own research. So I think this is very feasible. It just needs the right, kind of will. Coming to the sepsis priorities, sir, if you ask me, we can do big epidemiological studies. INDICAPs looked at IC on the whole. The sepsis was only one part of it. In the Hermes study, we looked at the hemodynamic monitoring aspect, but the sepsis epidemiology was one part of it. I think what we can move forward with is a big epidemiological study, or we can take certain conditions that are unique to the Indian setting, like dengue, malaria, leptospirosis, tuberculosis, different areas like this, and we can do multi-center research. In terms of interventional studies, also we can do them, but I don't think we can involve so many centers. We can involve a few centers, and then we can try to answer certain questions related to our MDR bugs or various interventions, antibiotics, and I'm sure there is a lot of funding for this. Question on funding. Even though ICMR may not fund private sectors, there are many government hospitals, and Dr. Rao knows this very well, which can get ICMR funding from big projects. Then it means just involving many other centers. So the lead investigator needs to be from the institute, one of the institutes conducting research. So all this is feasible. I just feel it first needs a change in the mindset among the Indian intensivists, and everything is possible.
Yeah, quite right. Observational studies will be probably the first step to go. But at the end of the day, as everybody mentioned, we can do simple interventional studies. Just few examples comes to my mind. We blanketly give 2 grams twice daily of ceftriaxone, say in enteric fever or in leptospira. But I have my doubts whether people have done studies on 1 gram twice versus 2 gram twice. That has become almost a dictum. Everybody gets 4 grams of ceftriaxone. So very simple daily clinical problems that we are facing, where we have not addressed that issue, whether a smaller dose can do the same thing. Colistin mono versus colistin combination therapy for MDR bug. Again, there is no randomized big study on this. Only we can do the MDR bacteria. So coming to Dr. Rao, are we ready for intervention studies? Because we are even hesitant for doing big observational studies. So are we ready for interventional studies in our country?
Yes, I think because going back to what Yatin said, we don't want to share a lot of data, but we will be happy to share the interventional data. There's nothing to hide in that. So I think we are ready. We have reached that maturity. The only challenge that we face is you assemble a team, you work on it, you train them, you get a funding, you do a study, the study winds up, and then you lose the team. This is a huge challenge for us because every time we have to reassemble the team, and it takes a lot of time to train them and all. So what we are talking has to be with continuity. We can't say that, okay, fine, we do it now, we dump it for the next 6, 7 months, because then the whole thing is then fragmented. All the team will be gone. So whatever ISCCM is doing, there has to be a continuity in whatever they are planning.
One thing which is different.
Next year we won't do it.
One thing which is different from the Western thing is we are all practicing physician, and this we do as a passion, or rather than we don't have a protected time for research. I doubt any of us will have that. We just take our time out of our busy clinical practice to do research, and then it becomes probably not very much sustainable for a very long period of time. That is one thing which, especially in the private sector, that comes. And that is where, again, probably the government sector might take a role as well, where they can get some protected time for doing research. So as Sheila has mentioned, it has to be a partnership between both public-private hospitals. Government hospitals are big hospitals with a lot of input. But again, then we still do not know the quality of care. We have to select good hospitals with a good background. There are a lot of private medical colleges with a good quality of critical care has also been evolved in India. So I think that is where the network thing again comes. In order to build up a Indian network of critical care which are ready for interventional studies, because our experience with Hermes was pretty good. We kind of got a very small CRO, and we had so many entries from about 100 plus hospitals. So we get 800 septic patients within a span of a year, septic shock patients requiring fluid resuscitation. So numbers is our big strength. But the question comes when we do interventional studies to get funding, to get a big CRO, to get a good network of ICUs, how we go about it, because at the end of the day, that is what we will count. That is where we can publish our studies in a big international journals. But because I think unless we do interventional studies, big peer-reviewed journals might not be interested to take so many of our publications. So again,
I think it will need a lot of discussion, a lot of meetings between like-minded people. You have to identify, and then they start meeting, and then it's going to take off.
Right.
Unless we initiate it, won't take off.
Probably we have to start with few centers only, 10, 15 centers. and then select a topic which is critical for us, which is clinically oriented, and which is not very difficult to do, something which is simple to do. So any suggestion from you, Yatin, on this, how we go about selecting topic?
See what we can now, if most, even the private hospitals, for instance, I can persuade my, I think the IRB to, partially waive off. Instead of 1 lakh or 80,000 rupees with a charge from industry level, they can cut down their fee to say 50,000 bucks. All right. We can have it central insurance. You have the insurance through ISCCM, through an insurance agency, so that all the participants are insured. Because that is substantial cost.
That's a big.
If you individually do for each hospital, that adds substantially to the cost. Now, what else do you need? So you need the IRB fee, you need the insurance fee, the hospitals.
You also need a CRO. You need a CRO, no?
Correct. But per patient fee, what you normally pay for a device or for a drug, that can also be waived off. If it is for a good cause, the hospital can be persuaded. So you need, say, CRN to do a data collection, because busy clinicians, let's be honest, will not sit on the computer all day and put in data. Nobody has time. All of us are overworked and underpaid, including Sheila. It is not going to cost so much. It is CRO, yes, you do. CRO also, if you take a startup CRO who will get a huge exposure if they do a study, get involved with ISCCM. And this will be like continuous recurring studies. So we can persuade a CRO not to charge so much the regular fee. They can also cut down. So it is not going to be as expensive as industry-driven studies, but I think time to get on. And as Sheila said, have 5-7 centers. That's all you require for an interventional study.
So if I may add, sir, I completely endorse what Dr. Rao and Dr. Mehta have said. I just think that, it's not only an issue of, government, private, because in both areas we are busy at the moment. It's also about the quality of the data. This is also very important. So I think if you want to ensure quality and you want to make sure that the study is well conducted, we need to support the site, either by a per patient payment or with a CRO, or we have to make the funding for this if we want to do good quality study, not just research for the heck of doing research. And as Dr. Mehta rightly said, we can involve a few centers to start with. It is very important that the research is led by people who are familiar with clinical research methodology. It should not just be any study. It should be thought out from the beginning till the end, till publication, and what is going to be the way in which we are going to conduct it. This is very important because many projects start, but they don't reach the logical conclusion. So this kind of planning, and I'm sure if we have even incentive for patient recruitment, all this can be done, sir. Starting with few centers, they get motivated, more centers join in, and you have a permanent network. It shouldn't be that every time you again assemble these people. So this is very important and we kind of have it, but not very formally organized. Through Indicaps and Hermes, we already have this kind of network. So when we reach out for studies, it's almost the same sites that come every time. So, what I really think, there are two areas where we really need to capitalize on. One is the big data that we have. And the second is the huge interest that people have. People are very interested, even in the private sector, in taking part in research. They're not familiar with clinical research methodology, but you have a couple of people to lead that. So what we need is to capitalize on these numbers and the huge interest across the centers and get the few people who can lead this research all together. What is happening now, as Dr. Mehta rightly said, is there are institutes and certain sites doing interventional studies. This results in, siloing of ideas and divergent practices. What we need is to come together on one platform and to organize this. And I believe that societies like ISCCM, are really in the key position to be able to lead this kind of research. So it really takes the right will, and I'm sure we can do this.
In our experience with the previous industry-sponsored research, international research like Zygris, at one time, India did contribute almost a huge number of septic patients to those research. Many of these antifungal agents which are in the market, India had contributed a lot of patients. So a lot of industry-sponsored research, international research, when our laws were not that stringent, India contributed a lot to the international research in industry-sponsored research. But as Yatin mentioned, nowadays with more stringent laws and this compensation laws, it has become difficult for non-industry sponsored research to start because the funding becomes huge, the insurance premiums becomes pretty big on this. Another thing, Rajesh, I wanted to ask you, all the countries which are doing big clinical trials, these are built up on basic research first. They have all done basic research. Then they have gone into translational and clinical research. Our basic research in critical care is probably zero in our country. So what is your
Sir,
take
you
on
are rightly said. So we realize this problem, and most of the time when we do any research methodology, even courses or even training, nobody joins. So Dr. Mehta has initiated with Anirban. There was a research methodology course that was also not picked up. So what we have done very actively, there are certain things which we have already included in coming all the conferences, all the research methodology workshop will be totally free, and we are going to first engage more and more people who are interested to do these workshops. That training will come. We are going to further upgrade it to do it on quarterly basis courses where more and more people can understand and learn how research has to be done. That is the first thing which lacks, and we need to involve people. Once that process has set in, and we have at least 15 or 20 or maybe little bit of more people who are interested in contributing and working with us. The second thing, we have to look into the what we can do and what we cannot do. You also know that we have very stringent law as far as research is concerned. So we have to find out our way where we can do maneuver our basic thing easily without putting our nose at wrong place rather than right place. That is the second thing, and that's where we will need what we are doing wrong and right. We just need to compare. Like say for example, I tell you example dengue. Dengue patient, lot of people will like to give platelet. Lot of doctors do not give platelet. Now FFP is a trend. So just I'm just giving example. We have already started.
There are so many things that we can work on.
So we have already started working on a first thing. We are going to have our surveillance. We are going to have a data. What is the practice, and then we are going to plan a study. So probably in coming on 2-3 months, ICSM initiated this study will be coming. There are 2 or more industry initiated study already in the plan from ICSM that. But the basic thing is the training. So this is a conscious decision that 3 or 4 workshop, not only research only, but out of the course I'm training you the communication, research, nurses training about basics. So all these things about these workshops, ISCSM has now enough fund. So all these workshops, the need of the hour to train people, and next year onward, we are going to do it totally free. Even our online courses probably will make it free. So we just want to train more and more people to do this thing. Once at least we have enough people who can do. And another thing we have to understand, sir, there is a huge gap. There are few people who knows about research. So rest of the people think they do not know anything, and then there is a lot of barriers. So we need to bridge that barrier, which we are also trying like that. And we are, but basic purpose is that more and more people should come with us, should be willing to get working on this issue. They should understand that this will be one of our proud that India is contributing and define this treatment, and that feeling we are going to put that, and probably we'll be successful in that. So we have already started working on that. Couple of months we are working, and I say it's like not a one-day job, but I'm very sure that you will see the result very soon about this.
Okay, thanks, Ajay. BK, can you just throw some light? There has been, like, if one does a big research, is where to publish it? Because say, for example, a certain society-funded research, should it be published in the Indian journal, or should it be published in the international journal? Many of the international journals are not read by many of our Indian audiences. So what is your view on this? Where it should be published? And Indian research should be sent for publication.
It depends whether that Indian research is transformational. Will it impact the way we practice? Or is it something
say it's
that
a good
will
research,
be...
it's a big research, which can get published in an international journal. That has got a potential to get published. should the author send it to, and because even our Indian journals are PubMed indexed now, reasonable impact factor, rather than sending it to an international journal, which is probably not the number one journal, but is of good repute. That becomes a question of debate.
My point will be that if you want to project India and not yourself and not your study alone, then go for the international journals, because that is where we want ultimately the impact to be felt. And when it comes to people who are genuinely interested in knowing, in some form or the other, this in any case will find its way back to India.
Rao sir, although I do agree with your thought that we should be putting all important study in big international journal. But one thing, this is my personal thought, that if we have to become big, we have to make our home bigger. So probably it's time for us, whatever data we have, we start putting, because after 27 year IJCCM, it has no impact factor, because as I spoke to our editor, he says that still we are not in position that we can apply for impact factor. The only reason we do not have enough code from the whatever is the criteria. So probably if it is ISCCM money, if we are spending money, we would also like that all the data should go to ISCCM. Let people come to the IJCCM, read from it, and once they read, probably we will be able to build. It's a very easy. Probably
Rajesh, my answer is very clear. If you have funded it, the authors cannot publish it without your permission in any case.
Yeah.
So they will have to.
We would
I'm
like
talking of somebody. Who started it at that time when he started? Did he have it in mind that I will publish it in this journal, that journal? As this study evolved, and depending on after the results and analysis, whatever he found, he thought that look, this is something that can catch the world's attention. So that look at the authorship of that person.
Tell me, BK, does ICMR funded research, do they have any kind of guideline? Should it be published in Indian journal, or it can be published anywhere? Is there a guideline from ICMR?
All our data, these are networks. So individual network center cannot publish their own results. It has to be submitted centrally to the ICMR, and the authorship also is decided by the ICMR.
True, but ICMR has its own journal. ICMR has its own journal. So are these ICMR funded studies need to be published in ICMR journal, or it can go to international journals?
Not necessarily.
Okay. So
see, but as BK rightly said, that decision has to be ICMR.
Right.
See, it's a difficult line which we are walking now. Because a study which is publishable, say Lancet or JAMA or NEJ, whatever, now that study will expose ISCCM to the whole world.
Right.
But on the other hand, I say ISCCM has funded it, and they say my journal is not being promoted. But I suppose a paper of this large impact or whatever, you can always have subgroup analysis which can be published in IJCCM, and something can be. But all these issues should be resolved when the study is being planned, and ISCCM's decision has to be final.
Like this example of this JAMA study.
I'm doing a study which is funded by, let's say, one of the big research organizations, government research. And they have said that you can publish, but the manuscript has to be cleared by us, and we will help you to get it published. So in a way, they are controlling.
But like this JAMA study, it was funded by the Brazilian Ministry of Health, the entire study, and it was published in JAMA. So I'm sure the other countries are also following the same path, that yes, if you want to do a good research, we will fund it. I will look at the manuscript, as you said, and probably part of an authorship. But publication can be of an internationally reputed journal if the study is very of good quality. So I think in our today's discussion, we have covered areas of how to go about doing networks, probably to start with smaller networks and then go to a bit bigger networks, to start with doing small observational studies. But we should be getting ready for more interventional studies, again with few centers, having good quality workforce who are being trained into research methodology, as has been done by the different our workshops. And we have to create a critical care database, like ICNARC database in the UK. Probably it's high time that India has its own database of critical care that has also helped in many of these studies in COVID time, like recovery studies and other, where ICNARC database has helped them a lot, and publication issues and funding issues we have addressed. So basically this forum was just to highlight the issues that needs to be discussed in different forums about the research. But one thing is for sure, that I'm sure all the panelists would agree, that research agenda is the one which is probably missing from our map at the present moment. We have done a great job into education and training, but that is, I think, research now should be our priority agenda of all forums and societies. And I'm sure with all of you at the helm of big societies and forums, will be taking research agenda forwards, both in the front, in funding and making a network of ICUs which are part of these societies and forum, selecting those few important ICUs and creating a workforce who are interested and will devote time to research. With that, I would say we have covered half an hour. So I would like to thank all my panelists, Dr. Rao, Dr. Yatin, Dr. Sheila, and Dr. Rajesh, for giving your views on research in India. And if any one of you have any special comments to make before we wind up.
Just the last one, Subhash.
Yeah.
Can ISCCM think of creating its own CRO?
Yes, sir. We are doing it. We are working on it. We are not only working on that, we are working on CRO, we are working on ethical committee, we are already working on so many things already. There are some technical
committee.
Sir, it is
What
already
about ethics?
done.
What are you working on ethics committee? CRO, yes, agree.
Sir, actually there were centers who do not have that. So we have planned as per this current situation, and probably it will also work out. So the center who do not have ethical committee and they need to work on, we are going to give support to them also.
Okay. Offsite.
Yeah, there are many issues which needs to be sorted out.
So,
but I think
actually,
the
COVID has really slowed down, because these things were planned ahead, but now we have very quickly picked up. So I mean, in a couple of months, you will see a lot of things being done on this front, sir.
Thank you. Thank you very much to all the panelists. I will hand it over to our organizers. Thank you all.
Thank you, sir. Thank you for all your.
Thank you, everybody. Thank you. Thank you.
I thank all the panelists for that robust panel discussion. As there are no more questions, we'll move on to the next section. It is on gram-negative infections. And the first talk is on antibiotics for NDM infections by Dr. Parikshit Prayag. Over to you, Dr. Prayag.
Matthew.
And thank you very much for inviting me to this prestigious conference. So in the next 10 minutes or so, I'm going to be talking about infections caused by gram-negative organisms which are producing the New Delhi metallo-beta-lactamase. So it's a very short period of time to cover such a complicated topic, but I'll try to do my best. So if you look at the gram-negative bacteria, then there are various ways in which they can become resistant to beta-lactam antibiotics. When I say beta-lactam antibiotics, I mean the penicillins, cephalosporins, carbapenems, and the monobactam aztreonam. So one method could be, or one way could be, modification of the porin channels so that the antibiotics are not able to enter. Another way is, production of efflux pumps or expression of efflux pumps, which can kick these antibiotics out. Then the third way is, production of beta-lactamase enzymes, which can destroy these beta-lactam antibiotics. Or there could be modification of the penicillin binding proteins. So if you look at the beta-lactamase enzymes, then there is an increasing complexity depending on the kind of antibiotics that they destroy. So if they destroy penicillins, they would be penicillinases. Similarly, if they destroy up to the third generation of cephalosporins, they would be AMPCs. If they destroy all cephalosporins, they would be ESBLs. And last but definitely not the least, we have carbapenemases, which destroy the carbapenems. Another way of classifying these enzymes is what is known as the Amler's classification. So here you have group A or class A, B, C, and D, and I'll be focusing on class B enzymes, which are metallo-beta-lactamases. So these are zinc-based enzymes known as metallo-beta-lactamases. So coming to the metallo-beta-lactamases, there are numerous metallo-beta-lactamases, but the ones that you will commonly see in clinical practice would be the WIM, IMP, and NDM. So we are going to be talking about the New Delhi metallo-beta-lactamase or NDM. So this was originally discovered from a Swedish patient who happened to visit New Delhi and got infected by an NDM producing Klebsiella. So what is unique about these NDMs? So what is unique is that they have a unique cellular localization, and this endows these NDMs with enhanced stability upon the zinc starvation, which is elicited by the immune system. So these are very robust enzymes. These are very powerful enzymes, and they have an ability to really severely destroy or hydrolyze all our beta-lactam antibiotics except aztreonam. So if you look within the NDM family, there are various variants of this enzyme. So up to 20 variants of the New Delhi metallo-beta-lactamase have been described so far. So what is the difference? If you look closely, then their hydrolytic properties vary slightly. So there are certain variants within this New Delhi metallo-beta-lactamase family, which are a little bit more powerful when it comes to destroying the carbapenem. So if you look in this figure, then you will see that NDM 20, 5, 17, 4, 7, 14, 10, these are slightly more potent destroyers or hydrolyzers of carbapenems compared to the other enzymes. So this study classically highlights, the resistance profiles or the MICs when you have bugs which are producing NDM. So look at NDM1, NDM5, and NDM20 in the right part of this figure. You will see that they are very good when it comes to destroying almost all beta-lactams except aztreonam. Look at the aztreonam MICs, 0.03, 0.03, and 0.06. Whereas if you go down the list and take a look at the carbapenems, you will see that NDM5 and NDM20 are slightly more potent when it comes to destroying the carbapenems as compared to the New Delhi metallo-beta-lactamase 1. So again, this highlights the fact that, they are very good when it comes to destroying most beta-lactam antibiotics except aztreonam. And there are slight variations within the family as far as their potency to destroy carbapenems is concerned. Now, if you look at the geographical map of the New Delhi metallo-beta-lactamase producers, you will clearly see that the Indian subcontinent predominates. So we have an endemic spread of NDM producers in the Indian subcontinent. Whereas if you look at regions like North America or Europe, there are sporadic cases of NDM producers, mostly from travelers who visited the Indian subcontinent or endemic regions for these New Delhi metallo-beta-lactamase enzymes. So how is our national scenario? Let's consider our big four: E. coli, Klebsiella, Pseudomonas, and Acinetobacter. Now, in carbapenem-resistant E. coli, our main enzyme is the NDM. Whereas if you look at carbapenem-resistant Klebsiella in India, the main enzyme is OXA48, or the commonest enzyme is OXA48. Then you would have the NDM. Of course, many of our Klebsiellas are multiple enzyme producers. If you look at Pseudomonas, then the main enzyme is WIM, or the commonest enzyme is WIM, followed by NDM. Whereas for carbapenem-resistant Acinetobacter, OXAs predominate the landscape, followed by NDM. But you will see from this chart that NDM is a very potent and a very commonly found enzyme in the Indian subcontinent. Now, coming to the therapeutic aspects of it, unfortunately, none of the beta-lactamase inhibitors that you use, so whether it's tazobactam, sulbactam, clavulanate, avibactam, relibactam, vaborbactam, none of these beta-lactamase inhibitors are able to destroy the New Delhi metallo-beta-lactamase. And this is where the problem starts. So now I'm going to talk about, in the next 4 or 5 minutes, I'm going to be talking each about, how to tackle NDMs, which are produced by Enterobacteriaceae, Pseudomonas, and Acinetobacter. So if you look at Enterobacteriaceae, so by Enterobacteriaceae, I mean Klebsiella, E. coli, Enterobacter, Citrobacter. Now what happens is that epidemiologically, you will commonly see that organisms which are resistant to beta-lactams by production of NDMs are also resistant frequently to fluoroquinolones and aminoglycosides. So what options do we have? One is a polymyxin or a colistin-based therapy, but there are certain caveats to it. One is that we must confirm the polymyxin MICs because the automated systems that we use in many of our hospitals can underreport or underestimate the polymyxin MICs. So we must always confirm it by broth microdilution methods. The second question is that, if the MICs are acceptable, is combination therapy always required? So polymyxin-based combination therapy has stronger evidence for Enterobacteriaceae. It has decent evidence for Pseudomonas and not much evidence for Acinetobacter. So Enterobacteriaceae has pretty robust and pretty strong evidence for combination therapy. So the general recommendation is to go ahead with combination therapy when we have such a scenario. But the question is, which agent should be used as a combination agent? So if I'm using polymyxin, should the automatic choice be meropenem? The answer is no. If you have very high MICs, let's say MICs of more than 16 or 32, you should not automatically combine polymyxins with meropenem. So the second agent that you're using really depends on the MICs and MICs relative to breakpoint. So the closer these MICs are to the breakpoint, the better it will be when it is used in combination therapy. Also, other factors like cost, toxicity, site of action, they all have to be considered. The other very attractive option for tackling these infections caused by Enterobacteriaceae producing NDM is what is known as Zavicefta plus Astionam. So why do we use Astionam? Astionam has to be used as the backbone because it is not destroyed by NDMs. So if it's a pure NDM, let's say E. coli producing only NDM, I can use Astionam monotherapy. If it is producing other enzymes, let's say for example CTXM or OXA48, I need the avibactam there to destroy those enzymes. Otherwise, they will destroy my Astionam. So that is why I need the avibactam in case these are multiple enzyme producers. But for a pure NDM producer, Astionam should be susceptible. I've already mentioned briefly, so there are different concerns related to polymyxins, pharmacodynamic concerns, toxicodynamic concerns. In India, are we getting accurate MICs? We are not doing colistin levels. So, are we knowing what areas under the curve we are achieving? So there are numerous concerns. So that's why there is emerging data. So for example, if I have Enterobacteriaceae and if I have other options, let's say BL-BLI based options, that therapy might be better than using polymyxin based therapy. Of course, we have to keep in mind that not many of these studies have included NDMs and that therefore we need studies in NDM producers comparing Astionam plus or minus avibactam versus polymyxin based therapy. But right now it looks as if we are heading towards moving away from the polymyxins. Now, if you look at Pseudomonas, this is a completely different bug because it can have many non-enzymatic mechanisms of resistance as well. So what are my options? One is, of course, using polymyxin-based therapy. Again, go back to the basics, confirming polymyxin MICs. In case of Pseudomonas, is combination therapy always required? So the answer is that the evidence is there, not as strong as Enterobacteriaceae, but stronger than Acinetobacter. Now, what about using something like ceftazidime avibactam plus Astionam? Now, here we are using avibactam for AMP-C because Pseudomonas can produce AMP-C, which can be difficult to detect. However, we have to keep in mind that there could be many non-enzymatic mechanisms such as efflux pumps or porin-mediated resistance. And that's why we always need to confirm, especially when there are efflux pumps, whether ceftazidime avibactam plus Astionam is going to work. So that's why we should always test for synergy. So combine ceftazidime avibactam plus Astionam and really test whether this combination is susceptible. Now, another interesting option is combining ceftazidime avibactam plus fosfomycin because it works on the PBP-mediated mechanism. So right now, polymyxin-based therapy is a robust option. Once we confirm the MICs and have, especially if we have a decent second agent to combine with it. Otherwise, we have to make sure that, the BL-BLI combination has been tested in the lab. When it comes to Acinetobacter, something like Astionam plus or minus avibactam is a poor choice. The reason is that Astionam is not a very good anti-Acinetobacter drug, and avibactam does not destroy many of the enzymes that Acinetobacter produces. So usually for these infections, polymyxin therapy remains the backbone, provided the MICs are acceptable. Now we no longer use the term polymyxin susceptible. It is either polymyxin intermediate or resistant. So if the MICs are acceptable, then polymyxin-based therapy can be the backbone. the evidence for combination therapy as far as Acinetobacter is concerned is not that strong, and we'll hear about it later in the day. There are other options for which we must test. So minocycline, tigecycline should be tested. We must keep in mind that sulbactam also can be a useful agent, especially when used synergistically. So again, these are the caveats about treating Acinetobacter producing NDM. There is some hope on the horizon. We might have cefepime, zidibactam in the years ahead. So zidibactam seems to be a better BLI compared to avibactam when it comes to tackling these NDM producers. And of course, cefidericol is a real hope because it can sort of counteract bacteria producing NDMs and also has anti-pseudomonas and anti-Acinetobacter activity. But for now, our options are limited. So we must utilize all our microbiological and ID resources and come up with good strategies to tackle these difficult infections. So again, thank you very much for having me, and I look forward to the question and answer session.
Thank you, Dr. Parikshit, for that excellent talk. And I will now hand over to you for some take-home messages from you. Thank you, Dr. Parikshit.
Yes,
yeah.
Thank you so much, Khalid sir. Yes, so I think, there are three important things when it comes to dealing with these organisms. One is that we have to know our enzyme. So we have to first know that we are dealing with an NDM, in order for us to devise strategies. The second is that the approach to different bugs is different. So how I would approach an E. coli producing NDM would be different from how I would approach a Pseudomonas producing NDM. So there are different approaches for different bugs and different approaches for different enzymes. And of course, we have to create a robust microbiological infrastructure to sort of detect all these things. The other important thing is polymyxin caveats. We have to know or become a little bit more comfortable and conversant with polymyxin dosing. What are the kind of AUCs we are likely to be achieving? A good MIC testing. I think we really don't have access to good MIC testing for polymyxin in a lot of labs across the country. So these are the kind of things that we have to work on, if we have to tackle this problem of gram-negative resistance better. So again, one size doesn't fit all. We have to know the bug, we have to know the enzyme, we have to know certain polymyxin caveats. And the automatic option is not polymyxin plus meropenem. The combination therapy has to be decided on a lot of things. For example, MIC, site of action, cost, toxicity, etc. So I think these would be the key points to remember when we are dealing with these infections.
Thank you, Dr. Prayag. As there are no more questions, we will now go on to the next talk.
Thank you.
Thank you. The next talk is on adjunctive antibiotic nebulization for VAP by Dr. Ravindra Mehta. Over to you, Dr. Ravindra Mehta.
Hi, my name is Ravindra Mehta, and I'm the Chief of Critical Care and Pulmonology at Apollo Hospitals in Jayanagar, Bangalore. My topic for today is aerosolized antibiotics as adjunctive therapy for VAP. To try to understand this, we must ask the question, why aerosolized antibiotics? And the advantage is similar to what was done for inhalers over the years. If there is high intrapulmonary concentrations and low systemic absorption, you may be having a combination of more local effectivity and less toxicity. And that is why these agents came up as we ran into a paucity of antibiotics for MDR infections. At the same time, if you can reduce antibiotic usage, you may promote antimicrobial stewardship. Characteristics of these agents, well, they have to be safe, so they should be compatible with the airway. They should penetrate and go into the local area, which has always been a bone of contention. And at the same time, typically because of the nature of the science, antibiotics with concentration-dependent effects like aminoglycosides were typically chosen for aerosolization, with the newer agents coming down the line. What is the background and evidence trail for this particular strategy? Well, ad hoc medicine where people ran into desperate measures with MDR bugs. These agents have been used for a long time. As we said, it used to be the aminoglycosides, but a bunch of other agents as shown have been used. And there is a paucity of categorical definitive data to show us that this is going to be a standard strategy. So let's look at the data in the last decade, which has actually thrown light on all these aspects. We start over here with the 2015, where we have a systematic review looking at all the papers so far. And over there, we realized that in these 12 studies, there was higher rates of clinical cure. You note all these endpoints. higher rates of clinical cure, but not much of microbiological cure or duration of mechanical ventilation. So usually you want to look at A, B, C, and the holy grail mortality, which is so difficult to prove. And in the forest plot over here, it's quite evident that the meta-analysis favors nebulized antibiotics, as shown over here. Then the scene shift to 2016, where the first RCT of amikacin combined with fosfomycin comes for VAP. My eminent investigators, they have around 140 patients, 70 roughly in each group. They follow clinical criteria of CPIs. No bronchoscopy here. It's CPIs over there, and they look at the same endpoints and find no difference in mortality, clinical cure, or ventilator-free days. However, the subset analysis shows them that there is a tendency towards fewer positive cultures. So there is microbiological improvement on days 3 and 7, and there's a whole argument on why that happened. But by and large, this tells us that this specially given combination by a robust system doesn't seem to be having much of an impact in an RCT. And the same thing is reflected in the chart over here, where 3 and 7 days, there's a difference in microbiological eradication, but nothing else is relevant in this particular analysis. Then comes the next year, we have another meta-analysis looking at 11 studies now. And these also focus on the fact that these drugs have been associated with a concern of resistance coming in your ICU. And they say that actually, no, you will have less resistant, and further go on to add that in resistant pneumonia, you'll have higher clinical resolution, may not in susceptible pneumonia, but in resistant pneumonia for sure. And the same thing gets reflected over here where the plot favors nebulized antibiotics. So consistently we're getting a signal that some impact is there on at least soft, if not moderate endpoints, though the RCT of amikacin and fosfomycin does not pan out. And then comes a recent one. Michael Niederman has led this study, which it's a robust, probably the most robust study is looking at amikacin again as an adjunctive drug in gram-negative pneumonia, large number of patients, and again, to cut a long story short, no between group difference in survival and no increased side effects when you look at the two groups over here. And so over here, you realize that at up to 28 days, there's no survival advantage using amikacin. Again, it's an amikacin-based RCT, which showed it's not of much use. Recently, close to that time, a very interesting large analysis comes which looks at fancy statistics and looks at every study done so far short of the amikacin study, which we showed. And it tells us that if you look at comparison with systemic antibiotics and then inter-aerosolized agent comparison, aerosolized Tobra and colistin increase the rate of clinical recovery compared to systemic antibiotics. And over here, listen carefully to this, tobramycin seems to be scoring over amikacin. So all the trials were done with amikacin, not much with tobramycin. So is it that we're seeing a bias over there against the drug because of the choice of agents used in the RCTs? Here the ranking comes as Tobra better than colistin, better than amikacin when it comes to clinical recovery. What about, and so this graph also reflects similar things over here, where tobramycin scores over there. What about microbiological eradication, the second endpoint? Again, colistin over here seems to be better compared to systemic antibiotics, and they're not very different. And it's difficult to explain why, but clearly here, when it comes to killing the bugs, because of the high level of agent in there, all of them seem to be doing a similar job. And this graph also shows that with the edge of colistin when it compared to systemic antibiotics. What about mortality? Again, there is no statistical difference between aerosolized amikacin and colistin compared to systemic antibiotics, but tobramycin has some advantage. And again, tobramycin seems to be a little better than colistin or amikacin when it comes to a signal towards mortality. So a lot of data to basically tell you that if you look at the clinical endpoints of microbiology, of clinical recovery and mortality, there is a signal, and the signal seems to be more for tobramycin and for colistin compared to amikacin, hence partly explaining why amikacin did not succeed in the RCTs. How do you deliver these? There's a science and art which can also confound the studies. It's based on the size of the particles. You have to connect it correctly to the appropriate limb of the Y connector. At the same time, synchronize with the patient's respiration, and the vibrating mesh nebulizer is supposed to be the best. So this is very important to maximize the impact of the antibiotic and get the desired effect. What has our experience been in COVID-19 and aerosolized antibiotics? By and large, we found a lot of tracheobronchitis and MDR infections, and midway through our bronchoscopic sampling, we then changed to inhaled polymyxins, which again reflected the data in terms of better microbiological and clinical recovery, but we also could not demonstrate a mortality benefit. And this is the preprint which has been submitted for consideration for publication. What do guidelines say? Guidelines soft pedal it. Guidelines say that you may use it when you have MDR or PDR bugs over there, and this is 5 years old. And again, they don't leave it as a strong recommendation, but don't let the science get thrown out also. As they say, you can't rule out these agents completely. And in the agents, prefer colistin over polymyxin B. So what is the take-home message in these 10 minutes epitomizing around 30 years of these drugs? Adjunctive aerosolized antibiotics in VAP. Why do it? High local concentrations and point of care delivery, hoping to get a better eradication of bugs and other endpoints. The candidate drugs are by and large over here, the aminoglycosides and colistin. These tobramycin and colistin have always been in most analysis favoring, having an edge over amikacin, which has not stood the test in RCTs also. Endpoints are very important. If you look at the softest one of bacteriological cure, you'll get somewhere. Clinical cure, there's a definite edge. Mortality, which is so difficult to demonstrate in ICUs anyway, also similarly does not pan out when it comes to aerosolized antibiotics. How administered is very important, and that will directly lead to these endpoints over here. And you have to be careful to use the right nebulizer, which is partly the reason the study showed it did not work. There is hardly any side effects, and in fact, the original resistance worries are going in the opposite direction. And if it helps to reduce systemic antibiotics, it may reduce resistance. And the current role, to summarize the talk, is debatable and controversial if you look at it from a purist point of view. As a practicalist, it's an adjunctive role with systemic therapy for PDR organisms, incorporating the science we talked about. And of course, in patients with associated structural and disease like bronchiectasis, and the COPD, with especially VAP, it may have a greater role to play. With this, we end the talk. Thank you very much for the attention, and have a lovely meeting.
Thank you, Dr. Ravi Mehta, for that excellent talk. As there are no more questions, thank you, sir. We'll go on to the next topic, which is controversies. The first talk in that is piperacillin tazobactam versus carbapenem for less severe ESBL infections. The talk is by Dr. Rajiv Soman. Over to you, Dr. Soman.
Indeed, a great pleasure to be speaking to you on this platform of Sepsiscon. And the topic which we are going to discuss today is when do you use the beta-lactamase inhibitors, and when do you use the carbapenems? Should the carbapenems be used in each and every infection, or should it be reserved only for the serious ones, and the BL-BLI combinations for the milder ones? Let's see what we can discuss in this particular talk. With this, I will start my screen share. Okay, so this thing, whether the BL-BLIs or carbapenem should be used for ESBL infections. All of you know what this is the extended spectrum beta-lactamase, and this has been under continuous debate. And the debate is there because it depends on your viewpoint. If you look at it from one side, you see this. If you look at it from the other side, you see this. So the question is, which one out of these is correct and which one is wrong? And probably the answer is, it depends on your viewpoint. What are we looking at? So this is the particular debate which we are talking of. And before that, let me tell you that the goal of antimicrobial stewardship is to maximize the outcome for an individual patient and at the same time minimize the selection of resistant organisms. Most clinical trial data on this BL-BLI versus carbapenem debate has been interpreted in such a way that carbapenems are to be preferred over the BL-BLIs for all the ESBL infections. However, I'll submit to you that can we select this therapy in a much more nuanced fashion or in a very granular way? And can this carbapenem sparing strategy actually help to reduce collateral damage and prevent the emergence of carbapenem resistant organisms? We had done this study long ago, and we had a poster in 2007. So this was looking at outcome of treating infections due to ESBL producing organisms with non-carbapenem antimicrobials. And this was only an observational small study. And our conclusion was that it was possible to successfully treat at least the less severe infections by non-carbapenem drugs. And this we thought will probably reduce the cost, because that was a time when BL-BLIs were much cheaper than the carbapenems, and perhaps minimize collateral damage, which may help to preserve the efficacy of carbapenems against increasingly resistant organisms. And remember, in 2007, carbapenems was the last word for the resistant infections. Now, why this debate came up is because the difference in the efficacy between BL-BLIs and carbapenems is relatively narrow. And therefore, we have kept debating this issue endlessly. However, the organisms have not remained silent and resting, but the raw and restless power of the microbes led to carbapenem-resistant organisms becoming more common. So what we actually feared did happen. And these were some of the studies which we did and a letter which we wrote. And the title of that is interesting. So NDM, or New Delhi beta-lactamase, is the treatment options with carbapenems getting compromised. And have carbapenem at their doom? These were the questions which we had posed at that time. And then once you have the carbapenem-resistant organisms, you already know what is used for the treatment. So that what is needed for the treatment is no longer debatable. We had a larger study which we had published in JAPI, and that was in 2012. And this was 522 consecutive Indo patients during these periods were treated who had true infections with ESBL producing organisms. However, it was an observational practice observation study. So antimicrobials were prescribed or changed by the treating physicians on the basis of the nature and severity of infection, susceptibility of the organisms, and actually even the affordability of the patient. So this was definitely an important issue way back in 2006 and 8. Patients who received carbapenems were in the carbapenem group. Those who never received a carbapenem at any time were in the non-carbapenem group. And what we really found is it was possible to treat at least the less serious infections due to ESBL producing gram-negative organisms with non-carbapenem antimicrobials. And what we speculated was that this was not going to compromise outcomes, but will likely result in restricting the use of carbapenems, which we wanted to preserve at all costs, which may help preserve their efficacy against increasingly resistant organisms. A large number of similar studies, which are better designed than the ones we did, have appeared in the literature. I have picked 2 studies for you to discuss. So these, why did I pick up these? These were actually in the same issue of Clinical Infectious Disease Society. And they are looking at the same problem, but they come to opposite conclusions. And this is why the debate is continuing endlessly. So what did the first one from Spain say? That these results suggest that both ampicillin clavulanate as well as pip/tazo are suitable alternatives for carbapenems for treating patients with bloodstream infections due to ESBL E. coli, if they are found to be active in vitro, and would particularly be useful as definitive therapy. On the other hand, in the same issue, we have another study which says that carbapenem therapy is associated with improved survival compared to pip/tazo for patients with ESBL bacteremia. Look at it, both the studies are looking at bacteremia. And there, the conclusion is pip/tazo appears inferior to carbapenems. For patients with high risk of invasive ESBL infections, early carbapenem therapy should be considered. However, they also say that our findings should not be extended to some of the BL-BLIs in development, the later generation ones, as there is limited data which is available. So which of these studies is right? And that is the question which we need to consider in depth. So it's not a question whether one of these trials is false, rather how both these trials and results from these trials may be true. So both these studies are observational. They are methodologically sound. They are not RCTs, but they are still methodologically sound. They used a propensity score to overcome the selection bias. And mechanistically, if you see, it's BL, BLI, both are beta-lactams as well as the carbapenem. So there's no clear difference in the mechanism of action between these two treatments. So why is it that the results are diametrically opposite? And then the answer lies in looking at the fine differences between these two trials. So what were the differences? The source of the bloodstream infection was urinary or biliary in the first trial, as against CRBSI or catheter-related bloodstream infections and pneumonia in the other. So obviously, these in the one in the second group are more difficult to treat. The organism was E. coli in the first versus E. coli along with Klebsiella pneumoniae, Oxytoca, as well as Proteus in the other. Molecular mechanisms such as CTXM sequence type 131, which is, remember, a highly virulent sequence type, that the presence of other ESBLs, and what are those? PER, OXA, VEB, JES, MC, hyperproduction of some of these enzymes, efflux, by which the organisms are going to pump out the antibiotics which is trying to enter inside, porine channels which contributes to membrane impermeability, all could have added more complexity to these particular different organisms. And maybe checking for these and balancing for all of these could have helped over and above what was used in the trials, and that was they were using the current low breakpoints for these BL-BLI combinations. Then came this study in 2018, and this attempted to stop this controversy once for all. Question is, did it do so or not? So this is called as the famous Merino trial. So here the effect of piperacillin tazobactam versus meropenem was seen in both E. coli as well as Klebsiella pneumoniae bloodstream infections who had ESBL. So they had ceftriaxone resistance. And what's the conclusion? Among patients with E. coli or Klebsiella pneumoniae, definitive treatment with pip-tazo compared with meropenem did not result in non-inferior 30-day mortality. So, you are now familiar with this kind of terminology. So what is non-inferior actually means it is what is not non-inferior means it is inferior. So these findings do not support the use of pip-tazo in this setting. So this trial was thought that it will settle this controversy, but like all good trials, did it settle the controversy? Did it provide answers, or did it raise even more questions than it provided answers as a result of the trial? And so what are the questions which come up from this trial? So they were talking about bloodstream infections only. So our question today is, will pip-tazo remain equally effective as meropenem for patients who are having UTI or other infections, but without bloodstream infections? In other words, these are relatively milder infections. Or those patients with low mortality risk, which perhaps depends on their immune status and other factors. Or are the carbapenems going to be more effective than the pip-tazo even when the patient is at low risk? This is the question which still doesn't have an answer. Now, if source control was achieved in these patients who had complex sources of bloodstream infection, so we had those patients who had biliary tract disease and so on, if they had a surgery, would it have altered the results? The other question which can come up is, would a higher dose and prolonged infusion of pip-tazo? Now, we remember that pip-tazo dose which was used in this trial is probably less than what we are tuned to using, such as 4.5 grams, maybe 6 hourly, and that too given as a prolonged infusion. And the question remains whether this dosing strategy would have been more effective. One more question which comes up is, maybe you may begin with a carbapenem, but is there a chance of de-escalating therapy from a carbapenem to pip-tazo, even if it has not been initially used? And obviously, we are concerned with using drugs for a long time. We are concerned with de-escalation strategies which will aid the antimicrobial stewardship. So this is also an important clinical question. The other question is whether this question was only related to pip-tazo. But we have a host of other drugs, other BL-BLIs with us today. And the question is whether they would be more or less effective than peptazone in this situation. So you have cefoperazone, sulbactam, which we use quite commonly. So there are some issues with this drug. Intrinsic activity of cefoperazone is probably not so good. On the other hand, we might be having additional OXA enzymes against which cefoperazone and other cephalosporins are relatively more stable than the penicillins. What about cefepime tazobactam? Yes, if you have that organism is also producing a low grade producer of AMP-C, then cefepime is actually more stable to AMP-C, which is another type of enzyme, not strictly a ESBL, but often it is present in some of the organisms. What about the new one, the avibactam? So avibactam is very stable against all the types of beta-lactamases, including the OXA48, although not stable against the NDM or the metalloenzymes. And what about finally this ceftriaxone sulbactam? Now we know that the kinetics of sulbactam and ceftriaxone don't match very well. And if we are talking only of the ESBLs, then EDTA obviously is not contributing anything to treatment of ESBLs. We are not even very sure whether EDTA has any contribution for treating metallos because we don't know whether that concentration of EDTA is going to be enough for that. We also have a big question that if it is not NDM, but it is an OXA48 mediated carbapenem resistance, how is it that EDTA can even theoretically work? Besides that, there are other practical problems. We do not have validated breakpoints for the use of this compound, and there are many other controversial aspects. The question is, this trial was looking at meropenem, but are there other carbapenems which would have been either more or less effective? So that is another question. So meropenem, remember, has been kind of a workhorse carbapenem for us. We have used it in a large number of patients with large doses, sometimes 2 grams 8 hourly or even higher than that. So imipenem probably is equally effective, but it has a different mechanism of resistance. So if there's a porin channel mutation, imipenem is not going to be working. Besides, its tendency for producing seizures is somewhat higher than meropenem, and therefore we really don't use high dose imipenem in the same fashion that we use high dose meropenem. So this becomes a controversial issue. Almost the same thing is true for doripenem. The standard dosing is very less. Probably it needs to be dosed at a much higher level, but again, there is no standard recommendation for that. And ertapenem is given once a day with 1 gram as the dose, but it is very highly protein bound. And there is no experience of increasing the doses of ertapenem as there is a good experience of increasing the doses of meropenem. Now, the final question is the use of carbapenem going to contribute to more and more collateral damage? So in this particular study, the Merino trial, they found that it actually did not lead to more superinfection with other bugs as well as with Clostridium difficile. So that did not happen in the same patient. So there was no difference in these superinfections between the BL-BLIs and the meropenem. However, this still doesn't answer the question, what is happening to the overall ecological impact? Maybe in the same patient, superinfection is not more with the carbapenem, but will it not affect the rest of the flora in the ICU, in the outside environment? So I'll summarize this whole discussion by saying that this battle continues. So what are the factors which we would consider? So if it is a mild to moderate, it is possible that BL-BLIs can be used. Carbapenems may not be really superior in that mild to moderate category. On the other hand, if it's moderate to severe, there is very clear evidence that carbapenems will have to be used. Now, what do we really mean by that? We look at the immune status of the patient. If the patient is immunocompetent, then maybe you can try the BL-BLIs, but if he's immunocompromised, it's basically the demand placed on the performance of the antimicrobial becomes much higher in a patient who is immunocompromised, and therefore you might possibly want to use carbapenems in preference to the BL-BLI in that situation. What about the site of infection? Urine, skin structure infections, intra-abdominal sites with good source control. So if you have relieved the obstruction, if you have done debridement, if you have also done resection, anastomosis, and so on, maybe you can get away with this. On the other hand, if these are the infections such as bloodstream and pneumonia. And in these two situations, there is really no source control which you can do. In that situation, you should definitely want to use a carbapenem. Again, look at organisms. So E. coli traditionally have not been that resistant as compared to Klebsiella. However, that is also changing, and there are many new forms of E. coli where they have terrible amount of mutations apart from the NDM. So if it's E. coli, maybe BLBLI based on the Rodriguez-Banu study. However, if it is Klebsiella and Enterobacter, definitely be sure to be using carbapenem. Now, what do we consider as susceptible or resistant to pip-tazo? And that's also a subject of controversy. So if you look at the UCAS breakpoints, they consider something less than 8 as susceptible and something more than 16 as resistant. And this is much lower than the CLSI breakpoints. So I would suggest that we should be using for this particular decision, the UCAS breakpoints. If you have a really low MIC to pip-tazo, such as less than 8, maybe we can use pip-tazo, but if it is something more than 16, which will still be reported as not resistant by CLSI because their resistant breakpoint is much higher at 128. If we are able to use a high dose as well as a prolonged infusion, then perhaps we can think of using a BLBLI. Often the laboratory is going to make a remark that when you are going to when you are finding an ESBL, there may be a remark saying that suboptimal outcome may be possible, and that needs to be considered very carefully. So if you are going to look at what is happening to the patient, maybe you have initiated a BLBLI, but patient is not responding, you have to really carefully see that, and maybe on the second day or so, switch immediately to the carbapenem. And conversely, if the patient, you started off with a carbapenem, and if you find that a patient is improving, many of these other factors have been taken care of, patient is not really immunocompromised and so on, surely there is a potential for de-escalation, and maybe from a carbapenem to BLBLI may not be a bad idea at all. So really this debate is endless, but what can the clinician do? We still have to hold two opposite ideas in the mind at the same time and still function in our day-to-day clinical practice in the ICU and outside. And that is something which we need to bear in mind. With this, I'll stop here, stop my screen share. And thank you.
Thank you, Dr. Soman, for that excellent talk. As there are no more questions, we'll go on to the next topic, which is colistin combination therapy for an Acinetobacter infection by Dr. Ram Gopal Krishna. Over to you, Dr. Ram.
Dr. Ram Gopal Krishnan. I'm an infectious disease physician from Apollo Hospitals, Chennai. Give me a minute while I share my slides. Okay, there we go. Okay, so this is my topic for today, a combination therapy for Acinetobacter infections. Should it be used? These are my financial disclosures. I have no financial interest in any company making any of the drugs that I'll be discussing. And these are the companies with which I've been associated in the past. Now, Acinetobacter is by nature multi-drug resistant in the 21st century, and this implies susceptibility to only one or two antimicrobial classes, which means that you are stuck with very few drugs you can use against this pathogen. It's also a clonal pathogen, with about 50% of cases being part of a single international clonal complex. And it's also considered a low virulence pathogen, which frequently colonizes, but often causes significant infections as well, especially in compromised patients. This is a paper which we published about 6 years ago from my center. It's a longitudinal trend in the susceptibility patterns of Acinetobacter over a period of about 10 years. And you can see here that all the beta-lactams, including meropenem here in this green color, are really falling down to 20–25% or so. And if you look at the only drug which remains reasonably active, it is actually the polymyxins. Even tigecycline of late has lower sensitivities than we had. Then this is as far back as 2013, with the situation which is worse now compared to 6–7 years ago. Another problem we have with Acinetobacter, as in this paper, is that it is resistant by means of this BLA-OXA23. Now, OXA23 is a class C carbapenemase, and this means that it is not inhibited by BLBLIs like ceftazidime, avibactam, which you typically can use against E. coli or Klebsiella or so. It also has BLA-NDM1, but it also has multiple other mechanisms of resistance, including porin channels, efflux pump, enzymes that inactivate ESPLs. So it really has multiple molecular mechanisms of resistance, which is why it's such a difficult pathogen to treat. And in fact, it is classified as one of the pathogens where we don't have good incoming drugs. If you look at MDR Acinetobacter here, the only drug which may work is eravacycline, which is not available in India. The drugs available in India, like ceftazidime, avibactam, just don't work against this particular pathogen. Another issue when you're discussing treatment of Acinetobacter is that the colistin resistance is not always correctly done. If you look at isolates as per the CLSI, if your MIC is 2 or less, they call it intermediate, which means that the drug is likely to work only for urinary infections or for low inoculum infections. Always use broth microdilution, never disc testing. And the CLSI believes that we really shouldn't be using colistin for systemic infections because we can't achieve a level very much higher than 2. That is the rationale behind this intermediate level resistance reporting recommendation by them. And they always recommend using alternatives whenever alternatives are available, but that's easier said than done. In terms of Acinetobacter, you often rarely have an acceptable alternative. So this is my core topic today, combination therapy of Acinetobacter infections. Should we use it? And when we look at Acinetobacter, you can kind of look at 3 situations. If Acinetobacter is, say, carbapenem or any other beta-lactam sensitive, I think that's open and shut. Just use that one drug to which it's sensitive. If it's a carbapenem, just use carbapenem monotherapy, no questions asked. What is the usual situation we encounter in India? It is resistant to carbapenems and other beta-lactams, but it's polymyxin sensitive. So here the question asked is, do you use monotherapy with polymyxins or do you use combination therapy? Finally, you may have an unfortunate situation where it's resistant to everything, including polymyxins. And here really you're stuck in a no evidence zone. You just have to give whatever you can. And there's unfortunately only one large randomized controlled trial to inform this decision as to whether you use monotherapy or combination therapy. So a lot of poorly done retrospective studies and expert opinion. So these are your options for a multi-drug resistant Acinetobacter. You can go with polymyxins, which are usually a standard go-to drug for this organism. You can go with carbapenems, but then again, most of the time it's resistant, as I showed you earlier. And these are some of the other drugs which I'll briefly touch on, which you can use to treat Acinetobacter, perhaps in combination with polymyxins. First of all, colistin versus colistin plus meropenem. Does it work? This is the only combination for which we have a good randomized controlled trial. And you can see here that in this trial, they combined a stiff dose of colistin with an even stiffer dose of meropenem, 2 grams to 8 thali. Most of the infections were Acinetobacter, 77%. There was no significant difference in clinical failure, almost exactly the same. And the rate was similar, whether it was Baumani or other carbapenem-resistant infections as well. So the take-home point is addition of meropenem is unnecessary if colistin sensitive. And if you've started combination therapy, colistin plus meropenem, just cut it back to colistin alone once you have the DSTs. A retrospective study showed similar findings as well, that you did not prevent emergence of resistance in this in the same analysis. Actually, this was an analysis of this study where they look back and see whether it cut the prevalence of colistin resistance. Now, sulbactam is often used as an add-on agent. This is a beta-lactamase inhibitor, but in this case, in terms of Acinetobacter, it is effective on its own versus Acinetobacter, and that's why you use it. Remember, you never use it as monotherapy, and there's no susceptibility testing available, so you don't know whether it's going to work or not. And it's a big dose that you got to give every day, about 8 grams per day, whether you use it on its own or whether you use it in combination with cefoperazone or ampicillin. Tigecycline is another drug we commonly use versus Acinetobacter. It's important to remember that it does not work for primary bacteremias because intravascular levels are low. Most of the drug leaches out of the circulation. And there's also this black box warning about increased mortality if you use it as monotherapy. So perhaps it's best reserved for salvage or combination therapy. So use high doses if you're using tigecycline. There is a study available now using 200 mg per day for both Klebsiella and Acinetobacter. And if your MIC to tigecycline is more than 1, if it's 2 or more, please avoid the drug. So this is the study which looked at combination at high dose tigecycline containing regimens, although it was largely looked at Klebsiella was the pathogen they looked at. 200 mg per day seems to be the appropriate dose. For instance, VAP and including Acinetobacter isolates where it was as good as imipenem. Minocycline is another option open to you. This is approved now for treatment in combination against Acinetobacter, but look once again at the Acinetobacter MICs. This is the usual dose of minocycline, but then this paper says that if your MIC is 4, which is reported as sensitive, then the chance of your attaining adequate levels are low with 200, and even 400 is you just can't inhibit and isolate with an MIC of 4. So if you use minocycline, look at the Acinetobacter MIC, make sure it's 2 or less, and use a dose of 400 mg per day when you treat Acinetobacter. Can you combine rifampicin with colistin? This is an attractive concept, theoretically synergistic, but an RCT from Italy showed no benefit. 30-day mortality is not affected, more microbiologic eradication, but no difference in nephrotoxicity and more hepatotoxicity due to the rifampicin. So rifampicin and colistin combination therapy is out. This is a small retrospective study which suggested that combining a carbapenem with colistin was better than tigecycline for an Acinetobacter bacteremia. But then this is bacteremia. Why would you treat a bacteremia with tigecycline, which is a poor drug for bacteremia? So limited take-home message from this combination therapy. This is a large meta-analysis which looked at all studies on Acinetobacter. Do you give monotherapy or combination therapy? And they ranked colistin in combination with sulbactam as the highest rank among these three compared to colistin or TG monotherapy. If you combine these two agents, you had a higher microbiologic cure rate, but no significant difference in all-cause mortality. So we as clinicians want our patients to live. That does not change whether you use monotherapy or combination therapy. This international guideline on the use of polymyxins was basically expert opinion and a review of the literature. What it said was that if you have one other agent sensitive, you can use combination therapy. If you have only polymyxin sensitive, which is often the case in the Indian scenario, 8:7 in favor of monotherapy. Now, I don't know, that's as good as tossing a coin whether you use mono or combination therapy. There is a good drug in the market abroad, cefiderocol, which is a Trojan horse, which sneaks in through the siderophore channels. This is potentially active against Acinetobacter. So watch this space. It is now approved for VAP as well. So if this drug comes to India, it's a valuable addition to treatment of Acinetobacter infections. Another drug which is especially useful for intra-abdominal infections is eravacycline. Aceneto is rarely a cause of intra-abdominal infections, so perhaps limited utility in the current concept. So these are my recommendations on treatment of Acinetobacter infections overall when it's carbapenem resistant. First of all, decide whether you need to treat it or not. If it's not in the blood, it may just be a colonization. You don't need to treat it at all. Do source reduction, remove lines, etc. Most of the times you're stuck with polymyxin therapy. Look carefully at the polymyxin MIC. If that's less than 0.5, monotherapy is good enough in the majority of patients. There are some situations where you can use combination therapy. If your MIC is high, there's no way you're going to inhibit that isolate with the standard doses you use, however high you take the dose. If it's a severely ill patient in septic shock, again, similar concepts. Perhaps combination therapy. If you have persistent bacteremia despite monotherapy, yes, that's a failure of monotherapy. Or if you have severe pneumonia, which, the penetration of polymyxins into lung is often quite poor. And that's actually recommended by the CLSI that don't use this drug as monotherapy for pneumonia. So these are some situations where I would combine polymyxin with other agents. What are your choices as a second drug? High dose minocycline, that's double the standard recommended dose, provided the MIC is low. High dose sulbactam, that's really a lot of sulbactam you're pushing into your patients. Tigecycline against high dose. Look at other things as well. Anything that's sensitive on drug resistant on drug resistance testing, and it never harms to offer a prayer. So this is my final slide on combination therapy for Acinetobacter infections. If your carbapenem is sensitive, any other beta-lactam sensitive, just give that one drug. No questions asked here. The usual situation where other beta-lactams are resistant, but your polymyxin MIC is pretty good, then monotherapy for most patients, because clinically there's no trial showing that there is improvement in mortality. Consider combination agents if your MIC is high, severely ill patients, persistent infection, or if you have a severe pneumonia. And what about the situation when it's resistant to everything? Here it's really off textbook. You just have to look at the DSTs and use combination therapy based upon best guesses. So this is my talk on Acinetobacter infections. Thank you very much. I'll be happy to answer questions if there is time. Thank you.
Thank you, Dr. Ram, for that excellent talk. As there are no more questions, we'll move on to the next session. The next session is supported by Acumentis. It is on infections. The first talk is on empirical antibiotic choice for severe community-acquired pneumonia in India by Dr. Dhruv Chaudhary. Over to you, Dr. Dhruv.
Friends, today I shall be discussing over next 10 minutes about the empirical antibiotic choices for severe CAP in India. Let's have a clinical scenario. 68-year-old man with poorly controlled diabetes mellitus, 2-day history of fever and a productive cough confusion was brought to our emergency outpatient department. There was no recent history of hospitalization or use of antibiotics. There was no history of any vaccination in the recent past. On physical examination, patient had marked tachycardia, febrile, and tachypneic. On room air, the saturation was 91%, and the blood pressure was 100 by 70 millimeters of mercury. He was oriented only to the person, but not to time and space. On auscultation, he had the bilateral crackles on the both hemithoraces. Cardiac auscultation was normal. And on evaluation, we found that he had a marked leukocytosis with an elevation of blood urea. Serum creatinine was 1.4 and LFT was within normal limits. His X-ray presentation showed bilateral areas of patchy consolidation, dominantly in all zones, but dominantly in middle and lower zones bilateral. And there were a few patches of air bronchogram there. So a clinical diagnosis of community-acquired pneumonia was made in this patient. Now, the community-acquired pneumonia is a leading cause of morbidity and mortality. And the mortality rates are between 5 and 15% in hospitalized patients. And those who are admitted in intensive care unit can go up to 30%. There has been a little progress in the management of CAP since the widespread introduction of 50s with no new class of drugs as such licensed specifically for CAP. And there has been there is a little progress as far as reduction in mortality is concerned. Therefore, it is very important looking at it, which antibiotic we need to give to know the etiology of CAP. When you see it at the etiology of CAP today, there are both bacteria and viruses, and gradually viruses are taking a very important role. But primarily it is a streptopneumonia, which is the one which, again from the Western data across the globe, also is showing highest prevalence. Additionally, atypical bacterial antigens have also been seen up to 14 to 25% of cases. The viral agents, again, are not uncommon, especially now you must have seen, all of us know well aware about COVID-19, and before that influenza epidemics which were there, followed by bacterial pneumonias. Similarly, non-pneumococcal, non-atypical agents are also known, which is H. influenza. We also see with Moraxella catarrhalis, Staphylococcus aureus, and gram-negative rods are also an important point. And more so, now there's a multi-drug resistant rods which are coming up, and mixed infection polymicrobial is seen in people who are having an aspiration or the persons who are having actually lung abscess. When we see the data from the Indian context, which was published in 2013, strep pneumonia again is the commonest, but majority of the people we were not able to have organisms. Legionella was only in 2%, but what is important for us to remember is Mycobacterium tuberculosis was in 7% of the cases. Therefore, it has a very important implication in terms of selection of antibiotics in our country. Incidence of plasma pneumonia as an etiological cap in India was found to be 35%, which is a very high incidence. But I think there's a lot of this primarily has been on the antibody basis. Legionella pneumonia also has not been seen more than 2%. Another important organism which is taking a lot of attention nowadays, especially from the South India, and also started coming to the Central India, is the melioidosis, especially people who are extremely sick, hospitalized in the ICU settings. So when you have it after knowing the knowing the organisms which are commonly responsible, we need to know under what circumstances which particular organism predominates, because that also tells us in terms of and helps us in selection of antibiotics. Strep pneumonia is the common one. You can see it in persons of smokers, COPD, low social economic status, but across the board, this is the commonest one which we see in general population. Pseudomonas is sent when you have a structural lung disease, gram-negative bacillus states when persons are coming in a regular contact with the hospital or the nursing homes. Along with it, if they have been in the hospital for a long time, along with diabetes is the constant comorbid factor, which you will see, and also in chronic aspiration. Staphylococcus aureus is not as common in it, but post-influenza is not an uncommon scene. Drug abusers, diabetes, renal failure, again, common cause. Community-acquired MRSA, again, in the previous influenza infection, or if somebody has got a skin infections. When you start looking at Legionella, chronic steroid use, hematological malignancies, and especially fumes and the building materials, when you're around humid weather, etc., you tend to see it much more commonly. Anaerobes, again, high dental plaques, index of periodontal disease and aspiration are the common causes and responsible primarily for lung abscess. As far as the Burkholderia pseudomyelite leading for melioidosis is concerned, you commonly see in the farmers, hot, humid environment, diabetics, alcohol abuse, and people who are explorer. And anybody who comes to you with a severe septic shock or has multiple abscesses, please do think in terms of melioidosis and the causative organism Burkholderia, which is a gram-negative organism. People tend to put it non-fermented, and you need to talk to your lab about this particular case. Therefore, from this discussion, we have three pneumonias, which are three major etiological agents, that is bacterial pneumonias, atypical pneumonias, or you can have non-bacterial viruses, which are the key. And in this case, when you start seeing it in terms of the viruses, what we find it up is COVID is now becoming important, so is the influenza, para-influenza virus. But today, primarily discussion is related to bacterial pneumonia, where we see hyperacute presentations. Patients may have a septic shock. They may or may not have upper respiratory symptoms, and they have a significant leukocytosis or band cells, and they will have a segmental lobar consolidation with high levels of biomarkers like procalcitonin. Atypical pneumonias, we will say the factors which will not present in bacterial pneumonia, family clustering is known, and will the cough more than 4 to 5 days, and absence of sputum production. And commonly we tend to see in younger individuals and will have a normal procalcitonin values. So our patient had a hyperacute presentation. He had a septic shock, absence of respiratory symptoms. He had a significant leukocytosis and also had a death segmental lobar consolidation bilateral, and his procalcitonin levels are high. Therefore, this patient had bacterial pneumonia. Now, when you start looking at it, you need to stratify and classify these patients on the basis of severity. Multiple scorings are there, but we tend to see commonly the BTS guidelines on CUB or CRB when you remove the urea. In this case, what is very important is that as the risk assessment you do in these patients, they go higher and more risk factors, the probability of severity increases and mortality also goes up. And in this case, the choice of antibiotics also changes. And if you realize that the person at the highest risk, the severest of the case, you use combination antibiotics, whereas the person at the low risk of death or hospitalization, simple monotherapy is used in those cases. So key point in the treatment of community-acquired pneumonia in terms of antibiotics is when to initiate antibiotic, what should be the initial choice, what about de-escalation, switching over to oral, and the duration of antibiotic treatment. Timing of antibiotic, there's no doubt about multiple studies are coming up, and this meta-analysis published in JAMA clearly shows earlier the treatment start, favorable is the outcome. Therefore, ideally speaking, we must preferably start treatment once patient reports to us within less than 4 hours, and preferably the first shot of antibiotic be given in the emergency itself.
then come up which should be the initial antibiotic of choice as we discussed. We have a different guidelines, including Indian guidelines. I will talk about it later. If you see, there has been 3 major groups which are being discussed. That is beta-lactam, beta-lactam, beta-lactam inhibitors. Along with it, you can have a respiratory fluoroquinolones and macrolides. So the patients who have got a severe one all across the board is using and recommending combination therapy. And wherever the person having a high, in patients in intensive care units having a high severity, again, we are using beta-lactamase with beta-lactam inhibitors along with macrolide. In the European world, in the North Atlantic, they prefer respiratory quinolones, but the British, like us, have been using much more macrolide and respiratory fluoroquinolone as an alternative. And Europe also, instead of the beta-lactam, they're going for the 3rd generation cephalosporins plus macrolide. In the broader term, they also come under the heading of cephalosporin and beta-lactamases. And respiratory fluoroquinolones with or without a 3rd generation cephalosporin are used if person is sick or where you have some contraindications to use them. This is a summary of all guidelines which are there. And this is where the first time the chest societies of India, they came up and what should be the antibiotic therapy in intensive care unit setting or in the severe. Again, we are talking into the beta-lactams and which include 3rd generation cephalosporins, or they can have a beta-lactam with the beta-lactam inhibitors, plus a macrolide for patients without risk factors, without Pseudomonas aeruginosa. But if you have a Pseudomonas aeruginosa where structural diseases are concerned, or past antibiotics have been given, or you're suspecting ESBL, therefore we are using nowadays ceftazidime with BLI, or you can use the anti-pseudomonal penicillins like piperacillin, tazobactam, or you can use also cefoperazone sulbactam. Alternately, carbapenem can also be used like imipenem or meropenem. Combination therapy must be preferred in the settings of Pseudomonas with an addition of aminoglycosides, or if there is no contraindication, no evidence of tuberculosis, then quinolones, especially respiratory quinolone acting against Pseudomonas, should be used. Now, when you use fluoroquinolone, it is important that we must rule out tuberculosis, and 7% of our cases of CAP have turned out to be TB. So all the patients who are admitted with you with a severe tuberculosis, with a severe CAP, and having some evidence to suggest cavitation in the upper lobes or has a family history of TB, please do rule out TB by gene expert and the cultures as put on AFB smear examination. Indian Society of Critical Care Medicine also came up with the guidelines for the intensive care use, for the use of antibiotics in ICU. In that, Dr. Kelani and Dr. Zerpe played an important role. What is very important is that empirical therapy needs to be given, and that choice of empirical for the CAP again has to be against common etiological organism. It is a 2A recommendation, data is moderate, and strong recommendation has been there. Initially, must give combination of empirical agent against common causative organism. That's again, I'm saying, so that means you need to cover pneumococcus, you need to cover atypical organism or atypical bacteria. Non-pseudomonal beta-lactamases need to be used, which is amoxiclav combination in common, or you can use even ceftriaxone, sulbactam, etc. With the macrolide in this, you can have azithromycin, or you can use clarithromycin. If you suspect septicemia, clarithromycin is preferred. Respiratory fluoroquinolone, etc. are not the first line of treatment. We should use it later, only if there is no evidence of TB. Similarly, Pseudomonas is a consideration, then we will use anti-pneumococcal as well as anti-pseudomonal antibiotics. Combination therapy is to be considered. Again, 2 doses have to be given. One is that of a beta-lactam inhibitor with anti-pseudomonal property like piperacillin, tazobactam, with aminoglycoside like amikacin or gentamicin, or with the anti-pseudomonal fluoroquinolones, which turns out to be, in this case, ciprofloxacin or moxifloxacin, or the new quinolones which are coming up. And if you're suspecting methicillin-resistant staphylococcus especially, and they have, there you need to consider vancomycin as a first line or alternate is teicoplanin. If both are not there, you can use linezolid B, but be careful in diabetics because it comes in dextrose solution and persons who are having thrombocytopenia. And now this is a reserve duct for TB, so we need to be careful. Good anaerobic cover is provided by beta-lactam inhibitors like amoxiclav, clindamycin, or moxifloxacin. Same can also be provided by meropenem, so you don't need to add anything additional for it, for anaerobes in these cases. So the treatment risk of Pseudomonas aeruginosa, again, I'm re-emphasizing, treat with 2 antibacterial medications. But this empirical management must also cover strep pneumoniae and atypical organisms. Failure to identify pathogens will not lead to any alteration or an outcome provided the choice of empirical antibiotic is appropriate. Antibiotic de-escalation again is the key, and the use of broad-spectrum antibiotics can cause C. difficile, etc. As de-escalating practice is now a major element of antimicrobial stewardship program. And we are finding that procalcitonin is playing an extremely important role in de-escalation. Ideally, we should depend upon the series of tests rather than on a single test, so the cost of the treatment does go up. That's one important challenge which comes up. But nevertheless, we commonly see that procalcitonin, more than 80% of these patients in area under curve is 0.8% or so. So has a reasonably good sensitivity specificity, and we can follow it up. And we do expect that it will gradually go down and turn normal, and we can use it as to de-escalate the treatment. Similarly, if it is negative and becomes positive, in a person who is having a chest shadow, you can think in terms of bacterial pneumonias or bacterial infections. And similarly, as it is declining, it can also tell us is the time to switch over to oral as well as to reduce the duration of therapy. Switching over from intravenous to oral antibiotic therapy is as important. Once person is 72 hours of inpatient antibiotic therapy, has no cough or breathlessness or has significant improvement, becomes afebrile, has a normalization of white blood cell count, taking adequately and good GI absorption is there, and room air saturations are more than 90% with the normal blood pressure, no tachycardia, respiratory rate has settled down, and there is no confusion, then probably is the time to switch over from intravenous to oral therapy. And the data consistently shown that this is a good practice point and it reduces the cost of treatment without causing any increase in mortality and morbidity. As far as the duration of antibiotic treatment is there, the new antibiotic mantra is shorter is better. And again, the data is showing up, this is from the JAMA, where they showed that 5 to 7 days treatment is as good as giving 10 to 14, but in Pseudomonas and drug-resistant proper Acinetobacter, you may use up to 2 weeks of treatment is required in those cases. So the case continues. Our patient was admitted in intensive care unit. We gave him ceftriaxone along with azithromycin. Patient improved, and he was shifted to the high dependency unit and discharged in a stable condition. So this is how we practice up. And after 4th or 5th day, we tend to put these patients on oral beta-lactam inhibitors like amoxiclav in these cases, along with azithromycin, given for 5 to 7 days. So the commandment for antibiotic treatment for CAP are antibiotic therapy should be initiated preferably within 4 to 8 hours of hospital arrival, in emergency preferably. Empirical antibiotic therapy should cover both typical and atypical bacterial pathogens. Antibiotic de-escalation is effective in reducing length of stay. Objective measures of clinical stability can promote rapid transition from intravenous to oral antibiotic therapy. Duration of therapy in most patients can be safely shortened to 5 to 7 days, and procalcitonin can reduce unnecessary antibiotic use in nearly 1/4 to 1/2 of patients without having any increase in morbidity or mortality. Thank you very much for the patient listening.
Thank you, Dhruv Chaudhary, sir, for that excellent talk. As there are no questions, we'll move on to the next lecture. Thank you, sir. The next talk is by Dr. Vasant Nagwekar. It is on intrinsic colistin-resistant organism and whether they are on the rise. Over to you, Dr. Vasant.
Everybody, thanks Dr. Kapil Jirpe and all the organizers of the Sepsiscon for giving me this opportunity. Today's my talk is on basically pathogens which are intrinsically resistant to colistin, and are they on the rise? So basically, we have 2 types of pathogens which could be resistant to colistin or polymyxin big group. So polymyxins are polycationic antimicrobial peptides that are currently the last resort antibiotics for the treatment of multi-drug resistant gram-negative bacterial pathogens. Their introduction to polymyxins for antimicrobial therapy has been followed by an increase in reports of resistance among gram-negative bacteria. So majority of all of us deal with Klebsiella, Pseudomonas, Acinetobacter, and we know that majority of them are carbapenem resistant, and we are dealing with all of us will treat with them colistin and colistin based therapy. And we are seeing that now there is a 5 to 10% even colistin resistance, which is to Klebsiella pseudomonas acinetobacter. And this type of resistance which develops to polymyxin B is the acquired resistance. And today's my talk is nothing to do with these pathogens, but to deal with all those patients who are exposed to colistin or colistin-based therapy and develop a gram-negative sepsis on a colistin or colistin-based therapy. What are those pathogens and how do we deal with them, and what are the sensitivity pattern and why does it happen? So if you see this first slide, intrinsic resistance to polymyxin B in bacteria, and that is these are gram-negative bacteria. Actually, there are many, but I'm more concerned about those which we deal in the medical or surgical intensive care unit. And this happens, or these organisms are seen when a patient is exposed to colistin or colistin-based therapy. So there are a number of gram-negative bacteria that are naturally resistant to polymyxins, including but not limited to the following, and especially the Elizabeth Kingae, Stenotrophomonas multifilia, Proteus species, Providentia species, Morganella morgani, and the Burkholderia cepacia complex. So these are the most common organisms or likely pathogens what we see in the medical or surgical intensive care unit. Now let's go to each and every one. So Elizabeth Kingae meningosepticum. This is an important emerging pathogen causing a healthcare associated infection. In fact, all of them are nosocomial infections and hardly anything comes from the community. So all of them are nosocomial and infected. So if you see the Elizabeth Kingae meningosepticum, it is a nosocomial pathogen which is intrinsically resistant to multiple antibiotics, seen in causes meningitis and in premature newborns, neonatal ICUs. In medical and surgical ICU, usually it is presenting as a Lyme-related infection in a prior patient who is most likely prior exposed to colistin or ongoing colistin-based therapy. And what is the importance? Microorganisms in the genus Elizabeth Kingae are gram-negative, aerobic, pale yellow, pigmented, oxidase positive. So non-fermenter and oxidase positive, the other pathogens will be Pseudomonas, and weakly oxidase positive would be Burkholderia cepacia. So what is important for us in the medical or surgical ICU is that it is seen in the tap water of the hospital. That means if you have an Elizabeth Kingae, this is how the culture plate looks. That means your infection control practices are really bad. So having a lot of outbreak of Elizabeth Kingae, that means you have to get your infection control practices very strong. That's very, very important. Second thing is mostly if the organism is sensitive, then your piptazone, ciprofloxacin, levofloxacin would work. In majority of these, what organisms I've told you, but what we have found out is most of the time these are resistant, and all these pathogens, that is whatever Elizabeth Kingae, meningosepticum, Burkholderia cepacia, Stenotrophomonas multifilia, Providentia, Proteus, or Morganella, majority of them are sensitive to your minocycline and TMPX SMX. So you won't go wrong when you're using minocycline or TMPX. One specialty about Elizabeth Kingae is that this, though being a gram-negative pathogen, the gram-positive antibiotic, that is vancomycin, linezolid, teicoplanin, rifampicin, works beautifully well on this. So that is specialty of Elizabeth Kingae meningosepticum. So this is resistant to majority of the antibiotics and including polymyxin B. If the patient is very sick, then you consider combination therapy. That's very important. Now let's come to the next pathogen, that is Stenotrophomonas multifilia, or the non-milioid Burkholderia species, which is called as Burkholderia cepacia. So these are again non-fermenters and they are weak oxidase positive. So coming to Stenotrophomonas multifilia, if you see it usually in the medical or surgical ICU, usually it causes pneumonia or bacteremia because of Lyme-related infection. And again, the outbreak would be in a patient who has already been exposed to colistin or is ongoing colistin therapy. So on colistin plus meropenem, if a person develops a gram-negative bacteria in the blood, that means it is a pathogen which is most likely not resistant to colistin, but it will be an organism which is intrinsically resistant to colistin. And those would be Elizabeth Kingae, Stenotrophomonas multifilia, Proteus, Providentia, Morganella, or Burkholderia cepacia. All of them would be sensitive to minocycline TMPX. So immediately send 2 sets of blood culture and start off with TMPX or minocycline. So this is again intrinsically resistant to multiple antibiotics. And again, Stenotrophomonas multifilia, if you see the first line is TMPX, the second line would be, I would say, minocycline, or if it is susceptible to quinolone. Second, similarly, your B cepacia, maybe the first line is TMPX and your second line would be again minocycline. Similarly, your Acromobacter would be also similar. and your Elizabeth King is also similar. So that means majority of these pathogens would work on, there's this TMPX or minocycline would work in the present era. Coming to Burkholderia cepacia, it has got multiple mechanisms of antibiotic resistance, variably expressed, complicating recommendations for empiric therapy. So it is usually comes as a line-related infection and most common pathogen in the dialysis unit, because this pathogen is transmitted through the povidone or through the water. Water is a perfect source for, we had a huge outbreak of Burkholderia cepacia in the dialysis unit. So that's very common pathogen, and also in the medical or surgical ICU. So that is what you have to keep in mind. And again, the susceptibility is variable, but TMPX and minocycline would definitely work. So here is your quinolones or carbapenems or ceftazidime would work. Burkholderia cepacia is usually resistant to aminoglycosides and intrinsically resistant to polymyxins. That is colistin and polymyxin. Very important is that this organism survives in your betadine. So povidone iodine, it survives in that. And that's why many times it may be only one bottle is flagging positive, maybe a contamination of the povidone iodine. So if there's an outbreak in the ICU, go and look at your tap water or various injections, what we are giving, distilled water or povidone iodine, betadine, whether that is got infected with Burkholderia cepacia. Coming to the next pathogen, Morganella morganelli. Again, can cause a variety of infections and is often identified as an etiology of UTI or post-operative wounds. So typically it's a nosocomial pathogens. Again, though it is intrinsically resistant to colistin or polymyxin B, but your lower antibiotics, if it is susceptible, your amoxicillin, clavulanic acid, strains, cephalosporins and all that would work. But very important, if it is resistant to the common antibiotics, your TMPX, cefepime or ceftazidime would work, or if it is, or even sometimes meropenem would work. But I would say your TMPX will not go wrong here. And if it is highly resistant, then possibly you may have to use ceftazidime avibactam plus, that is carbapenem resistant strain, suspected metallo-beta-lactamase phenotype, resistant to ceftazidime avibactam, merovactam. Then ceftazidime avibactam plus aztreonam you will have to use. So you'll have to demonstrate the susceptibility before using it. Similar to Morganella, we have this protease, which is a cause, again, causing a urinary tract infections in presence as UTI, and sometimes it can be pan resistant. So usually protease is associated with UTIs and is known to be be associated with stones, that is struvite formation in the urinary tract. Again, the antimicrobial susceptibility is variable, and you'll have to look at the susceptibility pattern of the hospital order. So again, if it is susceptible, your common antibiotic levofloxacin, Septran will work. But if it is resistant, your possibly meropenem, cefepime or piperacillin tazobactam would work. Or if it is resistant to that, also ceftazidime avibactam would work. And if it is the carbapenem producer, then it would, your ceftazidime avibactam plus aztreonam would work. So many of these organisms, like the Burkholderia cepacia, protease, providentia, they are also spiced group of organisms. That means they are AMC producers. So even if it shows BL, BLI or cephalosporin sensitive in vitro, actually in vivo it may be resistant. Coming to the next pathogen is providentia. It is isolated in culture of the urine, blood or wound, Providentia stuteri or retigri. And again, it has got resistance and variable, and it is multiple mechanisms of resistance, and usually it is intrinsically again resistant to polymyxin B. So what is the specialty about Providentia is, again, if it is susceptible organism, your piptazo and levoflox would work, carbapenem would work. If it is resistant to carbapenem, then your ceftazidime avibactam or ceftazidime avibactam plus aztreonam would work. So coming to my last slide, what is specialty of these pathogens about is Elizabeth Kingae or protease or Stenotrophoma maltophilia, Providentia, Morganella or Burkholderia cepacia is that all these usually happen with colistin exposure, and if you have a colistin exposure or colistin ongoing treatment, and if you find a gram-negative bacilli in the blood, to think about colistin breakthrough pathogens, and usually majority of them would be sensitive to TMPX, and majority otherwise 90% of them would be susceptible to your minocycline. So we have to be, because of the colistin, we never saw this 10 years back, and why are we seeing all these new pathogens is because the usage of colistin and polymyxin B has gone so high that every ICU uses this. And you have to be aware that if you develop a GNB in ongoing therapy or if the patient is exposed to colistin, please think about this. And the first line treatment would be minocycline or TMPX. Or for Proteus, Providentia, Morganella, if the organism is susceptible, then quinolone will work, your carbapenem will work, or ceftazidime will work. So you have to look at your susceptibility. But till your susceptibility comes, your TMPX stands very strong and minocycline strong, very strong for these pathogens. Thank you for your kind attention.
Thank you, Dr. Nagvekar, for that excellent talk. We'll now move on to the next session, which is on microbiology of infections. The first talk is by Dr. Raman Sardana. It is on prudent use of gram staining in choosing empirical antibiotic therapy. Over to you, Dr. Raman.
Your friends, colleagues, and faculty members at this conference. So today's topic is what is diagnostic stewardship with AMSP. So that is how we have to deal in future if we were to make a success of AMSP programs. And it is very prudent to have introduced this topic at this conference. So prudent use of gram staining in choosing empirical antibiotics. My name is Dr. Raman Sardana, and I happen to be the Honorary Secretary for Hospital Infection Society India, and also have multiple affiliations with Indraprastha Apollo Hospitals, Delhi. So that is what I was talking to you about, that diagnostic stewardship and AMSP are definitely going to have a positive impact on healthcare outcome. We all know about it, on the patients, clinical team, costs, effectiveness, and the institution's well-being. So any delay in antibiotic administration can result in progressive deterioration and development of intractable complications like the dreaded septicemia. So before a definitive identification of pathogen and its source or directly causing bacteremia is conclusive, gram staining happens to be the mainstay, as we see for decades now, for appropriate guidance of antimicrobial therapy. And it is said that blood cultures in conjunction with initial gram staining or directly from positive cultures happen to be the gold standard for diagnosis of bacteremia. This appropriate early antimicrobial institution can lead to significant positive outcome in clinical conditions, syndromes, negative impacts on the development of antimicrobial resistance, and positive decrease in healthcare costs significantly. So we'll be dealing with gram staining interpretation, direct smear from sources, direct smear from prelim evidence, how they impact the prelim evidence, and post incubation or culture positive direct smears, red herrings or exotics that could have been missed but can be picked up on a well-groomed gram stain reporting. The connect with AMSP, gram staining, and challenges and conclusion. So on the gram staining developed by Heinz Christian Gram in 1884, it still is the mainstay for diagnostics in communicable diseases. So we can differentiate between gram positive and gram negative and gram variable organisms. We can also differentiate on the morphology under each. So there can be cocci in chains, clusters, diplococci, lanceolate shaped, or they could be bacilli, which could be sporing, non-sporing, budding yeast cells. Gram negative bacilli or cocobacilli or cocci. Each one of them has significant impact because each one of them carries a different antimicrobial which can be narrowed down to use. Other structures like polymorphs and pus cells, epithelial cells, cellular debris, proteinaceous material, they all still gram negative. Now we deal with something like a gram variable picture, and many gram negative bacilli or gram positive bacilli can appear gram variable on blood cultures or direct source specimens. Sometimes fungal elements can be picked up as gram variable hyphae or pseudohyphae. Nocardia, actinomycetes, non-tubercular mycobacteria have also been picked up, especially the rapid growers, have also been picked up in blood cultures based upon, or in Nocardia, even in direct smears, and actinomycetes in direct smear as gram variable. Now, interpretation always has to be a clinical correlation every time. And sometimes red herrings need to be in place where trust is something which need to be developed between the clinician and the lab. So gram staining reaction, what are the implications on antimicrobials? I can just give you a few examples of Estrinam being totally effective against gram-negative, doesn't have any effect upon gram-positives. Vancomycin, most of it is directed against gram-positive organisms. Metronidazole, totally against some of the parasites, and obviously antifungal by name remain antifungal agents. So, and there could be, the list is endless. So now coming to the direct evidence, have a look at this, where the source, in fact, we are first dealing with the source, and then we'll come to blood cultures. So source, this is a pelvic pus. You can see the gram-negative bacilli there marked, and this happened to be Bacteroides. Similarly, a source in pelvic aspirate, actinomycetes. In urethral pus from an OBD patient, in males, you can see gram-negative diplococci inside, intracellular, inside the polymorphs. And if you are very lucky, you can see other outside also. But this is a true depiction of gonorrhea in a male. In women, in females, it is a probable diagnostic or a very prelim report for diagnostics. Most of the time, it will turn out to be gonorrhea in high-risk patients. Some of the gram-negative diplococci in the resident flora can mimic. Now, in a bowel specimen, finding of budding yeast cells is pathognomonic if you've got a very good bowel and there is no oral thrush. So that is how it can be. Now here we see budding yeast cells from Canada other than albicans, and this happened to be auris. So a similar structure. Now you can look at whether we can use a sample or we cannot use a sample. How much can we gain out of a direct examination of a sample? So from a sputum, this we do a Bartlett scoring depending upon the number of epithelial cells and polymorphs. And this is a definite batch sample, needs to be repeated on Bartlett. This is a positive Bartlett. We see a lot of polymorphs here, and we can proceed with reporting of smear and processing of culture. Otherwise, in negative Bartletts, we'll get a lot of fallacies when the culture report comes, and unnecessarily we'll be treating gram-negative rods, which could be just present as coloniasis of the upper respiratory tract. Now, in sputum, you can see strep pneumonia in this picture, and this is again pathognomonic, especially when you find them in plenty, and they are gram-positive, gram-variable, diplococci, and lanceolate-shaped. Now, this is another example where true cells can be picked up with lack of lactobacilli around this. And true cells are the epithelial cells with a lot of gram-variable small bacilli. They are on top of these epithelial cells. And if you do a whiff test which is positive, well, you have to just start with metronidazole, and in case of bacterial vaginosis, the diagnosis is done, the treatment given. Now, this is a great study which substantiate the sensitivity of gram stain and specificity of gram stain, and how in Japan, Yoshimura et al. In that study have gone against the guidelines, the then prevailing guidelines, including ITSA 2016 and WAB guidelines, and they could narrow down to narrow spectrum antibiotics in about 26.3% cases just on the basis of gram staining. So much was the effectiveness of this tool. Another study by Seligman et al. Published in 2015, sensitivity of 68.4%, specificity, very high specificity of 97.8%, and a very high negative predictive value of 92.8%. So that means that they could predict that 7.2% of patients with Staphylococcus aureus could not be protected by an empiric treatment that limits antimicrobial coverage to staph only. When we reported only on gram-positive cocci in clusters, and we reported it as gram-positive cocci in cluster as Staphylococcus aureus. But on the other side, you see narrowed down 92.8% in 92.8% cases. Now, post-incubation blood cultures, gram-negative bacilli, 24/7 running labs. Case of enteric fever, you can see thin, slender, few bacilli like this, or you can see a horde of gram-negative bacilli, like with Escherichia coli or Klebsiella. In Klebsiella, you may sometimes find capsules which overlie, which are not stained in gram staining, but you can see a dead space there. So that is something which is not unstained space over the bacilli, so we can make out. Blood cultures of budding yeast cells, as you see here, and then gram-positive bacilli repeatedly grown from different sources, different sites, in immunosuppressed patients. Well, you are not dealing with contaminants. Otherwise, which can be labeled as contaminants, you might have to treat them post culture and sensitivity. So blood cultures, also again here you can see gram-positive cocci in clusters as a staff, and then one can also make out gram-positive cocci in short chains or in angulated diplococci, which are more enterococcus. So again, clinical correlation is required, and then one can go for appropriate antimicrobial. Now, this is a beautiful study by Rebecca Stone and her colleagues, and it talks about impact of gram stain results on proper selection of antimicrobials. So they did a 12-month continuous study on 482 true bacteremia cases from 374 patients, and they could change empirical antimicrobial therapy after gram staining results in 47.1% of cases, and the accuracy was excellent. It was in agreement with culture, except for 12 episodes, and you can see that in one blood culture, Acinetobacter was falsely taken as a gram-positive cocci, and which is a very true nature of this bacteria, that it is generally gram variable. And in a few episodes, a mixture was reported, but only gram-negative bacilli grew. So here you see the mismatch episodes are almost negligible. On the red herring side, one can see sometimes from a case of pneumonia or apical abscesses, one can see these, if a bar is done, or an aspirate is taken, so one CD-guided aspirate, so one can see these gram variable branching, unevenly stained bacilli structures. They are very pathognomonic of nocardia, and you have modified Zealand cell, and you get down. Sometimes fungal hyphae can be picked up on gram staining like that, which are unevenly stained and gram variable. NTM in blood cultures, especially the rapid growers, have been implicated. Now, this slide, courtesy ASM, Journal of Clinical Microbiology. Now, you can also see the ghost cells of MTB, and if you strain by Zeal-Nielsen, this is again a blood culture. We do get positive MTB and NTM, especially the rapid growers. And rapid growers can also be stained gram variable. So coming to gram staining and challenges, there are technical challenges, there are interpretive challenges, and if we have adequately trained staff, appropriate transport from site to lab, clinical details are available, rapid communication between the treating team and the microbiology lab, and a two-way communication, and a trust built up between the two, and understanding built up between the two, I think that we can, and a rapid reporting based on LIS or HIS or any other electronic media, one can do a fantastic job with gram staining and overcoming challenges which are posed. So rapidity and accuracy of communication is a must. So 24/7 running lab again becomes a corollary. Limitations and correlations, gram staining can detect only more than 10⁴ organisms per ml. That has to be remembered. And a gram variability can be an interpretive challenge. So you need a very good microbiology setup. But all can be trained on that. It just depends upon the trust build-up. So one can combine with other staining, one can combine with culture. Every time anything sent for gram staining should be cultured. And all, because of sensitivity also, so susceptibility results one has to. And then rapid molecular test, if they are available, they can be applied to the same sample. Now gram staining with AMSP It reduces the overuse of broad spectrum, narrows it down to narrow spectrum antimicrobials. The drug costs were definitely reduced. And recommendation is that gram staining should be included in all antimicrobial stewardship programs. That is Taniguchi for you 2015 paper. So in conclusion, gram staining is simple yet effective technique in guiding or modifying empirical antimicrobials. There is a direct correlation of decreased broad spectrum antimicrobial usage and conversion to narrow spectrum, just based upon the gram staining report. And only thing is that one needs to have clinical material provided, and its transport should be immaculate, and then clinical details have to be furnished to the lab. Excellent correlation can be achieved between gram staining and appropriate antibacterial usage if accurate research and interpretations are conveyed very fast. That is the key. Besides cost effectiveness, one can slow down the AMR rate. One can also, obviously that will lead to a successful EMS program. There has to be a will to change and implement by everyone involved in patient care. And more correlation studies can come out of our own healthcare to substantiate its values. But world over, especially from Japan and from Europe, the publications are very, very supportive of gram staining as the mainstay of clinical diagnosis and also starting empirical treatment. Challenges would remain, but they can be largely overcome. And we think that gram staining should be used as a Raman tool of diagnostic stewardship, leading to AMSP success. Thank you, and namaste, stay prevented.
Thank you, Dr. Raman, for that excellent and really relevant talk. We'll now move on to the next topic, which is smart interpretation of antibiogram by Dr. Camila Rodriguez. Over to you, Dr. Camila.
Good evening, friends. And let me thank the organizers for inviting me here. I'm going to share my presentation now with you. And my topic, as you can see, is actually smart interpretation of the antibiogram. Okay. Can you see my slides? Okay. So basically, if you look at it this way, an antibiogram is what the microbiologist does. And how do you interpret it? I'm actually going to quickly go through, I only have 10 minutes, this presentation with 4 cases to sort of illustrate the points I'm going to make. Okay. So basically, antimicrobial therapy, as you all know, is basically prophylactic, empiric, on which antibiotic policies are written. And what I'm talking to you today is about the therapy of defined infections, where you actually interpret the susceptibility reports. So as you all know, gram-negative bacteria have different resistant mechanisms, and they're operational in different pathogens. It's really essential today to know the local epidemiology and identify the enzymes to tailor therapy. This is the antimicrobial resistance research surveillance network that is just out by the ICMR. I would urge you to look at this excellent annual report, because it can kind of puts into perspective what our country is facing today in terms of an AMR. Now, if you interpret an antimicrogram, these are my 4 points. Let's look at intrinsic resistance. Intrinsic resistance is, for example, look at Proteus. It's intrinsically resistant to first-generation cephalosporins, to tetracyclines, to polymyxins, and to nitrofurantoin. So whatever report may show susceptibility, you must know what is intrinsically resistant. And today, there are other exceptional phenotypes that should be confirmed. For example, if you grow out a Serratia that's susceptible to colistin, you need to check it. If you grow out a Haemophilus that is resistant to any third-generation cephalosporins, it needs to be checked. Similarly, a Staph aureus resistant to Bank needs to be reconfirmed. Now, site of infection. Remember, when a microbiologist pushes out a report, they're actually telling you that the organism is susceptible, intermediate, or ATU, as UCAS calls it, or resistant, but it's actually projected to serum levels. This may not achieve, it doesn't say that the tissue levels are going to be achieved. So ideally, for the same bug and drug, you may have different susceptibility standards for isolates from the bladder, from the blood, from the meninges, bones, lungs, etc. And if you look at MDR and XDR GNV, from this. It's the site of infection that counts. And these are the salvage drugs that we use for, today for our MDR and XDR GNB. And you can see urine, for example. It works. Polymyxin B doesn't work in the urine. Tigecycline doesn't work in the urine. So these ideally should not be reported as such. Let's look at optimizing PKPD targets. I'm actually not going to tell you what you know. I'm going to go through this case. This was a patient with a history of a road traffic accident who came to us with postoperative meningitis. Elizabeth Kingia meningoseptica, also known as Flavobacterium meningosepticum, was isolated. This is a gram-negative bacterium with a paradoxical gram-positive susceptibility. No improvement on Bank and meropenem, and 4 to 6 days after starting this, we continued to grow the bug despite adequate serum trough levels of vancomycin. I would ask you, what would you do? So when you have this, in bacterial meningitis, when you have microbiology failures, you have to give intraventricular therapy because that is required to reach therapeutic concentrations. There's something known as the inhibition quotient. That is basically the trough CSF concentration divided by the MIC, and that should exceed 10 to 20. In this case, when we had the trough CSF bank levels was 3 and the bank MIC was 8. When we had started with 7.5 mg twice a day intrathecally, but we actually had to ramp up the intrathecal concentrations to 15 milligrams twice a day to achieve this inhibition quotient for CSF sterilization. Now I'm going to go through 4 cases with you to interpret the MDR difficult to treat gram-negative antibiotics. You all know this chart is well versed with most intensivists. You have serine, amongst the beta-lactamases, you have serine and metallo. A, C, and D are under serine, and metallo is the famous NDM, etc., the class B. Now, you remember there's ESBL and you have carbapenemases under class A, and similarly class D, you have oxas, which are ESBL or the oxar 48 for enterobacteriales, and AMP-C is basically class C inducible or plasmidic. So the first case is a urosepsis with ESBL E. coli. This is a really excellent chart that was published some years ago, which actually is kind of plus minus 2% as we've seen over the years. 70% of our E. coli ESBL producers, and these ones in red are the dominant mechanisms of ESBL production. So you have this urosepsis, blood culture growing E. coli, and the ones in green are the ones that are intermediate or susceptible. I'll put it to you, if you had this particular susceptibility, what would you treat your patient with? Piptazo is intermediate, cefoperazone sulbactam is S. Now we have something known as the blood culture ID, that is a BCID panel for blood cultures that also gives us an AMR gene. And if you look at it here, the CTXM was positive, that is an ESBL. So you would be tempted to think that maybe I could get away with the BL-BLI combination. But remember, when you look at the susceptibility again, you're seeing an intermediate for piptazo and co-carriage of oxa-A. A penicillinase with weak affinity for inhibitors is a major cause of reduced susceptibility to piptazo. It's also associated with resistance to the aminoglycoside. So in this case, the argument is, should I give a carbapenem or should I give a BL-BLI? And this is a really good publication that you could read in JACC. It was published maybe 2 years ago. So in this case, what is the ideal choice for treatment? For any urosepsis, you would do clinical considerations, the type of infection and the severity of the patient. If it's VAP or meningitis, there's really no room for therapeutic failure. You have to give a carbapenem. But for UTI and for biliary infections, you may get away with a BL-BLI. So piptazo certainly should not be a preferential choice of a BLI because you're already seeing I, and that is oxa is possibly responsible for that. Fosfomycin we would reserve for CRE. And actually, you really need to individualize treatment for different scenarios. My second case is a complicated intra-abdominal infection causing bacteremia with a carbapenem-resistant Klebsiella pneumoniae. Now, if you look here, you see that Klebsiella here, 40% of our Klebsiella are producing OXA 48-like or an NDM. Now, this is the susceptibility test that we got out of this. And as you can see, ceftaz-avibactam is resistant, aztreonam is resistant, and the only susceptible, colistin we don't report susceptible, we just report intermediate, looks to be colistin. So what would we do in this case? When we actually did the CARBA-R to look at the molecular mechanism of resistance, we found that both NDM and OXO were actually produced. So in this case, we also verified it on our BCID where we got a CTXM, which is an ESBL. So we knew that this bug was an ESBL producer, plus it was producing two carbapenemases, a class B and a class D. So this is something known as the zone of hope with synergy for fractional inhibition concentration index. And I don't have time to go into this. Basically, when you use Cas-Abi with aztreonam, you're actually getting a zone of hope. So here, if you look at the spectrum of activity of the beta-lactamase inhibitors, you'll find that the class Septas-Abi, the rest are all succumb to ESBLs. Clavulanic acid is really not too good. Tazobactam may work for CTXM, may work for chromosomal Pseudomonas amci, but not for the others. Avibactam works for most except the metallobeta-lactamases. So it has activity against class A, class C, and class D. What is the ideal choice for treatment in this patient? I would put it to that perhaps in this case, we need to know if OXA, you must know whether OXA48 is present. In this case, we know it is. Try for the zone of hope. And avibactam works for the ESBLs, in this case CTXM, AMCs, and oxalate. It doesn't work for MBLs, as I said it. And so perhaps this would be a good choice. Remember, not everything is also rosy. What if the blood culture had grown E. coli? This is something that we really need to worry about. This is a bug in our backyard for carbapenem resistant E. coli, not yet for CLEV, where E. coli isolates that are concurrently harboring 4 amino acid inserts in PBP3 with NDM are hugely emerging as a therapeutic challenge. In that case, note this study done by Balaji actually shows that about 25% of our Septas-Abi or our aztreonam-Abi wouldn't work for E. coli because of this insert of penicillin binding protein 3. Case 3. This is a post-operative meningitis with Pseudomonas aerogenes. 25% of our Pseudomonas aerogenes is actually producing metallos, which is worrying. So look at this post-operative meningitis where the CSF grows everything that seems to be resistant except colistin again. When we did the blood culture, the BCID, we found that NDM was positive. This is coming up to be a matter of concern today because Pseudomonas is difficult to treat. Pseudomonas aeruginosa is not really a great ESBL producer, but beta-lactam resistance is due to hyperproduction of AMC, due to porin and hyper-efflux pumps. Carbapenemases as MBLs, VIM and NDM are something that's unique to India. And they really are starting to compromise our choices for treating multi-drug resistant or DTR Pseudomonas aeruginosa. So the ideal choice for treatment is colistin. The important point I want to make is that colistin cannot be given alone and you must give intrathecal colistin for this particular MBL pseudo. Our pseudos are producing a huge amount of AMC and they're kind of hyperrefluxing. We are seeing MBL production, which is not seen in the West. We must do an E-test to confirm Septas-Abi if we're going to treat, or colistin is our only option, is our only drug here. The last case is about a secondary bacteremia post-VAP. Now, as you can see, Acinetobacter baumannii, really a miserable bug. And the mechanisms of resistance are not OXA48. They're completely different OXAs, 23, 24, 51, 58. This is a secondary bacterium post-VAP with Acinetobacter baumannii, where you can see IE means we don't know, insufficient evidence to actually call out a resistant breakpoint. Minocycline, tigecycline, colistin are all, these both are insufficient evidence. And colistin is what seems to be susceptible. When you see an Acinetobacter baumannii, when we actually ran the BCID, we found nothing. It looked like it was all pan-sensitive. But remember, Acinetobacter oxas are not detected by these panels. So when you look at the CARBA expert, CARBA-R expert or panels, you must make sure that these are being targeted. If they're not targeted, you'll be falsely reassured that there's no resistance on board. There's some work we did where we found really most of our carbapenem-resistant Acineto and pseudo were OXA23 plus 51, they were VIM, etc. So what is the ideal choice for treatment for carbapenem-resistant Acinetobacter baumannii? When you see an Acineto, the first consideration is this a colonizer or an invader? In this case, clearly the VAP has caused the bug to become bacteremic, so it is an invader. You look at host factors to decide what are the comorbidities, etc. Most importantly, when you isolate Acinetobacter baumannii, you would look at source control. Of course, you can't do source control where the lung is involved. There is a very interesting study known as INHALE, which talks about amikacin not being helpful as an inhaled antibiotic. We have to look at this when we give colistin by inhalation. Combinations, basically the IDA and the OVERCOME studies have actually shown that Acinetobacter baumannii should not be given in combination because the 14 and 28-day mortality for the combination actually remain the same. So you can give it alone. The other options for Acinetobacter include minocycline, tetracycline derivatives such as mino, tigecycline, and eravacycline. And sadly, cefodericol, which is the new kid on the block, maybe take a year or 2 years more to come to India, they've actually issued a black box warning for Acinetobacter. And finally, remember, Acinetobacter doesn't cover Septas avi doesn't cover Acinetobacter, as we see. Thank you.
So thank you very much, ma'am. So we'll move ahead with the keynote lectures. First is by Professor Craig Cooper-Smith, Sepsis Therapy Beyond Antimicrobials. Over to you, sir.
Hello, my name is Craig Cooper-Smith, and I am very, very honored to be here and thank the organizers for inviting me for a very exciting virtual meeting. Thank you. I'm going to be speaking to you today about sepsis therapy beyond antimicrobials. So my disclosures are here, and probably the most relevant are the top ones. I'm an author on the most recent Surviving Sepsis Guidelines. I co-chair the Surviving Sepsis Research Committee, and I co-chair Conflict of Interest for the next Surviving Sepsis Guidelines, which are going to be released fairly shortly. So I know everybody listening to me today knows the global burden of sepsis, but it's important on World Sepsis Day to reiterate it. Nearly 50 million people get septic worldwide each year, with over 11 million people dying, representing about 20% of all global deaths. And sepsis continues to be an underappreciated global public health crisis with an unacceptable high morbidity and mortality. And while antibiotics and rapid antibiotics are, of course, the mainstream of sepsis therapy, it's not enough. So I'm going to be talking to you today is mostly data from the Surviving Sepsis campaign, which is a partnership between the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. The 5th version is about to be published in the fall. And what I'm going to be going is published data, but also things that have come out since the last Surviving Sepsis that I think are relevant for you to understand. So whenever we talk about sepsis, of course, we start, in addition to antibiotics, with resuscitation. So resuscitation from sepsis-induced hypoperfusion should be done with at least 30 cc's per kilogram of crystallite within the first 3 hours. And what I have here in parentheses is the strength of the recommendation. So in this case, a strong recommendation. And after that is the strength of the evidence, so relatively low evidence. After initial resuscitation, additional fluid should be guided by frequent reassessment of hemodynamic status. That's a BPS or best practice statement. It's important to use dynamic over static variables to predict fluid responsiveness, and to normalize lactate in patients with an elevated lactate is a marker of tissue hypoperfusion. A fluid challenge should be performed where fluid administration is continued as long as hemodynamics continue to improve. So simply put, if you give somebody fluids and they respond, keep giving fluids. If you give fluids and they stop responding, stop giving fluids. We should start by giving crystalloids rather than colloids as the initial fluid of choice. And it's important to say that this is the first strong recommendation based upon a high level of evidence, as we should be not using hydroxyl ethyl starches. So if one looks at the 2017 Surviving Sepsis Guidelines, it says to use either balanced crystalloids or saline for resuscitation. However, since that came out, this trial came out, the SMART trial in the New England Journal of Medicine, comparing balanced crystalloids versus saline in critically ill adults, not just sepsis, but all critical illness. It was a very large study, over 15,000 patients who were randomized to receive either saline or balanced crystalloids, which could either be Ringer's lactate or plasmolite A. It was a single center study, and ultimately the final endpoint was a composite of death from any cause, new renal replacement therapy, or persistent renal dysfunction. And the authors found that the composite endpoint was better in patients who received balanced solutions, leading to the conclusion that perhaps one should be using balanced crystalloids rather than normal saline. Approximately a month ago, however, the BASICS trial came out in JAMA, and this was looking at the effect of similar balanced solution versus saline. This case, the balanced solution was always plasma-like, and it was, again, a very large study. Unlike the previous study, it was in 75 ICUs versus a single ICU, and again, over 10,000 patients were randomized to receive the two, and they were randomized 1-to-1, with the primary outcome being 90-day survival. And of the 11,000 patients who were randomized, ultimately, they found that there was no difference in survival, which was different from the SMART trial, but similar to previous data on the SPLIT trial. Here's the survival curves that are actually published showing no difference. I had the privilege of writing the editorial in JAMA on this, and I'd like to read to you what I wrote to put it into context. The questions of whether there are advantages to balanced crystalloids or saline is controversial. There are numerous factors to consider when interpreting the results of the BASICS trial. Patients received a median of only 2.9 liters of study fluid during the first 3 days of randomization. The small volume of study fluid, a mean volume of less than a liter a day, may have obscured an effect that would have been seen with more vigorous volume resuscitation. Furthermore, 68%, or over 2/3 of all patients, received non-study fluid prior to enrollment, with nearly half of them receiving more than 1 liter prior to randomization, which is a confounder in interpreting the results because some patients could have received a significant volume of a different fluid than they were subsequently randomized to receive. In addition, the finding that there was minimal separation in mean serum chloride groups between the groups is consistent with the fact that patients only received a small amount of fluids, which might be relevant towards understanding the final results. And then finally, we said after 20 years of comparing balanced solutions with chlorine-rich solutions, how should a clinician respond with this daily choice? Well, ultimately, what all of these trials probably show is if one is using a small amount of fluid resuscitation, a liter, maybe 2 liters, it probably doesn't make any difference. However, if one is using a large volume resuscitation in a septic patient who needs 5 or 7 or 10 liters of crystalloid, the answer is that it's still unclear, and I don't believe any of these studies actually determine whether balanced solutions are superior to normal saline. Further, in surviving sepsis, if one uses a large amount of crystalloid, it says we suggest using albumin in addition to crystalloid for initial volume resuscitation and subsequent intravolume replacement in patients with sepsis and septic shock who require substantial amounts of crystalloid. It should be noted, at least in the United States, that albumin costs 60 times more than crystalloid. Well, where does this recommendation come from? This is the SAFE trial looking at nearly 7,000 ICU patients randomized to receive albumin versus normal saline for 28 days. And you look at this and you say, well, there's no difference at all. But a subgroup analysis showed a survival benefit in patients in septic shock. This led to the Albios trial, which was albumin replacement specifically in patients with severe sepsis or septic shock. Again, a large study of about 2,000 patients, a higher concentration of albumin. And there was ultimately the patients with albumin at higher mean arterial pressure, but there was no difference in fluid and no difference in survival. And so you might say albumin is not beneficial. And so I show you this and I ask, what does this glass look like to you? Half full or half empty? And there's 2 large meta-analyses of albumin in critical illness, specifically in sepsis and septic shock. This former one is looking at 16 trials of a little over 4,000 patients, showing a relative risk of death of 0.94, ever so slightly crossing midline, where the authors concluded human albumin for critically unwell adults with sepsis was not robustly effective at reducing all-cause mortality. It's safe, as there's no single harm, but the analysis does not support a recommendation for use. But then a second albumin meta-analysis on a smaller group of trials, just 5 trials, looked at 3,600 patients. And here they found that the relative risk of death in all comers was 0.88, slightly crossing midline, But in septic shock, the relative risk was 0.81, not crossing midline, with the conclusion in the meta-analysis, a trend towards 90-day mortality was observed in severe sepsis patients resuscitated with albumin compared to crystalline and saline, and the mortality of patients with septic shock decreased significantly. When using pressors, the first pressure agent should be norepinephrine or Levophed. Once doses are getting higher, one could add either vasopressin or epinephrine to norepinephrine with the intent of raising the mean arterial pressure to target or decrease norepinephrine dose. Dopamine should generally not be used except in very, very, very selective alternate places where there's a low risk of tachyarrhythmias and absolute or relative bradycardia. I effectively never use dopamine. And of course, we should not use renal dose dopamine, which does not change outcomes at all. And not really a pressor, but we should use dobutamine in patients with persistent hypoperfusion despite adequate fluid and vasopressors, but that's for inotropy as opposed to pressors. Since the surviving sepsis came out, this study came out in the New England Journal of Medicine looking at angiotensin II for the treatment of vasodilatory shock. And it's a relatively small study, 350 patients. And what it shows is that angiotensin II is in fact effective at raising blood pressure. However, it's not effective at changing mortality. Of course, there are no studies of pressors that show a change in mortality. And so I would still say one would start with norepinephrine. This is a good tool to have in one's armamentarium above and beyond norepinephrine, though initial studies need to be shown. But this is an important subgroup analysis. Understanding the subgroup analyses are, of course, hypothesis generating only. And this is a small study showing outcomes of patients with vasodilatory shock on renal replacement therapy treated with angiotensin II. So it's a subgroup analysis of the study that I previously showed you. And in this, only 45 and 60 patients per group, they actually found a survival benefit on patients getting renal replacement therapy treated with Ang2, suggesting, again, a post hoc analysis, but suggesting that a randomized trial should be done specifically in this patient population. Steroids have been controversial for years, and the surviving sepsis recommendation says we suggest against using IV hydrocortisone to treat septic shock if adequate fluid resuscitation and vasopressin therapy are able to restore hemodynamic stability. If they do not, we suggest treating with IV hydrocortisone at a dose of 200 milligrams per day. And they also suggest to taper patients from steroids when pressors are no longer required. Of course, this is specifically for septic shock because there's no role for hydrocortisone for sepsis in the absence of shock. Since this came out, there were two large-scale trials that came out in the New England Journal of Medicine, the adrenal trial and the APROX trial. And if you look at them, the top one shows a benefit towards the survival. The lower one shows no benefit towards the survival. But in terms of patient-centric outcomes, like getting off pressure sooner and even getting off the ventilator sooner, there was a benefit for using steroids. And this is a meta-analysis that was published fairly recently after both of these, looking at the association of corticosteroid treatment with outcomes in adult patients with sepsis. It ultimately stated in JAMA Internal Medicine, the findings suggest that the administration of steroids is associated with reduced 28-day mortality compared to placebo use or standard supportive care. More research is needed to associate personalized medicine with the corticosteroid treatment to select suitable patient population who's more likely to benefit. Which gets to the question of how do we treat these? Because RCTs treat everybody. And the reasons why sepsis morbidity and mortality continue to be so high are complex and multifactorial. And one contributing factor may be that outside of tailoring antibiotics, we generally treat all sepsis patients pretty much the same. But are all sepsis patients truly the same? They not only have different initiating organisms, they have different genetics and different age and different gender and different comorbidities and different environments. And all these together lead to a different host response with seemingly similar patients having profoundly different outcomes. So when we look at these, which factors do we take into account when we treat sepsis? Well, we do treat organisms differently because we use different antibiotics, but we don't pay attention to patient genetics or age or gender or comorbidities or environment. And if we really want to move towards precision medicine for sepsis, we need to stop treating patients the same. Obviously, we don't do that for antibiotics, and understand that while patients may look the same from the head to the head, the drivers of sepsis may be very different between them. So how can we identify phenotypes of sepsis patient? There's multiple approaches currently under investigation. None of them are actually in use right now, but a number of them are very, very close to being in use. Some of these are quite complex, And some of these are simple as just using vital signs. And this is just an example of multiple publications that have come out in the last couple of years showing that potentially we actually can get to precision medicine. So in conclusion, the treatment of sepsis outside of antibiotics tends to be fairly generalized. Fluids and pressors and steroids and ventilator strategies, which I did not have time to talk about in this 15-minute talk, directly impact patient outcomes and should be chosen carefully. And importantly, the future holds the promise that we're going to be able to distinguish between patients who look the same from the head of the bed, but are actually quite different on a cellular and molecular level. Again, I'm so honored to have been invited to come here today, and I thank you very, very much.
So thank you very much, sir. Next lecture is on membrane-based therapies in sepsis by Professor Marlies Osterman. So over to you, ma'am.
It's a great honor to contribute to this important meeting. I would like to thank the organizers for inviting me. In the next 15 minutes, I will talk about membrane-based therapies in sepsis. These are my disclosures. They have not influenced this presentation. Undoubtedly, sepsis is a complex disorder with pro- and anti-inflammatory processes and periods of hyperinflammation, immunoparesis, and even immunosuppression. These processes may occur at the same time or in sequence. And finally, patients with worse outcome are often characterized by rising inflammatory mediators and an imbalance between the pro- and anti-inflammatory processes. So it comes as no surprise that blood purification is considered as a potential therapy in sepsis. And the aims of this therapy would be to remove various substances, including pathogens, endotoxin, inflammatory mediators, but also potentially activated inflammatory cells like leukocytes. And with regards to inflammatory mediators, there's a potential that blood purification may reduce the overall burden and reduce the peaks of pro- and anti-inflammatory mediators. And this may restore some balance between these two different groups. It is possible that this is beneficial, but it should be remembered that all these different inflammatory mediators are different. They have different sizes and different characteristics. Some are bound to protein and others are not. And when it comes to blood purification techniques, these characteristics have to be considered and remembered, because ultimately blood purification comes down to either hemofiltration techniques or adsorption techniques or combinations of both. Blood purification based on hemofiltration uses standard hemofiltration membranes of different pore size and different cutoffs. And depending on the pore size, substances are being removed and cleared into the effluent fluid. And so with standard membranes, hemofiltration can remove substances with a molecular weight up to 60 kilodalton, depending on the cutoff. In order to remove larger amounts of cytokines or inflammatory mediators, the dose can be increased. So with high volume hemofiltration at a high dose, larger volumes of cytokines can be removed, but they are still up to a molecular weight of maximum 60 kilodalton. In order to remove larger molecules, plasma exchange may need to be considered. And in plasma exchange, the membranes have larger pore sizes. And this allows the removal of albumin, proteins, and immunoglobulins. In order to remove even larger molecules or more molecules, adsorption techniques are considered. And these columns are designed in such a way that the surface area is maximized, as demonstrated here. And with a large surface area, a large amount of substances can be removed. Of note, CytoSorb facilitates the adsorption of hydrophobic molecules, but does not facilitate the binding of endotoxin. Endotoxin can be removed with the oxyrase membrane, which is designed slightly differently. And in addition to endotoxin, obviously it also allows removal of cytokines. Similarly, the polymyxin fibers allow the binding of endotoxin. So we have various adsorption techniques and membranes available. The polymyxin filter also facilitates the entrapment of inflammatory cells, as demonstrated here. Professor Beloma and colleagues looked at the existing literature until 2013 and identified 14 articles which had used and described 40 different filters of different sizes, different cutoffs, and different materials. And these 40 filters have been used in 18 different techniques, which ultimately come down to hemofiltration, potentially combined with hemodialysis, and the various adsorption techniques. And according to this systematic review, the main cytokines removed were interleukin 1, 6, 8, and 10, and also tumor necrosis factor alpha. And based on this literature review, the best results were seen with high cutoff techniques. I just show you one of these high cutoff techniques, although it had a negative result. This was one of the landmark studies performed by Professor Payen, looking at the role of hemofiltration in the early phase of sepsis. So they enrolled patients with first organ failure related to sepsis. They were randomized to hemofiltration for 96 hours versus standard care. Of note, at baseline, patients randomized to the hemofiltration group appeared to be slightly sicker with more severe organ failure. This trial confirmed that hemofiltration indeed removes cytokines, including IL-6, IL-1, and NTP1. But despite this removal, the serum levels were unchanged between the two groups. There was no significant difference in plasma cytokine levels. Other adsorption studies looked at polymyxin fibers and polymyxin-based techniques. A landmark study was the Aptomix trial, which focused on patients with septic shock due to peritonitis. And again, patients were either randomized to polymyxin hemoperfusion versus standard care. And in this trial, there was no improvement in organ failure. And of concern was the fact that patients randomized to hemoperfusion had a slight increase in mortality. However, this increase was statistically not significant. In a follow-up analysis, the investigators looked at cytokine levels of patients recruited to the study and ultimately found no real difference in various cytokines between patients treated with hemoperfusion versus standard care. For some cytokines, there was a decrease over time, but no real difference between the two groups. The authors concluded that hemoperfusion did not result in a difference in various cytokines or endotoxin. However, there was a difference with regards to interleukin 17, which is a cytokine with a protective role. There was a significantly lower 17 concentration in patients treated with hemoperfusion which reminds us of the fact that blood purification is not selective and removes harmful but also potentially beneficial substances. The UFAS randomized control trial was another trial looking at the role of polymyxin hemoperfusion. And in this first trial, looking at patients with abdominal sepsis, there was a significant improvement of organ function and 28-day mortality in patients who had received polymyxin hemoperfusion compared to standard care. In the follow-up Euphrates study, the team looked at a larger patient population in more centers, and again, randomized patients to polymyxin therapy versus sham therapy. So it was fully blinded. And in this trial, there was no significant difference at 28-day mortality. However, the question remains whether a subgroup of patients may benefit from this therapy. And this was the focus of a post-hoc analysis where the team looked at patients with an endotoxin level in range of 0.6 to 0.89 baseline. When they compared patients who had received either polymyxin or sham therapy, they observed a significantly lower 90-day mortality in patients who had received hemoperfusion therapy. So it is possible that certain patient groups may indeed benefit from the removal of cytokines or inflammatory mediators. It's also important to remember that time plays a role, and as shown in this figure, there are periods during the course of sepsis where blood purification may be beneficial, but it's also possible that at certain time points it causes more harm than good. Lastly, chemoadsorption may not just remove inflammatory mediators and cells, it also rapidly removes other substances, including nutrients and drugs. And the extent of drug removal was explored in this experimental animal study, where they looked at the impact of cytosol adsorption. That's clearly shown here. Some drugs indeed get removed with cytosol adsorption, for instance, linezolid, and other drugs are not impacted at all, like cefepime. And clearly this knowledge is important when applying adsorption techniques. I think we're still at a point where research is urgently needed to broaden our knowledge before these techniques are routinely implemented and applied. As an example, I'd just like to show this randomized controlled trial, which was published only a few months ago, looking at the role of cytokine adsorption in patients with COVID-19 receiving ECMO. In this single-center randomized controlled trial, mortality was significantly higher in those who had received additional cytokine adsorption, reminding us of the importance of randomized controlled trials and research in this area. So in conclusion, indeed, membranes and techniques exist to remove cytokines and inflammatory mediators. Also, the ultimate choice and selection depends on the inflammatory mediator to be removed, but also the time, the phase, and the characteristics of the patient. I believe more research is necessary to identify the optimal timing and duration and patient group for this therapy. Thank you very much for listening.
Thank you very much, ma'am. So there is no question. So we'll move ahead with the next sections. It is basic science in sepsis. So first lecture is on genotype and phenotype of sepsis response by Dr. Bala Venkatesh. So I welcome you, sir. Over to you.
Thank you. I'm Bala Venkatesh. I'm an intensive care physician based in Brisbane, Australia. And I work with the George Institute for Global Health, and both in Sydney and in New Delhi. And I'm also the chair of the Queensland statewide sepsis steering committee. It's a great privilege for me to be able to speak at the Sepsiscon 2021 about sepsis to commemorate World Sepsis Day. And so I'm just going to share my screen with you now. So just get the slides up on the screen. Okay. And the topic given to me is about phenotypes and genotypes in sepsis. And I guess this whole question has been very topical in the last 5 to 10 years is because of the increasing recognition that sepsis is a very heterogeneous disease. And although people come in with similar clinical characteristics, their underlying biological responses are different, and therefore they are phenotypically similar within their own endotypes or their underlying biological mechanisms. They're all different. And so I'm going to introduce the concepts of phenotypes and endotypes to you, and then I will use the septic shock reversal literature to talk about how phenotypes and endotypes give us different information, and talk about our own work based on the endocrine data and the genotypes on cortisol-associated genes and shock reversal. And so these are my disclosures. So as I mentioned before, there's been a large body of literature on why have clinical trials in sepsis fail. And this is because of the recognition that sepsis is still defined by a syndromic approach and really doesn't take into account individual patient biological host responses. And so people are now identified two fundamental concepts. One is the phenotypes, where there are patients with sepsis with similar clinical and physiological characteristics, and endotypes, where these are people who have got similar clinical characteristics, but who differ in their genomic, endocrine, and immunological responses that influence prognosis, outcomes, and response to treatment. And therefore, identifying these two, it's a very important clinical aspect. And this, in fact, follows on to the next step, which is about where precision medicine comes in, because using the concepts of phenotypes and endotypes, we can identify risk factors which allow us to selectively enroll patients into clinical trials who are most at risk of the outcome of interest, what's called prognostic enrichment. And then we also have therapeutic enrichment, where we are able to identify and enroll patients who are likely to be treatment responders. So, and the figure on the left illustrates where you've got a heterogeneous sepsis cohort, and from that you can identify a low-risk group and a high-risk group, and within the high-risk group, you can then identify responders and non-responders. And really the best example of this is cancer research, where the staging system for cancers allowed us to define prognostic enrichment, and having specific biomarkers such as, for example, Herceptin-2 expression in breast cancer has allowed us to identify treatment responders. And we are trying to adopt a similar approach to sepsis. And the fact that the gene plays an important role in recovery from sepsis was this classic paper from Sorensen back in 1988 in the New England Journal of Medicine, where they looked at adoptees who were dying of infection and looked at the lifespan of their biological parents and the adopted parents. If the biological parents died of sepsis, then there's a high risk of the adoptee dying of sepsis. But if the adopted parents died of sepsis, then the risk was no different from that of the community. So for the first time, it was able to separate the genetic and the environmental influences on premature death in patients with a range of conditions, of course, in this particular case, infection. Now, I'm going to take you to the septic shock literature to illustrate to you the impact of the phenotype and the environment. And I'll start with, as you all know, the steroids have been used in septic shock more than 50 years. Initially started with high-dose steroids. And so looking at the phenotype, which is the patient, and the environment, which is, of course, the treatment. And you look at this, the first large trial was the trial by Charlie Sprung back in 1984, where you can see that the shock reversal rate, which is shown there in the left figure, the shock reversal rate in the corticosteroid group was about 60% in 1 week, as compared to about 35 to 40% in the control arm. In a similar cohort, in a study repeated 3 years later, you could see that the shock reversal rates shown on the right here were not very different between the two groups, very, very similar. Now, you then look at the low-dose steroid literature. Again, similar cohort of patients enrolled into the septic shock studies. Now, this one was again done by Charlie Sprung, the Cordicus study back in 2008, where the shock reversal rates were in fact higher now, close to 80% versus 75% in the treatment and the placebo arms. In the Anand study in 2002, where they had a slightly different phenotype, the response to the shock reversal rates were different in the hydrocortisone, were lower than the Cordicus group, and they were also different again between hydrocortisone versus placebo. Now, if you look at the most two recent low-dose steroid trials, one was the adrenal trial, which we reported from Australia, and the APROX trial from France, led by Anand again. What we did was we adapted the sepsis 3, we used the sepsis 2 criteria for enrollment into the adrenal cohort. We looked at what would happen if we used the sepsis 3 phenotypic criteria and the APROX criteria to see what's the impact on shock reversal and shock recurrence. And when you do that, you can see there that the sepsis 3 really didn't have much of a change on, as shown in this. The sepsis 3 was very similar to the original adrenal shock reversal responses, but if you applied the APROX criteria, then the time to shock reversal was 1 day longer. And then if you look at the shock recurrence rates, interestingly, in the original adrenal trial, they were very similar between the two treatment groups. But if you apply the sepsis 3 cohort and the APROX cohort, you can see there are differences between, there's a much higher shock recurrence rate in the steroid arm. So again, it tells us that the phenotype has a significant impact on the conventional clinical responses that we look at. Evidence of further phenotypic influences, we looked at the sex differences in response to corticosteroids in patients in the adrenal trial. And this was led by Kelly Thompson from our group. And again, we found that the shock recurrence rate was higher in the female population as compared to the male. So it's again, another example of how the phenotype plays a role here. Then we went one step further. We want to look at the endotype influences, which is looking at now the biological mechanisms and the responses. So we looked at the endocrine biomarkers and whether they actually had an impact on shock reversal. So we measured plasma cortisol, aldosterone, total and free cortisol and aldosterone, and ascorbic acid concentrations. And in a nested cohort of 580 patients, and what we found was, of course, there was no difference. They did not have any influence on mortality, but importantly, the underlying endocrine markers did not seem to predict shock resolution to hydrocortisone. We then looked at the genomic mechanisms. Will they have an impact on the response to hydrocortisone and shock reversal in patients with septic shock? And this work was again in the adrenal study. We looked at 480 patients. We looked at RNA-seq data and looked at the gene expression. We looked at 11 adrenocortical genes. And this work was led by Jeremy Cohen. And basically what we found was there were two genes which showed a significant association. One was the GLCC1 gene, and the other one was a BHSD1 gene. So patients with higher expression of GLCC1 who received hydrocortisone achieved shock resolution faster than those receiving placebo. And conversely, patients who had higher expression of BHSD1 who received hydrocortisone achieved shock resolution slower than those who received placebo. And so this tells us for the first time that there are underlying biological mechanisms which influence your treatment responsiveness, and the variation in gene expression here may be a mechanism for heterogeneity of treatment response to corticosteroids in septic shock. So where the endotype comes in. And this similar work has been reported by Anne Cliff et al. From University College Hospital in London, where they looked at sepsis response signatures, and they've looked at SRS1 and SRS2, so the two signatures there, and looked at differences in steroid responsiveness. So to conclude, I think that the concept of using phenotypes and endotypes, which will hopefully lead the way to precision medicine approach to sepsis, is still an evolving science. I think the aim is to develop a clinical classifier that will use data collectible on entry to intensive care to predict mortality in patients with septic shock. And therefore, we can then stratify patients to treatment with certain agents. The omics approaches, which is the genomics, metabolomics, proteomics, I'm confident they will give us an improved ability to identify treatment responders versus non-responders in the treatment arms. I think this also paved the way for novel drug targets and drug development, and give us a decision support tool for clinicians, something like what I've got here. What I look at, what I say is a futuristic view. Once you plug in the patient's name, the details, and the gender, you upload the clinical data and the biomarker data there, and then it comes out with a match with a certain endotype, and then it might tell you that this particular endotype has a higher incidence of critical illness weakness and prolonged hospitalization, and potentially may benefit from an immunomodulatory treatment. But if you give them corticosteroids, it might result in prolonged ventilation and a longer duration of stay in ICU. So this is obviously, it's all hypothetical, but it's something, this is the way we're all working toward, that this might help us look after patients better in the future. But thank you for your attention. And I wish the organizers all the very best.
Thank you very much, sir. So next talk is by Dr. Deepti Suri on sepsis immunology for the intensivists. Over to you, ma'am.
Dr. Deepti Suri. I'm additional professor in the Department of Pediatrics at PGI Chandigarh, and I would be talking to you about immunology of sepsis. I want to thank the organizers for giving me this opportunity to speak on a very dear topic of immunology of sepsis. So, why is it important to understand the immunology? This is because there is a renewed interest in the unique presentations of infections. There is, after this pandemic, we have started using multiple biological molecules in sepsis, and a need is felt for newer drugs for controlling the inflammatory cascades. This has resulted in identification of newer biomarkers, and research is going on to identify newer therapeutic targets. From time immemorial, sepsis was defined as a state of excessive immune activation. However, it is not true that it is only immune activation, but it is immune dysregulation, and an important component that is now recognized is immune suppression in sepsis and failure to return to normal homeostasis. At cellular level, there is acute cellular reprogramming, and a lot of reorganization occurs at the cellular and metabolic processes. The pathogenesis of sepsis is complex, and it is not simply a systemic inflammatory response or an immune disorder. It involves changes in the function of multiple organ systems in the body, and there is an imbalance between the inflammatory response. There is immune dysfunction, a lot of coagulation disorders because of endothelial injury. Then at cellular level, it affects the mitochondria, increasing the reactive oxidation species and apoptosis of the cells. There is ER stress, that is the endoplasmic reticulum stress, as well as lysosome activation resulting in autophagy. But the crux probably lies in the fact that there are cytokines like IL-1, IL-6, and TNF-alpha, which result in extreme inflammation in these patients. So what happens in the first step of immune activation, and that is the innate response. This is the response that occurs within minutes of exposure to a microbial agent. The central to innate response is the pathogen recognizing receptors, which recognize the pathogen associated molecular patterns. And these receptors result in localized inflammation and are able to eliminate the invading pathogens. However, occasionally, also in addition to PAMs, what is liberated is the endogenous tissue injury products, or called the DAMs. And this results in vicious cycle of sustained immune activation and organ dysfunction, persistent inflammation, immune suppression, and catabolism. So the PAMs and DAMs actually are recognized by the pattern recognition receptors, the toll-like receptors, the C-type lectin receptors, the RIG receptors, and the NOD receptors. Out of this, toll-like receptors are the most important, and these toll-like receptors result in translocation of the nuclear factor kappa B into the nucleus, which upregulates the genes encoding the cytokines, and a lot of cytokines are being produced. This is a cartoon depicting the TLR families, and this TLR family works through the MYD88 pathway, that is the myeloid differentiation factor 88 dependent pathway, resulting in translocation of the NF-kappa B within the nucleus and release of cytokines like IL-6, TNF-alpha, and IRF7. Out of these, most of these TLRs are membrane bound on the outside, but some of them are also within the cytoplasm. An important soluble cytoplasmic receptor is the NOD-like receptor, which works through the RIP2 pathway and again activates the NF-kappa B and results in cytokine production. An important machinery also involved in the cell process are the inflammasomes. Now, in addition to the NF-kappa B activation, these inflammasomes also stimulate the pro-caspase 1, cleave it to form active caspase, resulting in release of IL-1 beta and IL-1 Now, IL-1 is an important molecule which drives the inflammation, and at the same time, the active caspases that are formed are important for cell death or by pyroptosis, and a pore is formed within the cell membrane, resulting in cell death. So more active caspases, more is the cell death. This is the figure which indicates the TLRs as well as the caspase activation and how the anti-inflammatory response in the form of first and second signal results in inflammation. The bacterial LPS endotoxins work through TLRs, but the fungi and the viruses work through another family, that is the CLR family, which includes the dectins and the DC signs and the mannose binding lectins. Dectins are important for yeast, as well as they result in a lot of ROS production and IL-10 production. In addition to the receptors, also what happens during this part is the complement activation, and you can see in this figure that microvascular thrombosis as well as the coagulation complement pathway is quite linked towards with each other, resulting in membrane attack complex formation. Phagocytes are also recruited at the same time, which result in elimination of pathogens by releasing proteolytic enzymes. Thus, this summarizes the excessive inflammation that happens in patients with sepsis in the form of leukocyte activation, endothelial activation, as well as a lot of platelet aggregation resulting in microthrombi. There is an attempt to return back to normals from this. However, many times it is not possible, and the immune dysfunction progresses to involve the adaptive response. The neutrophils not only cause phagocytosis, but also present the antigens to the T cell, resulting in T cell activation. These T cells then are directed with the help of MHC molecules to either become the CD4 helper T cells or the cytotoxic T cells, and further enhance the cytokine production as well as cellular molecular killing. This is the mechanism in which these CD4 cells can get committed to give the Th1 response, which results in production of interferon gamma or TNF alpha, the Th2 response, which gives rise to 4 and 5, and the Th17 response, which gives rise to IL-17. Some cells also get committed to become the T regulatory cells. With this inflammatory process, most patients would improve or progress to death. And one of the reasons for death is the immune suppressed states. The immune suppression occurs both in the adaptive and the innate arm. The most important part of the adaptive response is what is called as lymphocyte depletion or exhaustion. This results in reduction in number of CD4s and CD8s, B cells, and the dendritic cells. There is increased apoptosis of T cells, B cells, and the most important molecule that is important for apoptosis is the programmed cell death 1, what is called as PD-1 molecule, which gets expressed on the CD4s, and the PD-1 ligand, which is expressed on the macrophages or the endothelial cells. So in this figure, you can see that the T cells start exhibiting what is called as PD-1, while the macrophages show the PD-1 ligand, and once the two of them combine together, this results in T cell exhaustion, a lot of dysfunction, and is the most important cause for sepsis-induced immunosuppression. Now, these two molecules, PD-1 and PD-L1, are the potential sites for therapeutics to be used for future for preventing immune suppression. Also important are the regulatory T cells, which are actually the cells which maintain self-tolerance. These Treg cells also inhibit the monocytes and neutrophil function and further contribute to the immunosuppressive states. So blocking Treg function improves immune function and increases the microbial killing in experimental models of sepsis. At the same time, there is reprogramming of the antigen-presenting cells, and there is decreased expression of HLA-DR on these cells. The neutrophils also become dysfunctional, and what we see in the peripheral smear are the bands-like neutrophils, which are actually dysfunctional neutrophils, which are unable to release the oxidative and have reduced oxidative burst capacity. So this is the summary of the immune suppression that occurs in these patients involving the CD4, CD8 cells, the neutrophils, and the antigen-presenting cells. Why is this application knowledge of immunology important? Is because we can recognize various biomarkers related to inflammation, activation, and immune balance. We can also have specific therapies targeting excessive inflammation in the form of blood purification, giving good cytokines, the mesenchymal stem cells, or even reducing the mitochondrial stress. Specific drugs used for treating sepsis, as you can see, is a lot of efforts are going on towards cytokine antagonist, using drugs against immune function inhibition, use something like GM-CSF, and of course, a lot of research on PRR antagonist. So I'd just like to conclude that immunopathogenesis of sepsis is complex and interrelated. Understanding is important as it changes occur at organ and cellular level. A lot of epigenetic factors also are being identified, and the future of medical management of sepsis and therapeutics lies in immunology. Immunology is a revolution to stay. Thank you.
So thank you very much, everyone, for kind attention. Hope you enjoy the sessions. See you tomorrow at 9 a.m. Thank you.
Thank you, everybody.
you.